Hello. Yep. Hello. May I request everyone to sit down, please? Okay. So, can we go, sir? A very good afternoon to all. This is Dr. Kamlesh Patel, heading medical services of Lupin. And on behalf of Lupin, I would like to extend a warm welcome to each one of you. As we are aware that American College of Gastroenterology is a renowned professional body which champions prevention, diagnosis and treatment to deliver a world-class credible patient care. Lupin has established a close collaboration to ensure that we come up with best clinical practices which is delivered here to ensure that there is a better patient outcome. With this endeavor, it was possible to have best of ACG season 1, which was physical one in 3 cities, best of ACG season 2, which was hybrid or phygital one, and now we are at the doorstep of best of ACG season 3. And I'm pretty sure that with these 2 seasons, most of gastroenterologists present here and who have attended must have benefited in terms of putting that learning into the practice. At the same time, eligibility for ACG fellowship. Now at season 3, we have galaxies of eminent speakers, renowned panelists, and a wonderful audience. This itself shows the unrestricted commitment from a Lupin towards bringing the most scientific latest advance to the gastro-fraternity. At the same time, it reflects the unmatched credibility of ACG as well as the course directors who are involved in conducting this. And I'm going to introduce them little while. But before that, I would like to invite Mr. Pradeep Sachdeva, Vice President of Lupin, to take a small session.
Good afternoon, everyone. Looking into the audience, it's giving me goosebumps. I have never seen so many gastroenterologists sitting under one roof. I think it has bypassed the records which has been set in Chennai and Mumbai in last 2 days. So I think kudos to each one of you. I think we are expecting more than 700 gastroenterologists from across the country. I think we have a presence from Northeast, we have presence from Kerala, we have presence from South. Everywhere we have been receiving a very, very positive feedback about this ACG. I think I would not mince my words if I do not thank our course director, Dr. Goenka, I think for bringing ACG for 3 consecutive years to India. Thank you very much, Dr. Goenka. Uh, I think we had two wonderful sessions in the last 2 days. First session in Chennai, and the second session which happened in Mumbai, uh, were attended by most of the gastroenterologists. And I think the feedback which we have been getting is been amazed. I'm sure the carry home messages which you people would be taking would immensely help the Indian population. And today, this event is also getting relayed to 7 live locations across the length and the breadth of the country, where some of the gastroenterologists could not make it to this physical program. Before I hand over to Dr. Goenka, I would just like to tell you more about Lupin. What is Lupin all about and how we are progressing? Amitabh, corporate present. I also like to, I know there were some hiccups at the start when the registrations were happening. Like to apologize on behalf of Lupin. Such a massive crowd, they hotel people also have not seen. They do not have that experience of handling so many guests in one go. But thanks for a lot for your patience, which you have shown. And some of the guests are still waiting for the registration to happen. Maybe. Yeah. Aditi, we can do it afterwards also, agar if there's. Huh. So, I would request Dr. Goenka, Dr. Guda to please come for the lamp lighting and invite all the faculty and the chairpersons. Ah, sure.
Wow, it's really a great feeling to see all of you here this afternoon. Thank you, Dr. Kamlesh and Mr. Sachdeva. On behalf of my course co-director, Dr. Nalini Guda from USA, I welcome all of you for this third meeting of season 3 of Best of ACG in India. By your support, I have been interacting with ACG. I became a fellow almost 30 years back. And now for the last 5 years, I'm representing the country as a governor in the ACG. So in the last 5 years, we have tried to engage Indian gastroenterologists with American College of Gastroenterology on multiple platforms. The American College of Gastroenterology has been supporting and sponsoring at least 2 international faculty for our annual meeting, ISGCon. During the COVID time, we had mutual interaction between the leadership of Indian gastroenterology community and American College of Gastroenterology during those difficult times to sort out some of the issues. We have recently started joint webinars between Indian Society of Gastroenterology and American College of Gastroenterology, and we had 2 such in the last few months. The last one being as late as last week on endotherapy of chronic pancreatitis, where Dr. Nageshwar Reddy delivered a talk on the subject. Very important, we made more than 1,000 gastroenterologists from India members of American College of Gastroenterology, and that's a big chunk. I think other than America, this is the most represented country in the American College of Gastroenterology. And a significant number of them became a fellow, and I'm sure some of you would become a fellow in short time. Most important and most exciting has been this Best of ACG, which did not exist earlier. We have started, as was mentioned just now, 3 years back. During the COVID time, we had to change the protocol, but now we are back with the physical meeting. We already had successful meeting in Chennai the day before and Mumbai yesterday, and today we are Delhi. As Mr. Sachdeva said, Delhi has outscored the gathering at Chennai and Mumbai. And we have this additional live telecast to at least 7 cities. I'm very happy to announce that American College of Gastroenterology has agreed, as in the last year, to allow these meetings to be considered as one of the criteria for fulfillment of criteria for the fellowship advancement of ACG. So please see to it that your attendance is registered. I take this opportunity to welcome and felicitate our ACG faculty. As you will notice during the deliberation, these are real international experts who will be talking on their respective area of interest. So let me first welcome Dr. Sameer Shah, who has been the president of American College of Gastroenterology earlier this year and is from Brown University, who will be talking on the subject of inflammatory bowel disease. Dr. Sameer Shah. We have Dr. David Johnson, who is from Eastern VA School of Medicine, and we all heard him deliberating excellent topics on esophagus and beyond, and he will be talking on the same subject today as well. We have Dr. Vanessa Shami from University of Virginia. As I mentioned yesterday, this is her first visit to India, and I am hopeful that she is enjoying her visit here. She'll be talking to us on endoscopy. We have Dr. Nancy Ryu from Rush University, Chicago. She had come to India last year also, and on popular demand, we wanted her to come back to India. And here she is. She will be delivering the subject of hepatology. And last but not the least, I have my friend, Dr. Nalini Guda from Wisconsin, who is also the governor of that region, who is going to talk about pancreaticobiliary disorders. He has been instrumental in framing the program along with the others who are involved. I cannot thank enough Lupin for making this happen. The amount of passion, commitment, which we have seen in the last 3 years and also in the last 2 months from each and every member, including the leadership and the ground level people, to make this program be successful with unlimited educational grant and great logistics support. Thank you, Lupin, for making this happen. With that, I would request Dr. Nalini Guda to take this program further.
Mahesh, last 2 days you've been sending us home with bouquets of flowers, so today it's your turn to take it. So,
Thank you so much.
Good afternoon, everyone. Thank you for joining us here today. It's a little overwhelming to see a hall full of people on a weekend giving up your family time to be here with us. As Mahesh said, this is day 3, so I think it's great to see so many of our friends and colleagues back in person after the COVID pandemic. I think we've learned how to live with it. So it is my pleasure and honor to introduce our chief guest for today, Dr. J.B. Dilawri, who probably needs no introduction. He's the master of masters, teacher of teachers. There are several of you who are here in the audience who were trained by him, and I got to know of him personally in the last couple of years when I've had a chance to meet with him. Dr. Dilawri has worked earlier at PGI Chandigarh, where he has trained a lot of people, including Dr. Goenka, Dr. Reddy, all the known endoscopists. He also served as a senior consultant at Royal Hospital in Green Cork, United Kingdom, and also at the Glasgow University, Scotland. It's also my pleasure to invite Dr. Subratacharya, who is Professor Emeritus at All India Institute of Medical Sciences, New Delhi, who is currently a Pro-Chancellor of KIMS Bhubaneswar. Thank you both for coming and gracing us at this occasion. And if I could invite you both to come and lamp the light as we normally do, and it's customary to start the program. While they're doing that, I would request our speakers, Dr. Samir Shah, Vanessa Shami, David Johnson, and Nancy Rowe, to join them at the lamp lighting ceremony. So I would like Dr. Subrata Acharya and Dr. Dilauri Acharya comes first in the alphabetical order to come and impart some words of wisdom and inaugurate the program. And then we'll get back to the Lupin presentation before Dr. Shah gets on and starts the first thought.
Good afternoon, friends. At the outset, I must congratulate Dr. Mahesh Goenka and Dr. Nalin Gudda for continuously, with great enthusiasm, with great spirit, which I will say unending spirit, to bring in best of SEG and progress every year with progressive advancement and transmitting to all of us, which obviously indirectly benefit. Today, I don't want to take your time because you have got the introduction already. I will say it's a very pleasure and honor to be here, particularly when Professor Jung Dilavari is the chief guest. Many of the young people doesn't know Professor Jung Dilavari. I will tell the first word. He is the first man to start ERCP in your country. And also, as introduced earlier, is teachers of teachers. You had heard about Professor Nageswar Reddy. You have heard Professor Dr. Mahesh Goenka. You have heard about Dr. Patrick Kamath. You have heard about Dr. Santiswarup Bege. All these international luminaries in their formative years were guided by him. When they were in troubled waters, he held his hand and made him what they are today. Therefore, friends, I don't want to say anything. It's an honor and privilege to ask Professor Dilavari to start the ball rolling. Sir, will you come?
Thank you, Subrat. Subrat and myself known each other for almost 40 years, also when he was in Orissa, and we then convinced Badri Tandon to bring him to All India Medical Institute. And there he has really risen very high, and now he is the Vice Chancellor in Kalinga University. Thank you, Subrat. I want to thank Mahesh Goenka and Nalini Gouda for inviting me to be the chief guest today. It's an indeed honor for me. And to see so many people attending this meeting, there must be something in this meeting. And I think the best thing in this meeting is a hardcore, practical gastroenterology, which you don't find in any other meeting in the whole world. AGA goes behind the practical core gastroenterology. ACG is far ahead of that. And credit goes to Mahesh Goenka to organize such a fantastic meeting here and also in other 2 centers in India as well. Mahesh Goenka has been a very dynamic leader. He was when he was a student in PGI, and also when now he's the president of the Indian Society of Gastroenterology, or past president. He has encouraged so many people to become members of the Indian Society of Gastroenterology, and now he's helping the ACG to have a lot of membership from here as well. The program is so good that in one day you have the liver, you have pancreas, you have luminal gastroenterology all together. And we have 5 experts, gastroenterologists from America, to tell us about the best in these fields. And also, we have the best gastroenterologists from India to relate, to have a interaction with this top gastroenterologists from America. So it's going to be give and take. It's going to be win and win situation both sides. The American gastroenterologist will learn from the Indian gastroenterologist, and the Indian gastroenterologist will learn from the American gastroenterologist. So I think it's a unique meeting, and I welcome you all again, and thank you for inviting me. Thank you.
Thank you both, Dr. Acharya and Dr. Dilavari, for gracing this meeting and inaugurating it. We've had some technical difficulty initially, so I think we're ready to roll with the Lupin presentation before I invite Dr. Shah.
Sorry for coming again and in between the presentations for which you all have assembled. As I said earlier also, I think Lupin has always been committed to giving best of the education and bringing the best of the education to India. And Lupin is built to grow. So I'll just take you with some of the slides that how Lupin is in the world and in India. We are the 10th largest generic company and among the 5th largest Indian pharma company by global sales. We have 15 manufacturing sites and with 7 R&D sites where we are contributing close to 10% of our annual turnover to the R&D. We are 3rd in US by prescriptions and we are the 6th Indian pharma in Indian market and by far 4th in the largest South Africa generics market. So we have a presence in almost all the therapies. We are very, very strong in cardiovascular, diabetology, CNS, anti-infectives and cephalosporins, and we are becoming stronger in the GI therapy with all the support which is being given by all the doctors sitting over here and across the length and the breadth of the country. Whenever we are launching any new product, it is becoming the #1 in terms of all the new launches in the last 5 years. And today, we are among the top 5 companies. Whenever a gastroenterologist writes, it writes a Lupin product in every 5th prescription. We are a dominant force in the Indian pharma market. We have a sales of around 6,800 crores with the rank of 6th and with a market share of 3.5 and a CAGR of 13.53%, which is outpacing the Indian pharma market. So we are present, like we have said, all the therapies. We have presence in over 23 therapies, cardiovascular, diabetes, respiratory, get GI, and you name it, and we are present in that therapy. We have a large presence of field force which is catering to Indian doctors across the length and the breadth of the country, and I am sure their relationship with you has helped us to bring so many gastroenterologists in this city of Delhi. So we have expanding also in this year. We are adding more than 1100 representatives. So to meet our customers there and to bring them the medical information. So in gastroenterology, earlier we were having two divisions which were catering to the GI therapies. Now this year we are expanding in GI also by launching our third division, Ariser. So we have three divisions, Ascender, Endeavor and Ariser coming and meeting you and interacting you for your prescription support. So I think in almost all the therapies of GI, we are present. We have a large brands in the PPIs like Rablet, we have in IBS, we have Arcifex, Utka, we have Ulysis. And I would really thank each one of you for making these brands as successful brands in their respective therapies. Lupin has been recognized as one of the big Indian company, and that is the reason that most of the pharma companies like to associate and bring their products in India through Lupin. We have a tie-up with many of the multinationals like Eli Lilly, we have Novartis, Boehringer, Vifor, and Fidia, and there are so many other companies which they do not have a presence, but when they are looking out for a presence in India, they choose Lupin as one of the preferred partner. We have been awarded a lot of awards and accolades in the last few years. Our CEO, Vinita Gupta, has been awarded as the most powerful business woman in India. We are won a lot of awards in pharma field, green tech, CSR. We have, our CSR program has been awarded as one of the best programs by the government of India. We have received 5 India Star Awards for excellence in packaging by India Institute of Packaging. So with this, I'd like to thank each one of you, and I'm sure you will enjoy this next 5 sessions by ACG. Very, very informative and very, very interesting. Thank you very much. And Dr. Gouda, to you.
All right, before I invite the next speaker, I would like to invite the moderator for the session, Dr. Vinita Ahuja, Professor of Gastroenterology at All India Institute of Medical Sciences, New Delhi. We have some eminent panelists, Dr. Ajit Sood, who's from Ludhiana, Professor of Gastroenterology, Dr. Govind Makharia, again from All India Institute of Medical Sciences, Dr. Rakesh Kochar from Chandigarh, and Dr. Sandeep Nijavan, the current president of the Indian Society of Gastroenterology. Now it's my honor and privilege to introduce Dr. Samir Shah, who is the immediate past president of the American College of Gastroenterology, professor of medicine at Brown University, to give us an update on the inflammatory bowel disease, what is new.
Okay, perfect. Thank you. Well, let me start by thanking all of you for being here, all the people who are there remotely. Of course, Dr. Goenka and Dr. Gouda for inviting me. I have a strong connection to India. I was born in Ahmedabad and grew up in America, but I actually came back to India my 4th year of medical school. I was at Harvard, but my professor, Dr. Sanjeev Chopra, helped me do a rotation at Ames. So in 1992, I was at Ames and very impressed with the professors. I worked with Dr. M.P. Sharma and Dr. R.K. Tandon, and so it's a thrill for me to be here. I also want to thank the people at Lupin. They've done a remarkable job. I want to mention Aditi, Nidhi, and Payal, who made my and all the other faculty's stay such a pleasure. So with that, let me jump right into inflammatory bowel disease. We're going to go through IBD therapies first, and then we'll talk about IBD complications, medication safety, and then sort of an IBD potpourri. Now, there were a lot of abstracts that were presented orally and great posters that were winning, so I tried to put a lot into this, so I'll get through that in the next 35 minutes. So before I launch into the therapies, it's important to understand the IL-12 and IL-23 families. So interleukin 12 and 23 are involved in immune regulation, particularly interleukin 23, and you're familiar with ustekinumab. So ustekinumab blocks interleukin 12 and interleukin 23. Both those cytokines share a protein called the P40 unit, so if you block P40, you're going to block interleukin 12 and interleukin 23. Probably interleukin 23 is the more important molecule. So what happens if you just block interleukin 23? You can do that by targeting the P19 subunit of the IL-23 protein. And we have several molecules that do that. One, risankizumab, is already approved for use in Crohn's disease in the United States, and there are several others in development. So this will be an important therapy going forward for inflammatory bowel disease, and it's already out there for psoriasis. So the first three abstracts I'll talk about, abstracts 37, 38, and 39 that were presented at our annual meeting at the President's plenary session, looked at risankizumab in Crohn's disease. The first looked at patient-related outcomes. The second looked at patients who didn't respond to the first 12 weeks, what happens if you keep them on therapy. And the third looked at whether being on previous biologics, whether it was 1, 2, or 3 or more biologics, affected the response to risankizumab. So abdominal pain and increased stool frequency are symptoms of Crohn's disease, and although we care about mucosal healing and decreasing inflammation, for patients, improvement in these symptoms is an important therapy goal. Risankizumab has already been approved in the United States for Crohn's disease, including not only improvement of symptoms, but also mucosal healing. In this study, they looked at the patient-reported outcomes, specifically abdominal pain score, or APS, and stool frequency, and their correlation with endoscopic outcomes during induction and maintenance of treatment. So they utilized 3 different studies, 2 induction studies, ADVANCE, which included patients who were bio-naive to biologics, and patients who were bio-experienced, and MOTIVATE, which only included bio-experienced patients. Patients who responded in either of those trials went on to the FORTIFY trial, which was a maintenance trial, and followed for 52 weeks. So you can see both in the induction and I'll show you in a minute in the maintenance, that there was a reduction in abdominal pain and stool frequency with the treatment compared to placebo. And then at the end of a year, there was significant improvement at either dose of the drug, the 180 dose or the 360 dose, compared to placebo. In terms of correlation, there was not good correlation in the induction phase between reduction in those patient-related outcomes and endoscopic outcomes, but there was moderate relationship at the end of the study at week 52. So then moving on, the next study looked at what happened to patients if they didn't respond in the first 12 weeks but went on to maintenance therapy. So they were followed for an additional 12 weeks on maintenance therapy and then went on to the end of 52 weeks. So you can see, both in terms of clinical response and clinical remission, patients who did not respond at 12 weeks had a response by the end of 52 weeks. And there was also endoscopic improvement in both doses of the maintenance dosing. The third abstract looked at the efficacy and safety based on the number of prior biologics that had been failed, with the understanding that previous studies with most biologics have shown the more biologics failed, the more refractory the patients were, and the less likely they were to respond. So again, the patients were given induction therapy followed by maintenance, and then the co-primary endpoints was clinical remission and endoscopic response at the end of a year. And you can see the baseline demographics and disease characteristics, and they had a number of patients who had failed 1 biologic, 2 biologic, and finally 3 or more biologics. Now this is a complicated slide. Let me take you through it. In the first panel, you have induction at week 12, and that's placebo in gray, and then the drug in green. And then in the maintenance, you have placebo also in gray, and then the 2 different doses in pink and orange. Now, if you look across in columns, the first column has failed 1 biologic, the second has failed 2, and the third has failed 3. And looking across the rows, you have clinical remission based on CDAI, the patient-reported outcomes in the second row of stool frequency and abdominal pain score, and the last row is endoscopic remission. And you can see that the drug was better than placebo in all those different phases. The other thing I'll point out is the patients who had failed 2 or more biologics had a lower placebo response rate, not surprisingly, compared to the patients who had failed just 1 biologic. If you look at the patients who had failed ustekinumab, did they respond to risankizumab? The answer is yes, both in terms of induction and in terms of maintenance. So the conclusions from these 3 presentations was that Crohn's-related symptoms, abdominal pain score and stool frequency, improved with risankizumab induction therapy and maintenance, that symptom improvements in endoscopic outcomes were weakly correlated after induction and moderately correlated during maintenance. And this just underlies the importance of objective measurement in Crohn's disease, which you all know. The proportion of patients achieving clinical, endoscopic, and composite endpoint at week 52 followed extended induction were similar to those who responded at week 12. So the take-home message is if they're not responding at the end of 12 weeks, don't give up on the therapy, give it another 12 weeks, and go on to maintenance. Risankizumab was effective and well-tolerated in patients with Crohn's disease, irrespective of the number of biologics they had failed previously. And importantly, the safety was similar across all the subgroups, both during induction and maintenance. So switching now to a different molecule, guselkumab, which is also an IL-23 inhibitor. This was studied in this induction study in patients with active ulcerative colitis. The patients were well matched in terms of demographics and disease severity, and at week 12, clinical response was monitored. And in either the 200 milligram IV dose or the 400 milligram IV dose, the response was over 60% compared to only 27% for placebo. The patients that were not responding at week 12 when they were continued for an additional 12 weeks, by week 24, there was an additional 50% response rate. So in ulcerative colitis, similar to Crohn's disease, don't give up on this other IL-23 therapy if there's not a response at 12 weeks. And finally, if you look at cumulative response at either week 12 or 24, it was nearing 80% at the various doses. Patients who initially got placebo then got open-label guselkumab and had a clinical response similar to the patients who originally got guselkumab. The next study looked at whether a prior inadequate response or intolerance to advanced therapy. By advanced therapy, they indicated either biologics or small molecule inhibitors. And again, the dosing scheme was either placebo, 200 milligrams IV, or 400 milligrams IV. So patients who were naive to advanced therapy had a pretty dramatic response where they looked at clinical response, endoscopic improvement, or histologic endoscopic mucosal improvement. Not surprisingly, the patients who had had a history of inadequate response or intolerance to previous advanced therapy had a lower response rate, but their placebo rates were also lower. Next, I'm going to switch to a very interesting study called the VEGA study, and this was a phase 2A double-blinded randomized controlled trial, and they looked at the combination of biologics in patients with ulcerative colitis. So patients were randomized to one of 3 arms, either golimumab, which is an anti-TNF agent, guselkumab, which is an IL-23 inhibitor, or a combination therapy with both golimumab and guselkumab for the first 12 weeks, and then monotherapy with guselkumab ongoing for the next 24 weeks. So you can see in terms of remission, the combination therapy, both at week 12 and at the end of the study, week 28, was superior to either monotherapy alone. And endoscopic improvement, again, was better in the combination therapy group compared to the monotherapy group. In terms of both histologic remission and endoscopic improvement, again, combination therapy was superior to monotherapy with either agent alone. So patients treated with the combination induction therapy with guselkumab plus golimumab followed by guselkumab monotherapy achieved higher rates of the following endpoints at week 38 compared to monotherapy with either. So clinical remission, endoscopic and improvement and normalization, and the composite endpoint of histologic and endoscopic improvement. Importantly, there was no difference in adverse event rates among the various treatment groups. And so this combination therapy represents a new paradigm for further investigation. And this is particularly important for our patients with very severe inflammatory bowel disease. So switching gears, I want to introduce you to the JAK-STAT signaling cascade, and you're familiar with this, but let me review. There are four JAK proteins, JAK1, JAK2, JAK3, and TYK2, and cytokines signal through the JAK-STAT pathway. When the JAK kinases are activated, they signal through the STAT protein to result in transcription of further cytokines in a pro-inflammatory cascade. So tofacitinib is a pan-JAK inhibitor, so it inhibits JAK1, 2, 3, and TYK2, whereas upadacitinib and filgotinib are selective JAK1 inhibitors. I'll refer to upadacitinib in the future as UPA just for brevity. So this is a very interesting study looking at UPA in patients with moderate to severe colitis who had received extended 16 weeks of therapy followed by 52 weeks maintenance therapy. So initially, patients were given induction therapy with 8 weeks of UPA at 45 milligrams. If they had a response, they were re-randomized to either placebo, UPA 15 milligrams for maintenance, or UPA 30 for maintenance. If they didn't have a response, they could go on 8-week additional induction with open label at UPA 45. So of the 664 patients who got UPA 45, 125 did not achieve a clinical response and received 8 further weeks of induction treatment at that same dose of 45. Of the 125 patients, 73 or 58.4% subsequently achieved a clinical response by week 16 and were re-randomized to either UPA 15 or UPA 30. And you can see the breakdown in the demographics between the two groups during the maintenance phase. Not surprisingly, the higher dose, the 30 milligram dose, was superior to the 15 milligram dose in maintenance for the patients who required 16 weeks to achieve response. So conclusions from this study said that 16 weeks extended induction treatment led to achievement of clinical response in 58.4% of patients who didn't respond to the initial 8 weeks, that the 30 milligram dose was better than the 15 milligram dose across all clinical, endoscopic, and histologic endpoints, and finally that UPA maintenance therapy demonstrated an adequate safety profile with no new safety signals seen at either maintenance dose. The next abstract I want to discuss is looking at UPA in induction therapy for patients with moderate to severe Crohn's disease. And this is the 3U Excel study. They had over 500 patients with moderate to severe Crohn's disease, both from the United States and Europe, and they're randomized in a 2-to-1 fashion with either UPA 45 or placebo, and then the endpoint was at 12 weeks. They had elevated fecal calprotectin, and nearly half had failed biologics, including some that had failed multiple biologics. Most had failed at least one anti-TNF agent. So you can see the breakdown of 176 who got placebo and 350 that got UPA. Co-primary endpoints was clinical remission and endoscopic response, but secondary endpoints included clinical remission, corticosteroid-free remission, and endoscopic remission, all at week 12. And in terms of clinical remission, patient-reported outcomes, endoscopic response, not surprisingly, UPA 45 was superior to placebo. The response was very rapid, seen often in 2 weeks, and by week 12, there's already a signal in terms of steroid sparing and endoscopic healing and improvement. Importantly, no safety signals were seen, and we're hoping this drug becomes FDA approved in the United States for Crohn's disease, as it already is for ulcerative colitis, later this year. Next, this is a very nice study, and the senior author is here, so he can talk about it in our discussion. But this study from India looked at the role of tofacitinib as an adjunct to intravenous steroids in the management of acute severe ulcerative colitis. And although this was an interim analysis, I'm told that the full analysis is now available. This was a single center study of 82 patients with acute severe ulcerative colitis as measured by the Trulev-Witch criteria. They're randomized 1-to-1 to receive either hydrocortisone alone or hydrocortisone plus tofacitinib. And the dosing of the tofacitinib was initially 10 TID for the first 7 days and then 10 BID for 7 more weeks. At day 8, everyone was transitioned to prednisone orally and then tapered by 5 milligrams per week. The primary outcome was steroid responsiveness, and the secondary outcome was colectomy-free survival at week 8. Patients who didn't satisfy Oxford criteria were then offered rescue infliximab, cyclosporin, or colectomy as rescue therapy. And you can see the groups were fairly well matched, with the group T getting the tofacitinib and group S only getting steroids. And you can see that the patients who got tofacitinib had a higher steroid responsiveness compared to the ones who only got steroids. And this is shown in figure 1, and this was statistically significant. Although there was a numerical benefit in terms of colectomy-free survival, at least at this interim analysis, there was not a benefit in terms of colectomy, and therefore larger trials are needed. But I'm told by Dr. Sood that in their final analysis, there was a reduction in colectomy, so we'll talk about that more at the end. So the last therapy I wanted to bring up is S1P1 inhibition. So the S1P1 receptor system helps traffic lymphocytes to lymph nodes. So if you block S1P1, then lymphocytes get trapped in the lymph node. So ozanimod will result in the T lymphocytes being stuck in the lymph nodes and not circulating and decrease inflammation that way. This particular study looked at what happens to patients when you withdraw therapy when they're already responding. So this is results from the phase 3 True North study. Patients who got ozanimod and responded were then randomized to either placebo or continuing on ozanimod at standard dosing, and they looked at time to relapse. And you can see in the responders, by 8 weeks, there was separation between placebo maintenance versus staying on the drug. When they looked more carefully at patients that achieved either clinical remission or response by week 10, then it took longer for them to relapse, typically at week 12, compared to staying on the medicine. So they concluded that ozanimod was significantly more effective at preventing relapse over a 1-year period with continuous treatment compared to placebo, patients who were switched to placebo during the maintenance period. Randomization to placebo, i.e. ozanimod withdrawal, was associated with increased rates of relapse after week 8 and after week 12 if they had achieved response or remission by week 10. And these data show that the ozanimod can maintain disease control for several weeks even in the event of temporary discontinuation. But if you keep them off for more than 8 weeks, they're more likely to relapse. So the next study I wanted to look at was the study from Brigham and Women's Hospital and Mass General Hospital in Boston. And a common problem we see is what happens to patients if they have ulcerative colitis and they fail an anti-TNF agent. What should be the second agent we use? There's no head-to-head trial comparing this, and meta-analysis suggests that either tofacitinib or ustekinumab could be reasonable options to use. The same group had presented their data in the first 12 weeks, and they extended this to 52 weeks. So looking at these patients, 97 got ustekinumab and 69 got tofacitinib. They were well matched, except more patients with Mayo 2 and higher scores were seen in the tofacitinib group, and the tofacitinib group had a higher baseline CRP level. When we look at overall response or result outcomes, you can see that they're well matched, except for steroid-free clinical remission at week 12, where tofacitinib seemed to do better than ustekinumab. But when plotted out, it seemed very similar in terms of response rates, and both response rates over a year were over 45%. So the summary from this study, and again, this wasn't a randomized controlled trial, but a retrospective observational study, compared to ustekinumab, tofacitinib-treated patients had a higher baseline CRP and more commonly had Mayo endoscopic score that was greater or equal to 2. Both were effective in achieving steroid-free clinical remission at week 52, greater than 45% in both groups. After adjusting for confounding, there was no significant differences in steroid-free clinical remission at either week 12 or 52, or drug survival between the two strategies. And adverse events leading to treatment discontinuation were similar and rare in both groups. So again, limitations that this was retrospective, there was some incomplete data and variable follow-up time, and relatively small numbers. But the take-home message from this study is that if you have a patient failing anti-TNF, you can choose either tofacitinib or ustekinumab and expect similar response rates. So the summary of our therapies, risankizumab improves patient-reported outcomes in terms of abdominal pain scores and stool frequency. And there's additional treatment response. If they don't respond at 12 weeks, don't give up, keep going. And it's effective regardless of the number of biologics failed in patients with Crohn's disease. Gazilkamab, another IL-23 inhibitor, works in UC even if previous failure of advanced therapy. Vega was a very interesting study combining two different mechanisms, an anti-TNF mechanism plus an anti-IL-23 mechanism, and the combination therapy in ulcerative colitis is better than either alone with no safety signals. And this may be a paradigm in the future for our patients with really severe inflammatory bowel disease. Upadacitinib the JAK1 selective inhibitor at 45 milligram dose, when you extend the treatment to 16 weeks, you saw a pretty dramatic response. 58.4% of the patients who didn't respond at week 8 responded by week 16, and there are no new safety signals. If you required 16 weeks to get to a response, then the higher dose at maintenance was better, the 30 milligram dose compared to the 15 milligram dose. UPA 45 was safe and effective in moderate to severe Crohn's disease. Many of the patients were refractory to other therapies, and the response was seen fairly quickly, as soon as 2 weeks, and steroid sparing and mucosal healing was demonstrated by week 12. Tofacitinib improved steroid response in acute severe ulcerative colitis when added to intravenous steroids. There is no colectomy difference when this was reported, but we'll see that there probably is. Small numbers, this will need to be extended. And finally, ozanimod discontinuation, you see relapse as early as 8 weeks and 12 weeks in patients who had had a remission or response. Tofacitinib and ustekinumab are equally effective in ulcerative colitis patients after anti-TNF failure, and again, retrospective study from Brigham and Women's Hospital and Mass General in Boston. So let's talk about IBD complications and medication safety. So this is data from the PIANO registry that Dr. Uma Mahadevan leads up. I'm proud that my group is one of the centers participating in PIANO. And the PIANO study demonstrated that with biologic therapy and with thiopurines, we don't see any increase in important outcomes that our patients and we are concerned about in terms of congenital malformations, et cetera. And so there's not any negative impact of being on those drugs. So the problem with the PIANO registry of data published so far is there are very small numbers of patients with vedolizumab or ustekinumab, so maybe we're not have enough patients to see any signals. So we know that vedolizumab can affect MADCAM, and that's been identified in human placental vessels and may play a role in placental development. Ustekinumab, which blocks both IL-12 and IL-23, can affect uterine angiogenesis and human residual immune cells. And both decreased levels and increased levels have been associated with spontaneous abortion. So again, the PIANO registry looks at these important outcomes, including spontaneous abortions, preterm birth, small for gestational age, low birth weight, intrauterine growth retardation, C-section, and NICU requirement birth. They also looked at placental disorders, congenital malformations, and infections, which were broken down to serious infections that required hospitalizations and any infections. And the methodology was questionnaires were administered at study intake throughout the pregnancy and then after delivery. And the exposure cohort looked at were vedolizumab alone, ustekinumab alone, anti-TNFs alone, or combination therapy where there was either a thiopurine, one of the thiopurines, azathioprine or 6-MP, plus a biologic. And the control were IBD patients with no exposures to medicines that were listed on the other side. And they had 43 patients on ustekinumab and 62 on vedolizumab in this abstract that was presented. And they saw, fortunately, no bad outcomes in terms of pregnancy outcomes or infant outcomes with either drug. There was no increased risk in infections at 1 year in the babies who were exposed to these drugs. So there's no increase in pregnancy and infant-related complications with ustekinumab or vedolizumab, compared with no exposure, TNF exposure, thiopurine exposure, or combination with a biologic and a thiopurine. Interestingly, ustekinumab was actually associated with lower rates of preterm birth and C-section, and there was no signal found for increased placental events with either therapy. So therefore, continuation of ustekinumab and vedolizumab during pregnancy is recommended. This is another study from a different group. This is the Otis pregnancy study update, and looked at patients who got vedolizumab. So you have 98 patients who got vedolizumab during pregnancy. There's disease control, which is the middle column. These are patients with inflammatory bowel disease that didn't get any therapy. And then you have healthy control as patients without inflammatory bowel disease. And you can see the outcomes are very similar. In the panel to the right then, you see the patients with Crohn's disease were exposed only in the first trimester, only in the second trimester, and the vast majority in all 3 trimesters. In the middle panel, patients with ulcerative colitis, again, first trimester, second trimester, and third trimester. And then both groups combined, you can see most of the patients were exposed in all 3 trimesters. And again, the bottom line is vedolizumab is safe in pregnancy, no safety signals seen. And if the patient is on it, it should be continued during pregnancy to maintain remission during pregnancy to ensure good outcome. So I'm going to switch gears, and this is, I think, a very, very important safety study. This is looking at the risk of tofacitinib-related adverse events in patients with ulcerative colitis. This is a propensity match control cohort study, and Dr. Kochar from Allegheny System in Pittsburgh was the lead author. So this was done because there was a trial, a phase 4 trial in patients with rheumatoid arthritis who were on methotrexate and either on tofacitinib or an anti-TNF. So these were RA patients greater than age 50 on methotrexate who had at least one cardiovascular risk factor. And they had an increased risk of major adverse cardiovascular events or MACE or malignancy, specifically lung cancer, if they received tofacitinib compared to anti-TNF. So that led the FDA to put a warning label on tofacitinib, so we can't use tofacitinib in the United States in IBD patients unless they've failed an anti-TNF. So their methodology was to use a big multi-institutional database called TriNetX, which included more than 70 million patients from 49 health organizations across the United States. They looked at the 1, 2, and 3-year risk of MACE, malignancy, opportunistic infections, and venous thromboembolism, or VTE, in patients with UC on tofacitinib compared to other biologic agents. The other biologic agents formed the control group. So when they looked at that, they had 94,000 patients with ulcerative colitis. Of those, over 1,000 received tofacitinib. Mean age was 47, and about half, just over half, were male. Over 4,000 received an anti-TNF agent, and over 2,400 received vedolizumab. Over 1,300 received ustekinumab. Importantly, they saw no difference at 1, 2, or 3-year risk of MACE, malignancy, opportunistic infections, and VTE in the patients on tofacitinib compared to the other biologic agents. And in subgroup analysis, again, there's no difference at any of the time points of MACE, malignancy, VTE between the patients on tofacitinib compared individually to anti-TNF inhibition, vedolizumab, and ustekinumab. They did see an increased risk of opportunistic infections in patients on tofacitinib compared to the other agents, and this was mostly comprised of shingles, and this can be prevented with the vaccination using Shingrix. So next, I wanted to look at an interesting study from the military health system that looked at the use of biologics in ulcerative colitis. So they identified 371 ulcerative colitis patients through the military's Universal Electronic Health Record from 2013 to 2020. And they divided patients who got biologics to whether they got biologics within 2 years of their diagnosis or after 2 years of diagnosis. Then they looked at the clinical course, biochemical, radiologic, endoscopic, and histological findings. And they looked at specific complications, including UC-related emergency room visits, steroid use, hospitalizations, and surgeries. And you can see the patients in blue who got exposed to biologic agents within the first 2 years of diagnosis did better with lower rates of complications compared to those who were started after 2 years of diagnosis. They saw basically a 26% reduction in complications with earlier use of biologics in ulcerative colitis, similar to what's been reported with other studies with Crohn's disease. So the summary of our safety and complications: vedolizumab and ustekinumab are safe in pregnancy based on the Piano registry and should be continued. Vedolizumab is safe in pregnancy according to the OTIS study, so good collaboration or corroboration. Tofacitinib is safe in UC with no signals of MACE, VTE, or malignancy seen in this large propensity analysis, but there were higher rates of opportunistic infections. And remember, shingles is preventable with vaccination, and that vaccine is safe and available. A retrospective cohort of 371 UC patients showed that early use of biologics was associated with reduced complications by 26%. So finally, I'll end with a sort of IBD potpourri. We'll talk about bile acid malabsorption in IBD and microscopic colitis, the importance of multidisciplinary care in IBD and specifically a GI pathologist. We'll talk about MRE and fibrosis versus inflammation using artificial intelligence to score rather than just a radiologist. Capsule endoscopy after a negative MRE or CTE, and then finally intestinal ultrasound. So bile acid malabsorption is common in adults with Crohn's disease, and this study was led by one of my former fellows, Dr. C., who's now at University of Pennsylvania. And she looked at, with her colleagues, 181 Crohn's patients who were in endoscopic remission, And they looked for bile acid malabsorption with an assay looking for increased levels of bile acids in the stool. Despite having Crohn's disease with mucosal healing, a third of the patients had diarrhea. And when they tested for bile acid malabsorption, 28% showed that, conferring an increased risk of diarrhea. The next study is from University of Pittsburgh Medical Center, UPMC, and the lead author, or the senior author, is Dr. David Binion. And their group looked at patients with ulcerative colitis who had undergone ileoanal pouch surgery. So these were patients with ileoanal pouches that were identified between 2009 and 2022. They had 132 patients with over 2 years of follow-up. Of those 132 patients, 93 were treated with bile acid sequestrants, and 2/3, or 63, stayed on it for greater than 2 years. 30 discontinued within a year due to intolerance or lack of response. In the patients who had stayed on therapy, there was a mean reduction in bowel movements from 9 to 6, also decreased pain, emergency room visits, and hospitalizations, and this was statistically significant. The final study looking at, sorry, I'm not sure what happened to this was a study from the Mayo Clinic with Daryl Pardee as the senior author. And they identified 282 patients with microscopic colitis with use of bile acid sequestrants. And the bottom line was it benefited them regardless of whether they were on concomitant therapies, whether it was budesonide, Pepto-Bismol, or antidiarrheals. And they couldn't predict who was going to respond to bile acid sequestrant therapy. And they used 3 different bile acid sequestrants, including cholestyramine and pill forms of the disease. So the bottom line is you should consider bile acid therapy. So this was, I thought, a very interesting study, and we utilize a multidisciplinary conference at my center where we have radiologists, surgeons, pathologists, and GI get together to discuss cases. So this was in the Carlin Clinic in the United States, and they had 283 patients that were discussed semi-monthly. And when they looked retrospectively between June 2013 and December 2019, they found that they changed the diagnosis in a number of patients from ulcerative colitis to Crohn's disease or vice versa, and that change in diagnosis led to a change in disease management surgery. So this is really important. If you're taking care of IBD patients, make sure you start a multidisciplinary conference to help make sure patients get the best care possible. So this was an interesting study from the Cleveland Clinic, and they looked at MRE. So MRE has been used to figure out if somebody has a stricture, and not only whether they have a stricture, whether the stricture is more inflammatory or whether it's stricturing or fibrotic. If it's fibrotic, medical therapy is not likely to help and they'd be heading for surgery. If it's more inflammatory, then medical therapy has a role in treatment. And they used machine reader evaluation for severe inflammation and fibrosis using 3D quantitative radiomic features. So basically they were using artificial intelligence to see if they could better score compared to a radiologist's visual analog scale. And they had 51 patients. They used 34 for the discovery phase and then 17 for validation. And they confirmed stricturing of Crohn's disease on MRE by histopathology from surgery that happened within 15 weeks of the MRE. And they basically found that the artificial intelligence, the radiomics, was better in identifying either inflammation or severe fibrosis in Crohn's disease compared to the radiologist's visual analog scale. And this is depicted in graphically. You can see the tight window with the radiomic scale compared to the visual analog scale in either inflammation or fibrosis. And the last study is looking at small bowel capsule endoscopy's utility with high suspicion of, looking at capsule endoscopy with high suspicion of IBD after a negative MRE or CTE. And this was a single center study. They had 83 patients who underwent 87 capsule endoscopies at a tertiary care center. And they reviewed the charts to see if they had a previous MRE or CTE within a year. It was a small study, but they found that 33% of the patients with negative MRE went on to have a positive video capsule, and 50% with a negative CTE went on to have a positive video capsule. So the take-home message is if your suspicion is high, despite cross-sectional imaging, you should pursue the capsule endoscopy. And sorry, this is the last study. This is a meta-analysis of 17 studies of intestinal ultrasound. And the bottom line is that intestinal ultrasound, when looked at across these multiple studies in over 900 patients, was very helpful in picking out stricture, stenosis, abscess, dilation, and fistula formation. And if you had those things, the sensitivity and specificity of intestinal ultrasound went up. If you didn't have those things, MRE was superior. So there are a lot of advantages to intestinal ultrasound. It can be point of care, it's less expensive, and there's no radiation. There are a lot of challenges with that too in terms of reimbursement, training, and the patient population. If your patient population is more obese, like the problem we have in the United States, it's less useful as a technology to assess. So summary of our potpourri, bile acid sequestration is effective in Crohn's disease patients, ileoanal pouch patients, and microscopic colitis. It's safe, inexpensive, and underutilized. You don't need to test because testing is not predictive, so you should consider using that. Multidisciplinary care is critical in IBD management, and try to have that at your center. And you can check out a resource that Dr. Johnson will talk about in his presentation, GI on Demand, which is free. Radionomic scoring, or AI, is more accurate than visual scoring by radiologists alone. Video capsuloscopy is useful if negative cross-sectional imaging. And finally, intestinal ultrasound shows promise. So thank you very much, and happy to talk to you about questions. I hope to see all of you in Vancouver for ACG 2023.
Congratulations, Dr. Shah, for an excellent overview. You know, it's very difficult to pick up disjointed abstracts and then try to weave a stories together. And I think he did a marvelous job. Within 35 minutes, he picked up abstracts, subsequently categorized them, and then gave you a complete overview about the advances in IBD which have occurred this year. Excellent job. Congratulations. And now we move on to the panel discussion. Well, you know, Sundays are lazy, like. So I thought, like, I have a great panel out here, what to ask and what would be relevant for them. Then I thought that why should I put my mind to use? Why should I exercise my mind? Like, Sundays is to relax. Like, why not go to ChatGPT? I'd heard so much about ChatGPT. So I went to ChatGPT and I asked that, what are the questions which would be relevant for panel discussion on IBD? So they threw up 4 or 5 very interesting areas. They said personalized medicine. They said therapeutic drug ceiling, the drug resistance in a way. They talked about psychological and mental issues. They talked about newer ways of doing surgery and all that. I thought that is good, but still something was. So then I realized, then I put in the question, what will be the most relevant questions for panel discussion on IBD in India? The moment I put the query out there, came up gap, gap, gap. Gap in terms of awareness, gap in terms of diagnosis, gaps in terms of access to biological therapy. So I realized, well, there is something, but we know about it, but still I was a little convinced, but not fully convinced. But when I came out here, then I realized that ChatGPT is not only futuristic, it is visionary. I could not realize there was so much of a gap out here between the panelists and us, and this is a gap which ChatGPT had already predicted, and over half an hour, next 20 minutes, let us try to bridge the gap and come up with solutions, which I believe what Samir has introduced us to new friends, the Gus, Miri, Rizzi, the IL-23 inhibitors, etc. And what do we have out here? So let's start with the discussion. Now, Samir talked about Dr. Sood's study, Dr. Ajit Sood's study about tofacitinib, and that is, I think, when we talk about gaps, tofacitinib seems to be an excellent, promising drug for India, particularly when it comes to being a generic drug. So, Dr. Sood, that has been a great study, the randomized control trial, which you have done on acute severe ulcerative colitis, where you gave intravenous steroids in one arm and intravenous steroids plus tofacitinib in the other arm. So, could you tell us about the results now that the interim analysis that has been subsequently the study has been completed? So, do you think, are you happy with the results? Would you like to advise that we change our practice based on that? Do you think there are other alternatives? What were the adverse effects? And the mortality rate was a little higher, like in ASUC, don't expect in good centers mortality rate over 1, 2, 3%. The mortality rates were jumping to 6% in one arm and 14% in one arm, 10% overall. So, sir, I would request you to throw light on these issues.
Thank you, Vineet. Thank you, Samir, for including our work in your presentation. Uh, Acute severe ulcerative colitis is a medical emergency, and steroids remain the main treatment option for these patients. But we know that all patients, they don't respond to steroids, maybe because of different reasons, including genetic background. And while looking at the pathogenesis, we came across a theory that it's overstimulation of IL-2, which may make patients resistant to steroids with acute severe ulcerative colitis. And JAK inhibitors to some extent may actually work at this level, IL-22, and make its overactivity suppressed. So there was a logic we were just looking for. In fact, it was that it's an emergency and we were not satisfied with the results. So we thought that we should combine the two drugs. And as Dr. Samir has shown, I mean, its time is moving towards a combination therapy. I'm not saying that all therapies should be combination therapy, but the concept of combination therapy is emerging in management of IBD. So we combined the two, and what we found, and we have completed our analysis, and our patients is now 105 patients, and in two arms, what we found that the combination therapy, definitely the response rate is better. We have analyzed according to the Lectiger score and Travis score, and we found that the response rate is 82% with combination versus 58% with the monotherapy. The colectomy rate is not much different, but the requirement of rescue therapy is definitely different. And we have calculated the mortality till 90 days. And the mortality rate is definitely lower with the combination therapy compared to a monotherapy. So now question is that Dr. Vaneet has very rightly raised the issue of adverse effects. We had adverse events in our study, but most of them were not serious. And we didn't have any patient with thromboembolism or MACE. And it's a short-term study, so malignancy is obviously not a consideration. But we had one patient who had thrombosis in the cerebral circulation, but the patient survived. So TOFA has its inherent complications, we can't deny that, acne, hair fall, but the side effects were there. The other arm, I mean, we compared it with azathioprine, though beyond 7 days it's relevant. Now, question is mortality. It is very bothersome for us. When we compare this result with our own previous results, rather than improving, what we are noticing that the mortality has gone up, has increased over the years. Now, it's unbelievable that we are getting a very severe spectrum of disease. Whether it is something to the changing spectrum of the disease, we had a high number of patients who are malnutrition, and a good number of these patients who are referred to us, they are already exposed to steroids in the recent times. So that way, patients who are on oral steroids, when they present with severe ulcerative colitis and we put them on IV steroids, the response rate is not as good as patients who are not exposed to oral steroids in a near future, in the past few days preceding that. Or there's something wrong with our management. You know,
So do you think that we are underplaying surgery out here? Do you think that we are forgetting surgery? That is why patients are going from center to center, getting steroids or getting different kind of immunosuppressants, and that is why the mortality is rising. You're flogging a dead horse kind of scenario.
Vineet, as I said that we are the same team. We have a surgery team which is the same. And as I mentioned that over the years we are seeing, we are intrigued, really we are baffled that why our mortality rate is high. Now it's very difficult to show a mortality of 6 to 7% when world over the mortality reported is 1%. But we are really honest in this that our mortality is high and we have to look into the reasons. And this is in spite of the fact that we are very focused team working on acute severe ulcerative colitis.
Another very interesting thing which in this study, if you all noticed, was that day 3 response rate was checked. It was not seen that at day 5 or 7, and gradually I think in USA and even in India, people are trying to practice that would you like to give IV steroids for 5 to 7 days? Or on day 3, if you're not getting a response, you would like to move over. So like if I ask the audience, like if you could raise your hands, how many of you give only 3 days of IV steroids and then would like to move over to the second line therapy? And how many of you still practice 5 days of steroids and still hopefully wait for 7 days of steroids because that is more practical? Okay, so size and number, so you think the practice should change, sir? Is that a learning point?
I think it's a very, very important issue. Now we have to categorize patients into responders, partial responders, and no response, non-responders. Patients who have shown response or partial response, meaning that the number of stools have decreased, the amount of blood has decreased by day 3, we should continue. But the patients who are non-responders altogether, means the number of stools is increasing or they're deteriorating or the blood is not decreasing at all. I mean, there we should make a decision by 72 hours.
No, so our practice is very similar in the United States. At day 3, we assess response to intravenous steroids. If they're not better, then we make a decision to add, and usually it's infliximab. There's interest in using the JAK inhibitors, but they're not approved for inpatient use. The University of Michigan group led by Peter Higgins has looked at tofacitinib 30 milligrams, mostly in outpatients who are refractory. But our decision point is at day 3, and that's the time we also make sure our colorectal surgeons are meeting the patient in case they don't respond, so that they're not meeting the patient when it's time for colectomy, so the patient has time to think about what a colectomy entails.
Okay, so I'll move on to Dr. Kochhar, please. So now that ustekinumab is available in our country, if a patient came to you, let us say a 70-year-old lady who has Crohn's disease, kind of anemia, which is not responding and all, the patient has not been on any biological therapy earlier. So now you have a choice. You can give infliximab, adalimumab, vedolizumab, ustekinumab, and the patient can pay, can afford the drug. So do you think that here now we do not need to follow the traditional lineup that give infliximab and straight away jump on to ustekinumab? Do you think it can be practiced?
In comparison to infliximab, with Usteki, you have less of infectious complications. So that is one factor that to decrease the hospital-acquired infections or other infections, that is one reason that one could choose Usteki over infliximab. Second, the immunogenicity is less, so lesser need of adding azathioprine. And of course, in patients with fistulizing disease, one would choose infliximab still, till we have particularly perianal disease. In that condition, one would still follow the same algorithm.
Since ustekinumab is a safe drug, so you would decide in elderly, you may still go for it as the first line therapy.
Yes.
Because would in US also you do the same thing, or it's because of the insurance?
Insurance drives things, but our approach is exactly the same. So we feel that the ustekinumab has a great safety profile, but if the patient has fistulizing disease, then infliximab is still our first choice.
Do you think that we are going to now juggle sequence the biologics depending upon any of these, upon the individual scenarios? Is it going to be personalized?
To some extent, you chose an elderly patient. In elderly, the concern will be of, say, comorbidities, cardiovascular disease. So drugs which affect that part, like MACE, for example, that Dr. Samir has shown that ustekinumab, there's no difference in different drugs as compared, particularly in relation to MACE and VT and all those complications. So if we have data like that, then there's nothing to choose between the agents. But before the study, there was some reason to choose one drug over the other in elderly with cardiovascular disease, with diabetes, or with risk of thromboembolism. Otherwise, I think for us still cost will remain a factor in selecting that which particular agent is prescribed first. Apart from, fistulizing disease.
If I may ask all the panelists, like in ulcerative colitis, what is the first biological they generally choose? Most of the cases, leaving aside scenarios like elderly, malignancy, comorbidities, etc.
If you say biologics, yeah, I think for ulcerative colitis, still infliximab, anti-TNF agents among infliximab remains the first choice. But tuberculosis is a real problem for us. I mean, we have highlighted, you have highlighted, we also have shown a high prevalence of tuberculosis, and it's a reality. Once we have interleukins, I think the safety profile is so much better. If we see Vido's action is slow, interleukin's action is faster than Vido, so there is more future for interleukins. I mean, once we have this second generation, as you showed, the Sincizumab and a combination therapy, a combination of Golimumab and Guselkumab seems very promising. But if you say the thing which can give competition to these biologics is the small molecules. You know, we have to keep it in mind that he showed the ozanimod. Its action is very fast. Upadacitinib's action starts on day 2. If its safety profile is good, I think there's going to be very, very close competition between oral small molecules and biologics. And the cost is so much cheaper. And the balance might tilt ultimately in our country towards small molecules.
Yeah, I'm of the same view, like the newer molecules which are coming actually, they are much safer than infliximab. And of course, the fear of having tuberculosis side effect with infliximab is much less with these newer molecules. So it has a great future in patients with severe ulcerative colitis, where actually maybe then in future the colectomy rates may go down.
I think I'll agree with both of them, but let me ask you one question, Vineet and Samir. I mean, a lot of people ask that since TOFA is available in our country, it's much less expensive, even sometimes compared to mesalamines. So a lot of people might have questioned that for uncomplicated ulcerative colitis, why do I use mesalamine? Why not TOFA, which is more effective, maybe less expensive? So what do you suggest, Vineet?
So I would divide it into, if they have mild disease, I would not use tofacitinib, I would use mesalamine. It's just the long-term safety is there and there's no reason to move to more aggressive. But if they have moderate to severe, I think we don't need to have them fail a biologic first. There's a lot of advantages to the small molecule inhibitors. They're less expensive, you can start and stop them, there's no antigenicity. So I think if you don't have the FDA telling you you can't use it first, I would use it first.
I think like people have already made their choice. Even US people are willing to defy FDA. If I ask out here for a show of hands, if you are given a choice between, let us say, infliximab versus tofacitinib in a case of ulcerative colitis who is going from moderate to severe, how many of you would use tofacitinib? So you see, tofacitinib has already many people who are big fans. And
yeah, sorry, can I join the discussion in the 5-ASA versus tofacitinib?
Samir answered that question very well, that if it's a mild ulcerative colitis, then obviously tofacitinib comes with its set of side effects. Let's not ignore that. So you may give it for a short duration, then stop it. 5-ASA would remain the mainstay for treating mild UC. It's only when a patient has had a previous episode of acute severe ulcerative colitis, patient has multiple pseudopolyps, patient is going into frequent relapses, you need to switch over, then you can decide whether to give azathioprine. So ideally you should give azathioprine. If it is not working, move over to tofacitinib. But in general, what we see is that azathioprine takes 3 months to act. So people feel that why not give tofacitinib for 4 to 8 months and control the disease. So the practice is changing. Whenever it's like penicillin not having a RCT and all, obviously the RCTs would come for that, but already gradually the practice is changing out there.
I just want to make one point, rather emphasize one point, that for all patients with ulcerative colitis, from mild, moderate to severe, 5-ASA still remains the first line of therapy. We should never try to bypass this. We should never jump onto tofacitinib as a first line of therapy. And whatever is our experience so far of TOFA is in combination with 5-ASA. I think we should never forget 5-ASA as the main backbone of treatment of ulcerative colitis.
Absolutely, absolutely correct, sir. Govind, now I come to you with a question that often like over last, like you would see treat to target strategy everybody is promoting, that you should not only go for clinical response, you should also go for endoscopic healing. And could you tell us, like if a case of, let's say you have a scenario of ulcerative colitis patient is clinically doing well, symptoms are fine, you scoped the patient, you found that still there are ulcers, UCIS score is still somewhere around 4 to 4/8 and all. So patient is on 5-ASA. Symptoms fine. Now would you upgrade the treatment or not in such a scenario, or you would just relax?
I think this is very, very important. The ultimate goal of treatment in IBD was a symptom care some time back, last decade. But now the outcome we want to achieve in every patient with IBD, with UC or CD, that mucosal should heal. And as Vinith said, there are two situations. One is Crohn's disease, other ulcerative colitis. The fundamental difference with the two would be that ulcerative colitis is a mucosal disease. Therefore, the patient may remain symptomatic, but it may not lead to kind of loss of intestine. Only some patients who have a severe colitis may require surgery. But in Crohn's disease, persistent non-healed ulcer will lead to stricture and therefore obstruction and therefore loss of intestine. Therefore, it's very important that in Crohn's disease, as per data and my own mind is convinced completely that Crohn's, even patient is symptomatic, I'll upgrade the therapy. And in ulcerative colitis, if not symptomatic, I'll discuss with the patient and tell that, do you want to upgrade? Because the upgradation will come with little expense.
So in mucosal, this is something we struggle with in the U.S. as well. And so the question is, what's good enough? And so if it's a very mild mucosal disease, I don't push it. So if there's just a little bit of redness, Mayo 1 or less, then that's probably good enough. We actually have a study through the Crohn's and Colitis Foundation called Quotient for patients who feel well but have active disease. For patients who have moderate or severe disease endoscopically but feel well, those patients I think we can't leave alone. If we leave them alone, they're going to proceed to either having active symptoms or malignancy or other complications. So it depends on the severity of the inflammation you see on endoscopy and on histology. And again, the mild, if they're very mild, I leave them alone and monitor them. We talk to them about it. But if they're moderate to severe endoscopically and on histopathology, then we'll push them to step up therapy.
I think that's an excellent point. So in ulcerative colitis, treat to target strategy still remains to some extent a little bit controversial in the sense that you need not push in every case. So that's a very good learning point for all of us. Now, I come to Professor Najawan. Now, we talked about gaps. Samir showed 3-4 new biologics which are coming up. You already have a ustekinumab. The cost is, is quite like 5 to 6 lakhs. So obviously many of our patients cannot afford. In ulcerative colitis, you have a savior in the form of tofacitinib, which is reasonably priced, cheap in the sense. So I asked this question, I know it's a very tough question, but I ask you in the capacity not only as a panelist and as an IBD specialist, but also since you're the ISG president. So what do you think that can be done in a way so that can be some advocacy measures or something we can think of that so many molecules are coming up, so many biologics are coming up. Is it possible that in our country we can somehow bridge that gap, make it more affordable or make it easily available to the patients? Is it possible? Like some thoughts on that, sir?
See, it all depends actually on the government as well and all the pharmaceutical companies also. Because there was a time when, for hepatitis C treatment, it came for 60 lakhs of rupees and now it's cheaper than treating tuberculosis. So, and it is the same drug, it's not a different drug which came to the market. And initially it came for a year, which was very costly. Then many companies came and the same molecule become cheaper. So there has to be some sort of government policies which should come and it should have some control on the cost of these drugs because whenever they come to the market, there is a boom in the cost. And the same thing gets all right after a few years of marketing. So there has to be some control at the level of the government for these. And as far as the future therapies for ulcerative colitis and Crohn's disease are concerned, it looks to be brighter because as such, the smaller molecules appears to come at a cheaper rate. So it will become more cheap and more affordable to the present society in India.
So if we can bypass or buck the patent law, that is the only saving grace going to be for us in a way. So, Samir, like in US also, does everybody have insurance? What do you do in such?
No, so patients with commercial insurance were able to get them, although we sometimes have to jump through hoops, write letters, talk to the medical director to get the therapy we want. For patients on a government-sponsored program, I'm talking about Medicare or Medicaid, it determines certain things are covered, certain things has a 20% copay. So if the treatment costs $50,000 a year, most patients can't afford that 20% copay. So we're stuck with ones that we can choose. So it's the same issue. Hopefully with biosimilars, with with multiple products in the same mechanism, so multiple JAK inhibitors on the market, that's going to drive prices down. My hope is that Lupin and other pharma in India comes up with their own P19 inhibitors, their own JAK inhibitors, and the prices come down, not only in India, but across the world.
I think now I would like to thank my panelists for an excellent discussion, Dr. Sameer Shah for a beautiful lecture. Thank you, and we give them a good round of
I would like to, while you guys get together, take a picture, I would like to invite the moderator for the next session, which will be on endoscopy, Dr. Mahesh Kumar Goenka, who is the director and head of the Institute of Gastrosciences at Calcutta. Our panelists today are Dr. Kapil Dev Jamwal, Dr. Praveer Rai from SGPGI Lucknow, Dr. Rajesh Puri, my friend from Medanta, Dr. Rakesh Kalpala from AIG, who we dragged him into this, and Dr. Vikas Sangla. And it's now my pleasure to invite our speaker for this afternoon, Dr. Vanessa Shami, who is a professor of medicine and section chief of interventional endoscopy at University of Virginia at Charlottesville. Please congratulate her. She is also the recipient of this year's ASG Distinguished Educational Award, which she will be receiving in May. Her main interests are in therapeutic endoscopy, including Barrett's esophagus and pancreatic biliary medicine. Vanessa.
Thank you for that kind introduction, Nalini. I want to thank Nalini. I want to thank Dr. Goenka and let him know that I love India and everything about it because he was inquiring about it earlier. And thank you so much to Lupin for their hospitality and really great educational program. So I'm concentrating on endoscopy and Nalini is doing pancreatic biliary. So when we look at endoscopy, I'm going to separate it by body, procedure types. So first, we're going to look at endoscopic mucosal resection and submucosal dissection. And it really has revolutionized the way we treat dysplastic and early cancers of the GI tract. However, as you guys know, this procedure can be technically challenging. And the data presented in the next abstracts will really address the following. Management of tough-to-remove and adhesed lesions, new products for the development of periprocedural bleeding, as well as demonstration of a potentially new technique or actually a device that potentially facilitates resection. So this first abstract entitled Distal Cap-Assisted Endoscopic Mucosal Resection is safe and effective technique for resection of non-lifting or adhered colorectal lesions. You know that the reasons for not being able to lift a polyp are the following. They've had previous submucosal injection, so you tattoo too close to it, it goes into the submucosa and causes adhesions. Prior biopsies, either cold or hot, can do this, and failed prior polypectomy. All of this causes submucosal fibrosis and can be quite difficult to sort of resect afterwards. So what are the potential solutions? Well, we can do hot avulsion, we can do underwater endoscopic mucosal resection, or you can use a full thickness device. But how about this? How about if you utilize a standard clear cap, and then you go ahead and you lay it over non-lifting tissue. Once you do that, you use a stiff snare, you put it over the lesion, you press down on the cap, you suck up the mucosa that's adherent into the snare until you see a blue out because you've submucosally injected with a blue dye, and then you close the snare, and then the suction is released, and you do cautery, and you resect the lesion. So in this video, what you'll see is they feel like there's a flat area. Again, there's submucosal injection. They have a stiff snare, as you can see there, and they're using the cap and they're going into they're pushing on the actual lesion. They're sucking it up. You're going to see a blue out soon, and then you're using electrocautery to cut off the lesion. You can then look at the base of the lesion, and you're hoping to see submucosa, hopefully no target sign. And once you see that, you can look for residual tissue. You can see in this defect, there will be a little bit of residual tissue, no perforation, fortunately, and then you can do either cold avulsion or hot avulsion at this point. So this is a retrospective study of 3 international centers, one of them being Doug Rex. All lesions were previously biopsied, tattooed, or had a prior polypectomy attempt, and all of these polyps were greater than 15 millimeters. The primary endpoint was complete macroscopic resection, and the secondary endpoints were procedure time, recurrence at follow-up, colonoscopy, and adverse events. And what were the results? Well, complete macroscopic resection was in 100% of them. The mean follow-up of the colonoscopy was 6.6 months, and the recurrence rate was almost 10%. There were 2 adverse events. One of them required the post-polypectomy, a hospitalization, and antibiotics and observation. The other required, the bleeding actually required clipping. So the authors concluded that this is a safe, efficient, and effective way of managing fibrotic and non-lifting polyps, which have previously been manipulated. And in this study, it really looks like the macroscopic resection rate was 100%, but there was a 10% recurrence. And again, recurrences can be treated, but they become a little bit more difficult. The food for thought is, can we generalize this technique to other parts of the body? And we can talk about that in the panel discussion. Next, this is a new hemostatic peptide solution for hemostasis. Was originally used in the surgical literature. It's a synthetic self-assembling peptide called TDM621. It's got 16 amino acid residues, and it's aqueous until you inject it. So when you inject it, it's fluid, and then when it comes out as a gel. And once it comes out as a gel, it takes a while, a minute or so, but it actually will cause hemostasis in the setting of this, you can see in this ESD that the authors have performed. If you give it a moment, again, you have to wait, so it's not immediate like cautery, but nonetheless possible. So what they did is they looked at patients undergoing ESD of both rectal and gastric tumors, and they randomized them in a 1-to-1 fashion to the TDM621 plus coagulation, which means if the TDM621 during bleeding did not work, then they would use hemostatic forceps versus hemostatic forceps alone. And so again, so if the patient in the TDM group bled, they would give them gel, and they would wait up to 3 minutes. And if hemostasis wasn't achieved at 3 minutes, then they would go ahead and do traditional hemostasis. And they had both the endoscopist look at the results or kind of judge what the endpoints were, as well as a third-party committee who evaluated the procedure. And the primary endpoint was the number of cauterizations in each group. And so when you look at the third-party committee, the number of cauterizations was greater in the control group. Not a surprise, because the gel causes some hemostasis. This is the same when you look at the determinants by the operator. So if the operator decided whether it worked or not, they had the same conclusion. Secondary endpoints, so time from oozing of bleeding to completion of hemostasis, was statistically better with control. Because again, the hemostasis takes a little bit longer with the gel. Now, there was no difference between the bleeding, there was no difference between the start and end of the ESD. The one thing I want to point out is that if you use the gel alone, 60% of the time it would cause hemostasis. So the other 40%, there was additional therapy needed. Adverse events in terms of serious were similar in both groups. So the conclusion is that this gel appears to be efficacious and safe, and it may result in a decreased need for cauterization. It does take a little bit longer to achieve hemostasis versus cauterization. Again, this is a new tool in our armamentarium. This is a question of efficacy of a traction device for endoscopic submucosal dissection using a scissor-type knife. And again, it's a new device. It can, after you kind of get the first plane, you can take it, you can actually clip the mucosa to the opposite wall of the colon, or the lumen in general, and then you have the nice submucosal plane that becomes visible. And what they use is they use this scissor-type device in colorectal lesions. This is a prospective multi-center parallel two-arm open-label randomized controlled trial. They looked at laterally spreading superficial large colorectal lesions. All procedures were performed with a hood and a scissor-type knife, and patients were randomly assigned to either undergoing conventional ESD with a scissor knife or conventional ESD and traction. And really what they were looking at was mean resection speed. That was the primary endpoint, which was defined by resected specimen area over procedure time. There were about 49 in each group, and what they saw was the resection speed in both groups were the same. So there was no statistical difference in resection speed in this study. They also noted that there was a complete resection, curative resection, and adverse events were the same. But when they looked at the different parts of the colon, it appeared that the traction device did facilitate resection speed in cecal lesions. There was a trend to it actually helping in larger lesions, so lesions that were greater than 30 millimeters. So the authors concluded use of a traction device for ESD in the proximal colon and for large lesions may increase resection speed. And again, another tool in our armamentarium to potentially look forward to. Now let's shift a little bit to endoscopic ultrasound, which is my passion. Endotherapy, we all know, is the new kid on the block. We can now perform endoscopic evaluation for signs of portal hypertension. We can do EUS-guided portal pressure gradient measurements, and I know that's not available here yet, but it will be coming soon, and EUS-guided liver biopsies. The nice thing about this is we can do this all in one setting. So one procedure, and you can do all of this if necessary. So what are the potential advantages? Well, this was a nice article in ACG that says you can biopsy both lobes. You can do the right and left lobe depending on where you are in the stomach or the duodenum. It potentially has a better safety profile, decreased patient discomfort and anxiety, decreased recovery time, because when they do at IJ, our radiologists watch for about 4 hours, and the reason being is they can't tell if the patient is bleeding as well as we can by endoscopic ultrasound. And then again, they can do a one-shot stop where they can do a whole bunch of procedures in one setting. So is it efficacious? And what is the safety of it? Well, it appears in these meta-analysis that liver biopsy is effective and safe with a diagnostic yield of over 90%. This is a case that I had of hemoperitoneum, so there isn't no risk, just FYI. The other thing is, in terms of EUS-guided biopsy and other modalities, if you look at these meta-analysis, I'm going to sum it up. Percutaneous biopsy does give you longer samples with more complete portal triads according to the data versus EUS, but we are getting better with improvement of our techniques. And EUS biopsy is equivalent right now with the current literature than transjugular biopsy, but I do think we're going to see more promising data for EUS in the near future. Now, this is a nice table that they sum up kind of all the studies. And the one thing I want to show you is that over time, we've been doing more and more. We've gone from dry to wet suction technique. where we put some saline in the syringe and we do negative pressure. And this seems to really improve yield. The other thing is the type of needle you use. So for the ultrasonographers, the Francine needle seems to be superior. Questions for the future? Again, more data on the optimal needle type and the optimal technique. Now we're going to move to obesity. It's a pandemic in many parts of the world. Actually, in the US, this is the leading cause. The fatty liver disease is the leading cause of progressive liver disease. And the management of obesity becomes of utmost importance. And in this abstract, they looked at endoscopic sleeve gastroplasty versus intragastric balloon. And so for the endoscopic sleeve gastroplasty, I'm going to call it ESG because it's easier versus balloon. For ESG, the total weight loss in the literature is up to 16% at 12 months, sustained weight loss of up to 104 weeks. With the actual balloon, total body weight loss is up to 10% at 12 months, but it is removable. You need to remove it at 6 months. So what the authors did is they wanted to compare ESG versus balloon, and because the data is pretty limited. So they wanted to compare the short-term safety and efficacy of ESG versus balloon in utilizing a large international database. So they took this database of 80 centers internationally, and they had they propensity matched the groups. And what they saw outcome-wise was the outcomes were severe adverse events, and you can see readmission, reintervention, reoperation, etc. The baseline characteristics were well matched, as you can see here with the p-values. But what were the results? Well, the results were with ESG, even though it wasn't statistically significant, there was a trend to higher complications. So these were bleeding, ICU stays, sepsis, all of them recovered, but nonetheless. But the intervention within 30 days was actually greater with balloon. And that's because patients couldn't tolerate it. They had pain or nausea or refractory vomiting. The other thing is, dehydration-wise, it seemed to be much more difficult on the patients with balloon. And then in terms of weight change, there appeared to be more weight loss with ESG, but the database only went to 30 days. So it's kind of hard. We need longer-term data. So both of these seem to have low serious adverse events. Patients undergoing balloon placement had more re-interventions and higher rates of dehydration, and ESG had greater short-term total body weight loss, but remember, it was only for 30 days, so we need longer-term data. So ESG appears to be better tolerated than the balloon. Now let's talk about reflux. So GERD symptoms are a common problem after POEM, and this single-center retrospective study of a prospectively collected database, which is basically retrospective, looked at consecutive patients who reported one or more symptoms during pH monitoring greater than 6 months after a POEM. And the patients all underwent high-resolution impedance manometry, functional lumen imaging probe, or FLIP, and Eckerd symptom scoring, and some of them underwent wireless pH testing off of PPI therapy. Positive reflux symptoms association for any symptom was defined as the following: a symptom index of greater than or equal to 50%, or symptom association probability of greater than 95%. There were 91 patients that were included in total, and a mean of 8.8 months after the POEM. The clinical response to the POEM was quite good, with anywhere between 86 to 90%, based on the Eckerd score, the IRP, and FLIP. Post-POEM GERD objectively was 68%. But if you look at the correlation between symptoms post-POEM and the actual SI or SAP score, it was pretty poor correlation. So again, using the SI or the SAP post-POEM is less accurate than when you do it prior to POEM for reflux. So the other thing is that among the 91 patients who were symptomatic, post-POEM GERD patients reported more frequent heartburn and had more severe esophagitis compared to those without GERD. So again, there's poor correlation between symptoms and esophageal acid exposure after POEM. So objective testing by EGD, PPI trial, or pH testing, rather than patient-reported symptoms, may be required post-POEM. Now let's talk about some important guidelines. This is the ACG guideline on subepithelial lesions. I was fortunate to be an author on this. You know, subepithelial lesions, we all see them, we find them incidentally. They can be benign, they can be malignant. So it's always difficult to know what to do for them. And this is actually the first grade paper that we have. So for symptomatic subepithelial lesions, what should we do? Well, usually, if they're symptomatic, we're probably going to resect, right? Sometimes we'll get tissue if the surgeons want it, or they're going to give upfront therapy, but nonetheless, as a rule, you're going to resect it. Now, you incidentally find the subepithelial lesion. Now, what do? Well, you can poke on it, right? You look at the color. Is it yellow? Is it soft? And that's called pillow sign. If it's got a pillow sign, there's high specificity. Obviously, the sensitivity is not perfect, but the pillow sign plus it having a yellow hue, we concluded that if there is a positive pillow sign, then there's no need for EUS. I mean, you and I can identify a lipoma. Then for all other firm asymptomatic lesions, EUS is warranted. And that's because we are able to tell whether it's intrinsic or extrinsic, because sometimes the liver can push or the spleen can push, and it's difficult to tell. We're going to look at echogenicity. Is it bright? Is the lesion dark? Is it black? Because that's fluid. So those are the things we're looking for, and we're also looking at the wall layer of origin, because we know that muscle tumors come off of the dark layer, neuroendocrine tumors come off of the submucosal usually, and varices come off of the submucosa as well. So it really depends on the wall layer of origin, and that can help us differentiate what type of lesion it is. Now, how about you just tell me, I don't do ultrasound, let's do bite-on-bite biopsies. Why can't I do that? Well, you can, but you can also get into a serious situation, like in this case, right? I mean, you can always hit a varix, and it's been done before. So you really want to make sure it's solid. You can see on the right side, the EUS imaging clearly shows that it's a varix. And so we did not suggest bite-on-bite biopsies in the evaluation of subepithelial lesions prior to EUS. Again, I want you to notice that the data is very low quality for many of these recommendations because we just don't have huge randomized controlled trials in these studies. So what about FNA versus FNB? And I have highlighted some of the studies that are actually randomized controlled trials, but a lot of them are not. And what you can see is sample adequacy favored FNB, actually was statistically significant. I do want to show you that the confidence interval is large, so the estimate of effect is less precise. But with diagnostic accuracy, the confidence interval was small, so the estimate of effect is more precise. So it looks like FNB is superior. But not everybody has FNB. So we recommended EUS-FNB alone or EUS-FNA with rapid on-site evaluation. That's when they come in and look at the slides in the room for solid subepithelial lesions compared to EUS-FNA without a cytologist. So that's what we recommended in the guidelines. So you still don't have a diagnosis. You have no diagnosis. Should we unroof the lesion to get the diagnosis? And there's good data for this. Actually, there's a meta-analysis of 7 studies of 160 patients. And basically, the pooled diagnostic yield was 89%, so excellent. So clinically, there was significant bleeding in 5%. So we suggested employing an unroofing technique when definitive diagnosis of a subepithelial lesion is necessary and when EUS-FNA or FNB is non-diagnostic. Now you're going to say, you just told me I can't do bite-on-bite, but you're telling me I can go ahead and unroof something? Well, at this point in the algorithm, we've already done the endoscopic ultrasound. So we already know it's not vascular. Now, how about management? Well, you're going to leave alone the, lipomas, leiomyomas, unless they're symptomatic. It's intuitive. The ones we worry about are the GISTs. So if you look at the NCCN guidelines, if the GIST is 2 centimeters or less, the chances of metastases really, really low. So the question is, keep that in mind, right? 2 or less, very, very low chance of metastases. Now, in non-gastric GIST, or those that are greater than 2 centimeters, the chances of metastasis can be quite significant depending on the mitotic index. So we concluded there's insufficient evidence to recommend surveillance versus resection of GISTs less than 2 centimeters in size. But due to their malignant potential, we suggest resection of GISTs greater than 2 centimeters in all non-gastric GISTs. And again, because non-gastric GISTs are more likely to metastasize at a smaller size. How about neuroendocrine tumors? We know type 1, we see it in atrophy all the time. It's pretty benign. And so we tend to go ahead and resect the large ones. And what we said is, we suggest either EMR or ESD for resection of type 1 gastric neuroendocrine tumors. But no data for type 2, not enough to make any conclusions. But for type 3, because it can be more aggressive, if we've decided there's no lymphadenopathy and that the grade is low, then we suggest ESD over EMR because you do not want positive margins. These can metastasize, and it'd be interesting to hear what the panel thinks. So again, we recommend ESD over EMR in these lesions. How about rectal neuroendocrine tumors? Well, again, if they're small, less than 1 centimeter, keep that in mind. The chances of metastasis are quite low. So we do not suggest one type of endoscopic therapy, endoscopic mucosal resection versus ESD for the resection of anything that's less than or equal to 1 centimeter. So you have a subepithelial lesion. It's symptomatic, i.e. it's bleeding. You're going to resect it. If it's asymptomatic, you're going to see, is there a pillow sign? If there is, you're done. If there isn't, then you're going to do an endoscopic ultrasound. Now, in terms of treatment, if it's a gastric GIST, 2 centimeters is what to keep in mind. If it's less than or equal to 2, you can do surveillance versus resection, and a lot of it I find has to do with patient anxiety, age, etc. If they're greater than 2 centimeters or they're non-gastric GISTs, then you're going to resect. Now, how about gastric neuroendocrine tumors? If it's type 1, you're going to do EMR or ESD. Again, it doesn't matter. If it's type 3, they're more aggressive, and you're not going to surgery. Again, that's a big if. Then you're going to do ESD over EMR. And then for rectal neuroendocrine tumors, keep in mind 1 centimeter. If it's less than 1 centimeter, you're going to do EMR or ESD. If it's greater than 1 centimeter, you're going to do ESD or surgery. So please keep that in mind. Now, there's a new guideline on management of lower GI bleeding, and this is just updated from a few years ago. And I just want to highlight the major changes in these guidelines. And I'm going to talk about them one by one now. So first of all, they recommend a stratification tool, and they actually mentioned the Oakland score. This involves age, sex, previous lower GI bleed, digital rectal exam findings, like do you have blood or not, heart rate, systolic blood pressure, and hemoglobin. And what they found is if the score is equal to or less than 8, you can probably manage these patients as an outpatient, but you have to use your clinical judgment. So we suggest using risk stratification tools to identify low-risk patients with lower GI bleed who are appropriate for early discharge and outpatient diagnostic evaluation. Again, they say risk scores should not be used to supplement or replace clinical judgment, because we know clinical judgment is everything. How about the role of reversal of vitamin K antagonists? Well, although most patients with lower GI bleed on vitamin K antagonists are unlikely to require reversal, we suggest reversal of patients who present with a life-threatening lower GI bleed and have an INR substantially exceeding the therapeutic range. Also for patients on VKAs who prevent stroke in non-valvular atrial fibrillation who require reversal, they actually no longer use FFP as first line. We're now using PCC, or prothrombin complex concentrate. That's because it'll correct the coagulopathy quicker. How about the role of DOACs, and should we be reversing patients? Well, for patients on DOACs, they suggest reversal for a small subset of patients who present with life-threatening lower GI bleed that does not respond to initial resuscitation and cessation of anticoagulation alone. And the reason for that, if somebody has a thrombotic event, it's on us. So we can't just say we're the gastroenterologist, they had a stroke, oh well. It's actually on us. And for patients requiring reversal, targeted reversal agents should be used when available if a DOAC has been taken within the past 24 hours. So again, you gotta be very, very thoughtful. How about CTA? This is a big, big difference in our armamentarium. So they now suggest performing a CTA or a CT angiography as the initial diagnostic test in patients with ongoing hemodynamically significant hematochezia. However, CTA is of low yield in patients with minor lower GI bleeding or in those whose bleeding has clinically subsided. So keep that in mind. The algorithm has changed a little bit, and I'll summarize that. They also recommend that for patients who have a CTA demonstrating extravasation be promptly referred to interventional radiology for treatment. So you have mild hematochezia, and what's highlighted in red is new stuff. You get an Oakland score. It's less than 8. You can discharge the patient if it clinically makes sense. If it's greater than 8, you can do a non-urgent colonoscopy as an inpatient versus observation if the bleeding is slow or subsides. If you've got severe hematochezia, you want to resuscitate them, give them blood products as needed. If they have ongoing significant bleeding, then you're going to do a CTA, again, new to the algorithm. If there's extravasation, then you're going to send them to radiology for a prompt angiography with embolization. Now, if you're a very, very subspecialized facility that's very good at hemostasis, then you can consider an urgent colonoscopy for intervention. Now, on the other hand, if you have milder bleeding or bleeding has subsided, or there's no extravasation on the CTA, then you can do a non-urgent colonoscopy versus observation, again, if the bleeding subsides and the patient has had a recent colonoscopy. So again, clinical judgment is everything. So when do we resume antiplatelet agents and the risk of recurrence recommendations in diverticular bleeding? Well, we recommend discontinuation of non-aspirin NSAIDs after hospitalization. Now, those who have primary cardiovascular or on it for primary cardiovascular prevention, they suggest discontinuation of aspirin. But if you've had a history of cardiovascular disease, then they recommend continuing it. Kind of intuitively makes sense. And then they recommend that providers reevaluate the risks versus the benefits of continuing non-aspirin antiplatelet agents, such as Plavix, in a multidisciplinary setting after a hospitalization. So it's very important. I always document. I've had a discussion with the cardiologist. They have stents placed. It's been 7 months out, and the cardiologist agreed that it was safe to discharge or discontinue the Plavix. So with that summary, I want to thank you so much for allowing me to speak to you today, and I look forward to the panel discussion.
I must thank and congratulate Dr. Venesha for covering so many topics in 35 minutes. and give us an overview of what is new, not only in the ACG presentations in the last ACG meeting, but also some of the guidelines which has come in the last year or so. We have obviously excluded the pancreatic or biliary component, which will be covered by Nalini in one of the subsequent talks. And we have a very strong panel, I would call them aggressive endoscopists of this country, who are sitting there on the dais. What I have planned for the next 25 minutes is to only address some of the abstracts. I know we can discuss therapeutic endoscopy in great detail, but I'll restrict ourselves and see what are your viewpoints about some of the messages which has been conveyed on these abstracts. So let me start with the first abstract, and I would address this to Rajesh, Dr. Rajesh Puri from Medanta. Sami showed us the way to tackle a fibrosed or adherent lesion. So how big is the problem? How can you prevent it? What causes this problem? How can we prevent it? And what's your current way of dealing with such lesions? And also, do you think that the technique which has been demonstrated can be utilized at least in subset of people?
So what I understood is you asked, number one, how can we prevent the submucosal fibrosis?
And how common is that if you are treating 100 patients, how commonly do you find fibrosed or adherent lesions?
Okay, so let me start with your third question which you have asked. Is it relevant in the practice doing the cap-assisted EMR? Definitely this is a very good method, and when we encounter such kind of problem, especially when somebody else has tried the polypectomy outside and he was not able to do it and patient was referred to us and we find lot of submucosal fibrosis. This is a common problem which we encounter in our day-to-day practice. So in those situations, cap-assisted polypectomy will be definitely good. But this is a small study in 61 patients. 3 experienced endoscopists was doing. Number third, the follow-up was only for 6 months. In that, the 8% recurrence was there and there was no perforation. The most common complication which we encountered in a submucosal fibrosis is a perforation which has not shown in this. If we can replicate these studies in various centers and there's no perforation, less risk, then definitely it is going to be useful. But the drawback of this study is it is only seen in the type 2A lesion when we talk about the submucosal fibrosis because of the malignancy. In those situations, EMR is not the right answer, the ESD is important. Now when we talk about our clinical context, in this 50% of the patient was on the right side of the colon. One study from the India, AIG, 35,000 colonoscopy, 10% incidence of the polyp, and out of them, the 50%, 42% was adenomatous, and we encountered more on the left side of the colon or on the rectum. In our experience also, when the patient was referred to us, we find that it was an incomplete polypectomy was the reason of submucosal fibrosis. Not much of the biopsy or so, I think that can be tackled because that is an okay. But the most common indication in our sector is people tried polypectomy outside, not able to do it completely, and when they are referred to us, or there is a recurrence of the polyp. These are the 2 common causes in our country.
Rajesh, I think your message is very clear, but do you think that tattooing the lesion very close to the lesion is also responsible for fibrosis in some patients?
Yes, theoretically tattooing the lesion or taking the previous biopsy is one of the important cause. But as our incidence is not that much, what we encountered is people has injected the submucosal injection for removal and they were not able to do it, or there is an incomplete removal of the polyp. These are the 2 important indications in our scenario where we encountered a fibrosis.
So, Dr. Venesha, one of the question is that how safe is this procedure? When we do an EFTR, we are doing almost the same. In addition, we are putting a clip to prevent any perforation. So here, does the depth, the length of the cap or the type of the cap would also matter?
Absolutely. And so first of all, the longer the cap, obviously, the more tissue you can get in. And they actually had a low profile cap on there. So that makes a difference. But I agree completely, and that was why I brought up the food for thought. Like something like the duodenum, absolutely not. Here, yeah, you can do full thickness. I find the right colon is a little bit difficult to use the full thickness device. Sometimes it can be challenging. I think it's important to know that what they're saying is completely right. These are experienced centers that do a ton of these. And so I think it's important to know it's an option, but perforation is a real risk. Just because it's 0 in this study, it doesn't mean that it won't happen.
And one more important thing, the time taken in this study was around 48 minutes. I think doing a traction and doing the ESD is also a very good, because most of the lesion was around 2 centimeter or 3 centimeter, and they have opted for more than 15 millimeter. So doing the traction and doing the ESD is also not going to take more than 1 hour. You give a complete specimen, and that is good for a patient who has a suspected submucosal invasion where the EMR is not the answer.
I think Vanisha mentioned that as the alternatives which are available to us, and ESD was one of the alternatives which you talked about. Vanisha, you want to make any quick comment?
No, I want to say you're absolutely right. The hard part is not everybody does ESD. So I think these are just kind of alternatives to ESD, but you're absolutely right. If it was, in your center, an ESD can be performed. But, again, more and more people are doing ESD, but it's not available to everybody.
So let's move on to are there any comments from the other panelists?
Can I ask one question? What I understood is you opened the snare on the lesion and then took the scope and the suction was applied. Can we do the methods where the snare open inside the cap, as we are doing it with the duet? Duet where snare is open inside the cap, you suck the lesion and then the cap going to cut. Here what you have done is the snare is open, then the scope is taken on that and then the suction is applied. That might be sometimes difficult. So duet works very well in these situations or not?
I find it's hard to, especially in the right colon, it's not that easy to see that well with a duet. I think it's pretty challenging. Olympus has that pre-looped snare in the cap, but again, those are challenging to get to the right colon. And I'm not advocating this being the end-all be-all procedure, but those are the challenges.
Let's move on to the next abstract, and this is regarding the hemostatic solution, a novel hemostatic solution which is called TDM621, which was presented. So Kapil, this question is to you as to, are you excited about it? It's not yet available in India, but do you think it will be a good armamentarium? And what's your policy to prevent and treat bleeding during ESD? And do you do something at the end of the ESD to prevent a delayed bleeding?
So bleeding occurs in higher centers. What they have shown is 4 to 8%, but if we see the real world data, it's very high. And if it bleeds because it's difficult to control because the vessel is very deep, it's not like a bleeding vessel which find on an ulcer, it's very difficult vessel to control. Yes, we require armamentarium. Sometimes we don't find accessory to control because the forceps will not work. So that time we require such accessories. Powders have been used. The problem with why this are coming, because the problem is with our endoscopic maneuverability with this scope. If we compare to a laparoscope, they have very much instruments. Endoscopy is less instruments. That's why we require accessory support, like we require special forceps, we require powders and gels. So this powder is TD621, and this has shown to be very well because it's available in 28 countries. The new thing is that a new powder has come, which is available in Japan, is 623. So I think it's not FDA approved. I think it shows that time is half. And the limitation of this study was they had not tried this study on a spurting vessels. So they was or oozing or less vessels were used. So suppose they have tried on pig model and 623 has worked very well on lesions which had spurting. So this could be seems exciting. And the other future could be because the problem with triangulation, because we have only one arm which when we do ESD, in next 10 years if the robot comes into clinical practice, I think then we don't require such instruments. I think the robot will itself take care because we'll be able to do more hemostasis with the same channel.
So in this case, we discussed this last evening also, that after you inject, you wait for 3 minutes. Isn't that too long a time to wait before you apply the cautery?
Absolutely.
And do you think applying a cautery in an injected lesion is same as applying a cautery without an injection?
So the first question, 3 minutes is a long time. I mean, especially for endoscopists. I mean, I get impatient doing 30-second dilations. So yeah, it is a long time. And I think where this is going is, I think they're trying to find a home with this agent. I think eventually, post-resection, trying to see whether it can prophylactically decrease bleeding. And I think that's where the role is going. But yeah, 3 minutes is a long time.
So,
and go ahead.
Do any one of you push hemospray powder, whatever is available in our country, at the end of the ESD to prevent bleeding post-procedure? Vikas, Rajesh, or anybody?
First, I want to make a comment regarding this study. So when we do the ESD, we want a very clear field. So our preference is first attempting with the hemostatic forceps. Once you use this fluid, there can be opaque film formation in the field, and that may make it difficult. Even in this study, the first thing was the use of electrocautery forceps. If they were not able to localize the site of bleed, then they use this fluid. So the first attempt should be with the hemostatic forceps only.
Okay, we'll move on to the third presentation, was on the traction device, which Shami showed with the video. So Vikas, you do a lot of ESDs. When do you need traction? Which cases do you use traction? What is your present practice? And are you interested in a device like this?
Sir, during most of the ESD, we require traction. Traction is required to separate the mucosa from the muscle layer. We want a wider field, wider separation of mucosa with the muscle layer. So there are various methods used for the traction. We can use the tapered cap, we can use the gravity also, and then there are methods of using the pocket creation and the tunnel creation. Below the lesion, we can make a pocket and go across the other side, that the mucosa will provide a traction. So if everything fails, we can use a traction device. So right now we are using a multi-loop technique. So what we do with the suture, we make multiple loops. We attach one end of the loop with the mucosal flap, and the other end is fixed to the other wall of gastric or the colonic wall. But yes, if this instrument is available, definitely this is going to make it very fast.
So, Sammy, in this study, the primary endpoint was the speed. Does it really matter? Whether we are finishing the procedure in 20 minutes or 25 minutes, is that the deciding factor? Which was the primary endpoint in this study?
No, I actually disagree with that primary endpoint. I mean, it should be efficacy, ease, safety is a big thing. So I agree with you wholeheartedly.
So what is your comment about the pocket type of ESD? Do you do that back home?
No.
But I think very important, whenever you come across with the submucosal fibrosis where the traction is very much mandatory, the lesion more than 3 centimeter, lesion in the right side of the colon, because it not only increases the speed, but it also decreases the complications. Because a lot of fibrosis, the field of vision is not good, and you are doing the submucosal dissection. If you have a traction device, it is cheaper because SO clips are quite costly. So what we require is we invent like a small rubber band, and that is going to use to attach to the other wall, and that is going to give the traction. Field of vision is better, your dissection will be better, the total plane will be better, and the chances of the complication will be less.
But this design looks good. I don't know, we need to have more studies with this, but the design of a clip with a ring looks quite good. Now let's move on to the next topic, and it's a hot topic everywhere about EUS liver biopsy. Praveer, are you a convert totally from percutaneous biopsy to EUS biopsy? What is the technique you use? We discussed about the various needles and the wet versus dry. So, and will you do it only when you are doing an EUS for some other procedure? Also, how difficult or easy it is to do a biopsy from the right lobe through the duodenum?
Yeah, so I think multiple questions in a single question. So I think let me just put things into perspective. So if you just ask me whether ultrasound guided biopsy or an EUS guided biopsy, as far as India is concerned, the answer is ultrasound guided biopsy. Having said that, the only reason why I'm saying an ultrasound guided biopsy is the cost. That's the only reason. So let's see what's the advantage of EUS guided liver biopsy as has been shown in the first slide which was presented. So one is you are doing under real time, you are able to see the vessels. Secondly, if the patient has underlying liver disease, that's the most common reason why you are doing an EUS biopsy in these settings. You are able to pick up varices, you are able to measure the portal pressure if that is required, all in the endoscopy theater in the same sedation. So those are the distinct advantages which EUS has. If we see the slides, it was clearly shown that the percutaneous liver biopsy gives you more number of portal tracts as well as the specimen length is more. So having said that, what ASLD recommends is that you need to have at least 11 complete portal tracts and a sample length of 2 to 3 centimeters. And this is primarily for percutaneous liver biopsy where you're using a 16 gauge needle. What we are doing here is we are using a 19 gauge needle, and for all US literature, if you see, portal tracts more than 6 and length more than 15 millimeter suffices. So the increase in length or the complete portal tract may not translate into the diagnostic yield. So we have our study published, it's still to come online in Indian Journal of Gastroenterology, 50 patients. And all these patients, 19 gauge US FNB needle, diagnostic yield was 100%.
So did you use suction in those?
Yeah, so as far as the technique, I missed on that. So what we are using uniformly still till date is the slow pull technique of the stillet. Though, if you see the literature, what is recommended or what is suggested is that wet suction techniques gives you the maximum tissue.
So are there contraindications to doing a US biopsy? Is the patient ascites or a mild coagulopathy? And if the bleeding happens, what do you do? When you have a percutaneous, you apply a gel.
Yeah.
So how do you tackle this and what are the contraindications?
Yeah. So I think again a very, very important question. Mild ascites to me is not all a contraindication. You have the needle traversing through the stomach and entering into the stomach, entering into the liver. So even if mild ascites is there, I don't think that's a contraindication. We have done in few patients with mild ascites. Second, about coagulopathy. I think mild coagulopathy may be US guided FNB may be safe. There, instead of using a 19 gauge, you can choose to do a 22 gauge. And the reason why I'm saying that it's safe is, one, we are doing under Doppler. Second is, the recent evidence shows that even a single pass with single pass with 2 to 3 to and fro movements, you are done with it. You don't need further passes. The risk decreases.
Vanessa, you showed us a very dreadful complication of hemoperitonum. So what's the learning curve for US liver biopsy?
I mean, I think the learning curve, I think most people do have a learning curve. And I think it's a combination of technique and needle. So I'll tell you, I used to do dry, I used to do slow pull, and my CPTs were really low, and then I started doing wet, and I got a call from the pathologist saying, what did you do different? These are great specimens. And I do agree that you really have to watch. So if you start seeing bleeding, you can see, like you had mentioned, Doppler. If you start seeing bleeding, what I do is rescue-wise, and you can always push the specimen back. If you're starting to see, as you pull the needle out, you start seeing really bad flow, then you can always sacrifice the specimen by putting the stylet back in. Or you can use other agents as well.
So I think the next abstract, let's be brief comment.
Right versus left lobe liver biopsy. We have a study recently published from AAG where the yield is equal. Either you do it from the left lobe or the right lobe of liver biopsy.
Right lobe versus left lobe.
The yield is same.
And in liver, and if there's a liver disease, mostly the left lobe will get enlarged. So it's better to biopsy from left lobe, and suppose you are not getting a sample, then you go to right lobe.
Okay, so the next abstract was ESG versus balloon. And I think there cannot be a better person than Rakesh to talk about this. Are you disappointed with the results at 30 days for 3% body weight loss with ESG?
Actually, I disagree with doing the study itself. It's not wise to compare both the modalities, though they are gastric space-occupying things. It's not wise to compare a balloon with a ESG. Both are different techniques, number one. Number two, the re-interventions for balloon were shown to be high, probably because they must have used a adjustable Sparks balloon. Because Opera is a all or none. You cannot do any re-interventions. Number three, about the adverse events in ESG, I think the take-home message should not be of fearing that ESG has got complications. So whatever the complications have been shown in the paper must be by the people who have got initially started. But otherwise, ESG, authentically, I can say it's almost 0% complications which happen. And comparing the total body weight loss, obviously ESG is better than balloon. But again, you cannot compare it because both have, of course, indications are same between class 2 and class 1 obesity, less than 40. But again, I think the wide way of choosing whether one person will go to a balloon versus ESGs, again, the binge eating habits, what they have. If they are binge eaters, obviously you will advocate ESG than balloon. And of course, the BMI between 30 up to 32, then balloon might be a better option.
So, Rakesh, there are these new balloons which are swallowable balloons. Do you think there is some excitement for that?
So the data is scanty and it's showing around 5 to 7% weight loss. Definitely much lower than the routine conventional balloon, number one. And second, it's only a 4-month affair. So after 4 months, what happens, nobody knows.
Third is the cost. Cost is significantly high in comparison to
currency is 3.5 lakhs.
The clock is showing only 3.5 minutes left, so we'll just two brief comments. One on a very important guideline on subepithelial lesions. So, Praveer, do you agree with the guideline overall? A specific question is GIST less than 2 centimeter, what will you do? Number two, FNA versus FNB, what is the choice? And do you do unroofing or deroofing technique ever?
Yeah, so I think FNA versus FNB, I don't think there is hardly any doubt in that FNB should be preferred. What they have mentioned is FNA only in the presence of rows. So FNB for sure. And about the GIST less than 2 centimeters, they have mentioned that these patients can be, the risk of metastasis here is too low. So that's the reason why I think which is what we see. For these lesions, these can be followed up for long, less than 2 centimeters, because the risk of metastasis is very less in these patients.
So my concern while dealing with subepithelial lesion is that we often talk of symptomatic lesion. And now when there is a bleeding, I can understand it's a clear-cut symptom. But most of the other symptoms, it's very difficult to attribute it to subepithelial lesion. So when you say symptomatic lesion, what exactly do you mean? There may be a dyspepsia, and you think there's a gastric lesion, and you say it's symptomatic.
I think the main things are obstruction and bleeding. Yeah, I mean, I think the non-specific, I mean, if it's an 8 centimeter gastric lesion and they have dyspepsia, well, yeah. But if it's a 2 centimeter, you can't.
My concern is because I have seen reports of pancreatic rest being resected, saying that it's a symptomatic lesion. It's very difficult to put a pancreatic rest as a responsible lesion for a symptom.
I agree.
Actually, you don't require any treatment for pancreatic rest. It's just you have to wait and watch and nothing to be done. Then in fact, the surveillance is not required. So what is more important is whenever a lesion arising from the layer 3 and you suspect this is a GIST, but it may not be GIST, it may be a schwannoma. So that's why the concept of the deroofing comes, because you do a stir procedure or you do a local resection, it is better to make a diagnosis prior to that and then proceed and you follow up these patients.
All right, we'll move on to the last presentation, which is on the lower GI bleed. And I think it's a guideline which is worth looking at. A couple of take-home messages. One is that we hardly use Oakland score. It has been there for quite some time now, but do you ever use Oakland score in your practice? And do you think that with this data, you will start using it at any time? So the second very important point is the change of algorithm. In my practice, for my approach, the first approach is always colonoscopy. And moderate bleeding, I would do a colonoscopy after a proper preparation. But this seems to be tilting more towards doing a CT angiography. And if the CT angio shows extravasation, go for angioembolization or angio-related procedure. But then even if you show an extravasation, some of the lesions can be easily controlled by a colonoscopy. So do you think that this is what you should be practicing, or you should have a colonoscopy first approach? Kapil?
So there's basically what we see is American guideline, but Japanese, they don't do CT. So they directly do colonoscopy. If patient is like even hematologically unstable, what they say is colonoscopy. In my practice also, if patient is is not very severely short on inotropes, better is to do a colonoscopy first.
So I think if you're planning to do an angio-related procedure, I think the message is very clear that you should never take the patient to a cath lab without wheeling him through the CT angio, because it will give you a lot of information as to which vessel to approach and what you're expecting. But exact algorithm where you put the CT angio. So do you think that you'll do a CT before colonoscopy in all patients?
Not in all patients, but it's really nice to have in the middle of the night.
When you don't want to go for a colonoscopy.
No, our radiologists are actually, if it's brisk bleeding, they're pretty aggressive now.
But I think the important message has to be that if you're doing a colonoscopy, it should be a prepared colon rather than rushing into doing a colonoscopy in presence of ongoing bleeding. Any comments there? Praveer? Yes, Vineet. Somebody can give him a... Yeah.
What is some...
Yeah, so we are talking of a specific situation where the patient is hemodynamically stable. I think there we will always, that means the patient is massively bleeding, you will not do a colonoscopy. But I'm talking of a moderate bleeding, we will not do a CT before we do a colonoscopy. That's what my message was. So I think we have run out of time. Thank you very much, Venisha, and thank you all the panelists for a useful discussion. So we are breaking for half an hour. Or we're breaking for about 15 minutes for a quick tea, and then we'll start the session again. So please come back in 15 minutes. Yeah. Yeah. Can I join?
Things about the American College of Gastroenterology. A lot of people have come up asking questions about the membership and how to advance to fellowship with the ACG. So we are very thankful that the American College of Gastroenterology and the leadership have agreed to do the best of ACG. And Dr. Goenka and I have been fortunate to be the course directors for this program. What you would want to know is that attendance at this meeting would be considered as attending a regional meeting of the American College of Gastroenterology, and hence when you apply for fellowship, this would meet one of the requirements. The American College of Gastroenterology is about 18,000 members strong, and as Dr. Goenka has said, about 1,000 of those members come from India, so give yourself a round of applause for joining this great organization and making it stronger by a diverse international presence. So the American College of Gastroenterology is a very old, preeminent institution developed in 1932 with a goal to advance the knowledge of GI disease, to educate specialists in gastrointestinal diseases, and to represent the interests of practicing clinicians, that is you who are here today in the field of gastroenterology. And our goal always is to ensure quality patient care. That's the purpose we are here for today, and that's why we are in this field. To promote patient education on gastrointestinal conditions and digestive health. And once you become a member, there are multiple resources on the website that you would have access to help your patients. The vision of the college is to be a preeminent professional organization that champions the evolving needs of clinicians in the delivery of quality health care that is evidence-based, compassionate, and the mission is to do scientific investigation, education, prevention, and treatment of gastrointestinal illness. As I said, there are about 18,000 members, and most of the members are represented by the governors, and that's how the system works. And we are fortunate to have Dr. Goenka, who is on his second term as a governor representing the India region and the needs of all of you here. We have an international relations committee, and you're more than welcome to join or write to them. They also give international travel awards to go and train somewhere else. We do have international affiliate societies, and I would like to see the name of India sometime soon. We have 2 ex-presidents here, so hopefully they will get India's name as affiliate society. Hopefully ISG will become an affiliate society one day soon. So if you become a member, you would get the Red Journal or the American Journal of Gastroenterology, which has a tremendous impact factor. Not only that, you also get Journal on Translational Gastroenterology, and for those of you who are in training and would like to publish important case reports, you do have a Journal of Case Reports, because for those of you in the business of publication, you know it's extremely hard to otherwise publish a case report. So we do have evidence-based GI journals, and this is the only organization that actually lets their members attend the annual meeting for free. The annual meeting this year, as you've seen from the prior slides, is at Vancouver, Canada. So you're all welcome, and hopefully we'll see you at the international reception there at Vancouver. So we do have multiple educational programs as well as a member benefit of the college. So there's an international training grant, as I've said, and I know at least one person from Hyderabad who was a recipient of this last year. There is research funding that goes on, so if you do have a pilot project or some research you would like to do, you are more than welcome to apply for research grants through the foundation. There is online training available, and we are now conducting ISG, ACG, combined virtual grand rounds and other educational programs. So you should be able to avail all those benefits as well. Not only that, there are also benefits from your patients and patient-related educational materials that you can access. And the ACG Smart Brief gives you a small news items in well-written capsule form, so you can probably read it on your smartphone while you're waiting for your elevator at work. So advancement to fellowship, this is the question that has been coming up and a lot of people have asked. So you need to have an uninterrupted membership in the college for about 5 years. And then you need to be proposed and endorsed by at least 2 members of fellows of the College of the American College of Gastroenterology. And there are several fellows of the ACG that will be happy to endorse you. Any of the faculty members here will be able to endorse you as well. Within the last 6 years, you need to attend a national meeting. You need to attend at least 3 regional meetings, and that is why this meeting comes into play, and important to scan your badges if you have not already done so, so we can submit your attendance to the college. You need to demonstrate some scholarly activities. Mere attendance at the meetings does not qualify for fellowship. And we need to have you show that you are involved in the activities of college. So please join the college, avail of the membership benefits, not just to you, but also to your patients, so that we can together advance the care of patients in gastroenterology. With that, I'm going to start the next session. While the speaker is getting ready, I would like to invite the moderator, Dr. Ajay Duseja, who does not need much introduction. He is professor and head of the Department of Hepatology at PGI Chandigarh. Dr. Anil Arora, who is at Sir Gangaram Hospital. Dr. Shiv Kumar Sareen, who is well known internationally and is probably, I will kill the rest of the day giving his introduction, so Dr. Sareen, and Dr. Yogesh Chawla from Chandigarh. So now it's my privilege to introduce my friend and colleague, Dr. Nancy Rowe, who's Professor of Medicine, Richard B. Capps Chair of Hepatology at Rush University Hospital in Chicago, and she'll be giving an update on hepatologies from this year's ACG meeting and what's published. Thank you.
Thank you so much. And I've really enjoyed this invitation these last 3 days, the incredible enthusiasm for ACG from the crowds, and the amazing food. So I am looking forward to offering you the liver disease summary from ACG 2022. I've tried to break this down into a handful of topics. I'm going to start with portal hypertension. So the first lecture, which was part of the presidential plenary, was offered by a trainee, and the goal of this was to look at comparisons of non-invasive ways of determining who might have risk for esophageal varices, which varices might be higher risk for clinical complications, and which individuals required upper endoscopy. Concept here is that varices do have high prevalence, especially in decompensated disease, but in those with compensated advanced liver disease, it's a little bit harder to determine who's going to have varices and who is not. If they do bleed, that offers significant morbidity and mortality, and currently upper endoscopy is the standard for evaluating the presence of gastroesophageal varices. They do have multiple scoring systems, though, that can help identify a patient at risk, as well as one that does not need an upper endoscopy because the risk is low. And because the rapidity or the rapidness of evolution in our therapies and the incredible publication rates, this has already been a little bit out of date because the Baveno 7 criteria were published after ACG 2022. However, if we look at the concept of a compensated advanced clinical liver disease, which is CACLD, we know that using a combination of stiffness score, liver stiffness score, and platelet count can identify low versus moderate versus high risk individuals. And using this concept, we know that if your kilopascal score from your liver stiffness study is less than 10, you really have very minimal risk for compensated advanced liver disease. And so this is a group of individuals that does not have risk for clinically significant portal hypertension. If you're in between this, between 10 and 15 kilopascals, here you're going to use your platelet score to add to that risk. And if the platelets are high, the risk is lower. And if the platelets are low, the risk is higher. After a score of 15, you're going to assume that you have compensated advanced liver disease. And if your score is above 25, you should assume that you have clinically significant portal hypertension in addition to advanced liver disease. So this retrospective study used multiple scoring systems to look at their accuracy and being applied to identify patients at risk or not at risk. So they used the Baveno criteria, which is a liver stiffness score greater than 20 with a platelet count of less than 150, and this is compared to the expanded Baveno criteria, which look at a liver stiffness score greater than 25 and a platelet count of less than 110, so a more advanced disease. They also look at the chest alarm score model, which is based on age, gender, platelet count, and liver stiffness. And then they compare that to two less accurate but easy to obtain studies, the APRI and the FIB-4. You can see from these diagrams that some of the scores did underperform, and one of the scores that underperformed was your sodium MELD. And so we can talk about what that means. Recognize that your MELD score often is looking at components of synthetic function and not portal hypertension. They found that of the scoring systems that they looked at, the Baveno 6 had a very high predictive accuracy to eliminate esophageal varices, which is what it was really designed for. If you look at the expanded criteria, now you have a very high accuracy to rule out esophageal varices that would require therapy. And it was the chest alarm score that actually highly predicted the presence of varices and the presence of varices that required treatment. Now, we have had over the last couple of days quite a bit of discussion around the Baveno 7 criteria. So the first and easiest thing is if in using these criteria, if you have a patient who is not a candidate for non-selective beta blockers and has a liver stiffness score greater than or equal to 20 and a platelet count less than 150, you need to do an upper endoscopy to determine if this person has clinically significant portal hypertension and if they would undergo band ligation, because this is, again, a person who cannot have non-selective beta blockers. If you have a liver stiffness score less than 15 and platelets greater than 150, you do not have clinically significant portal hypertension, and this is an individual that you would not start non-selective beta blockers because currently, we do not have data that suggests that starting a non-selective beta blocker would prevent the development of esophageal varices. If you have a person who is high risk, so liver stiffness score greater than 25, this is a good enough indication for clinically significant portal hypertension, and you should put this person on a non-selective beta blocker. In between these metrics, you can use the anticipate model, which looks at a liver stiffness score between 20 and 25 and platelets less than 150, or a more permissive liver stiffness score, 15 to 20, but lower platelets. And here you have about a 60% chance of clinically significant portal hypertension, which warrants the initiation of a non-selective beta blocker. They do recommend carvedilol as the preferred non-selective beta blocker, and they do state that you should consider giving a patient who has been identified at risk for clinically significant portal hypertension this non-selective beta blocker. And if you do this, you do not need an upper endoscopy because it would not change clinical management. And again, we can discuss whether or not we believe that that's true. It's also very important to recognize that in this scoring system, this is only relevant for patients who have viral, alcohol, or lean, non-obese NASH cirrhosis. Once you add obesity, your liver stiffness scores are going to be less accurate and probably not accurate enough to determine whether or not you want to base this person's risk on this scoring system and not upper endoscopy. All right, the next article or presentation that I'm going to focus on is anticoagulation and portal vein thrombosis. So here, the aim of this study was to evaluate the association between anticoagulation and outcome, essentially, recognizing that portal vein thrombosis is associated with significant morbidity and mortality, and that when you have a PVT in a patient who is at risk for bleeding, we are often very hesitant to anticoagulate. But it's important to put into context that the more advanced the disease by CPT score, the more likely a person is to have venous thromboembolism. Remember, your liver does both sides of your coagulation cascade, both the anticoagulation as well as the procoagulation. So on a patient who is more likely to bleed, they're also possibly more likely to clot. And when they did this systemic meta-analysis, they did find that the use of anticoagulation was associated with multiple favorable outcomes. PVTs improved, recanalization rates were higher, progression was lower, bleeding events were no different, but more importantly, there was a significant association with all-cause mortality. So the patients that were anticoagulated actually did better from an all-cause mortality, and this was independent of the performance of your PVT. This has also been not this group, but this has also been confirmed in another publication called Immortal, which is still in press, and this in Journal of Hepatology also demonstrates an improvement in all-cause mortality independent of PVT outcome in individuals who are anticoagulated with PVTs. So who do we anticoagulate? Well, there are some very easy individuals to identify. If you are non-cirrhotic and you have a portal vein thrombus, you should be anticoagulated. If you have an acute thrombus or a symptomatic thrombus, a significantly occlusive or progressive thrombus, or thrombophilia, you should also be anticoagulated. It's also pretty standard that if you have a PVT and you are being considered for liver transplantation, that you want to anticoagulate this individual, as progressive thromboembolism can sometimes preclude transplant or make it more difficult. You do not want to anticoagulate someone who is at high risk for bleeding. So this would include large varices that have not undergone band ligation, non-adherence, poor prognosis, and poor functional status. You certainly don't want to anticoagulate someone who's much more likely to have a bleeding event because they're frail and they fall. We do end up with a bit of controversy, though. When you look at a chronic portal vein thrombus with cavernous transformation, these tend to respond less well to anticoagulation, and in a person who is not a transplant candidate. So cavernous transformation, transplant candidate, you probably want to anticoagulate. Not a transplant candidate, here it becomes a little more controversial, and we can talk about this because there still might be a benefit in all-cause mortality. The next article or presentation I'm going to address is the use of terlipressin and risk of renal replacement transplant in the pre- and post-transplant period. So this study is a subset of the CONFIRM trial. The CONFIRM trial really defined HRS a little bit differently than what we do now. Remember, our hepatorenal syndrome criteria have changed in our newer guidelines, but when they put this study forth, they used HRS type 1, which was based on predominantly creatinine, in individuals who had not responded by volume expansion. They then triaged them to either receive terlipressin or standard of care, and terlipressin overall improved hepatorenal syndrome in about 20 to 40% of individuals, especially if you identify the individuals at an earlier time point. Because renal replacement therapy is associated with poor clinical outcomes and increased morbidity and mortality, both pre- and post-transplant, they were interested in this subgroup. It's easy to see from these graphics that the individuals who received terlipressin had less renal replacement therapy pre-transplant, but also less renal replacement therapy in the 1 year post-transplant, which is really important. But more importantly, although not a huge increase, there was a significant increase in mortality in those that did not receive terlipressin. So in the terlipressin group, there was a survival benefit of about 11% post-transplant. So they really emphasize that you want to identify individuals at risk for hepatorenal syndrome using our newer criteria and escalate those individuals for appropriate therapy, as it's going to increase not just pre-transplant outcomes, but also post-transplant outcomes. Now, Todd Frederick gave a great summary overview of hepatic encephalopathy. I'm just borrowing a few of the slides that he discussed. First of all, by our guidelines, when you have a patient who has hepatic encephalopathy, or HE, you have a four-pronged management, which means that you have to do four things simultaneously. You need to initiate care for a patient who has acute mental status changes. This means making sure they don't aspirate, making sure they don't fall, putting them in appropriate location, intubating them if they're really at aspiration risk. You need to search and treat for alternative causes of acute mental status, so don't miss those subdural bleeds, don't miss those other explanations. Identify and treat precipitating factors such as gastrointestinal bleeding, infection, SBP, and then you need to commence empiric HE therapy all at the same time, because a lot of our diagnosis is all going to depend on if you respond to treatment. So if you begin standard of care therapy and you have someone who does not clinically prove within 24 to 48 hours, we're going to start to worry that this is not simple, straightforward hepatic encephalopathy. Standard of care therapy is not really evolved that much. It's going to be based on lactulose or a disaccharide and antibiotics. And then if you do not respond to these, we have a number of alternative therapies which are definitely second line or not standard of care. And these do include some of our ammonia scavengers, microbial modulation, whether you want to consider that for FMT, and then a bunch of other things that we'll often use, such as zinc, albumin, even branched-chain amino acid supplementation. So just in a quick review, lactulose has very well-established mechanisms. It's going to acidify the colonic contents, which is going to prevent ammonia absorption by converting it to ammonium. But we also are starting to recognize that lactulose probably has prebiotic benefits, so that it does a little more than just act as a cathartic and acidification. Our antibiotics, and here we're going to use rifaximin much over flagyl or metronidazole and neomycin because of the side effect profile. Although we often think that this decreases the bacteria that produce ammonia, it may not actually decrease the microbial contents nearly as much as it changes the function. And so when we are looking at those phylogenetic profiles, we often find that the contents don't look that differently, but the function of the bowel is much different. And then there's also other aspects such as limiting pro-inflammation, cutting down neurotoxins, and other aspects. And so that we know from a very older study of the New England Journal of Medicine that really led to the approval of rifaximin, that if you start rifaximin along with lactulose, because the placebo arm as well as the rifaximin arm really were in the backbone of using lactulose, that you decrease a subsequent episode of encephalopathy as well as shorten hospitalization times. Now, our guidelines would tell us, and this is a little bit on the newer end, that if you're going to be considering a patient for TIPS, or if a patient has a TIPS, that there is no way of decreasing the risk of hepatic encephalopathy, so you should not initiate prophylactic therapy. However, a newer Annals publication actually argues against that. Looking at nearly 200 individuals that underwent TIPS procedure, they used rifaximin for 2 weeks prior and 6 months afterwards, and they really found a benefit in the population that underwent TIPS in episodes of encephalopathy. And if you look at their graphic abstract, you can see that using 2 weeks pre and 6 months post of rifaximin decreased the rates of post-TIPS encephalopathy from 53% to 34%, which is quite striking. Now, we don't always have the ability to give a patient 2 weeks of rifaximin prior to TIPS, especially if it's being done for, urgent esophageal bleeding. However, you can still capture that 6 months post. And if we think about our patients, we often imagine that if they don't get encephalopathy in the first couple of weeks, that we're out of the woods. But you actually can develop encephalopathy all the way up to 4 to 6 months post-TIPS, which is why they used that window of post-TIPS treatment. Now, I'm going to turn to non-alcoholic fatty liver disease. I think that it's already been outlined that this is an increasing disease across the world, not just in the United States. And one of the presentations really addresses the global aspects of NAFLD. So the Global Burden of Disease Study, or GBD, was initiated in 1992 to really do exactly what it says, to look at the global burden of disease across the world. They did not add NAFLD as a condition of interest until 2017. So they were a little behind the curve there because anyone that went to a clinic was recognizing that fatty liver disease was driving a fair amount of morbidity and mortality. This is a ICD-10 code-based study, and so we always recognize when we're using ICD-10 codes to identify something that that is wrought with some kind of error. But they used this to look and estimate the differences in the global burden of NAFLD between 1990 and 2019, and it's pretty striking, the prevalence as well as the contribution of death from NAFLD over this time period. And in addition to death, they also tracked the significant detriment in disability-associated liver years related to NAFLD, which means that our patients not only die at a higher rate, but they also have a fair amount of disability when they have fatty liver disease. This graphic, when you break it down by socioeconomic status or the country, is most impactful in our higher and our middle income socioeconomic locations, but it is not ignoring those of lower socioeconomic status. And you can see across our world map in 2019 that there are some hot spots. I actually think that everyone in my clinic has fatty liver disease, but you can see that the United States is not one of the areas of highest prevalence, although I would argue that I think that it is. And when they broke down globally where NAFLD is really having a significant toll, although they do find that the high, middle, and middle socioeconomic status countries are involved, it's really North Africa and the Middle Eastern regions are the current disease hotspots. So it's really important when we see things like this to know where we need to focus our interventions. Well, how do we focus our interventions? Unfortunately, in the United States and across the world, we don't really have any approved therapies for NAFLD. I know that here in India, you do have some, or at least one. But you can also use some of the other agents that you're using for the other metabolic abnormalities or other comorbid conditions. And in the United States, the 2022 ACE guidelines, which is the Association for Endocrinology, outlined how to address comorbid conditions in a more liver-favorable way. One of the things that they've emphasized is the use of GLP-1s. I think we've already talked a little bit about GLP-1s because they do have strong metabolic aspects as well as weight loss. And in our country, it only took Kim Kardashian and Elon Musk to outline the fact that if Hollywood and Elon want a GLP-1, probably all of us would like a GLP-1. Most of our patients, however, were already on metformin, and there's a fair amount of old literature that demonstrates that metformin has a strong impact on all-cause mortality as well as cancer rates in patients that have cirrhosis or fatty liver disease. We do not think that metformin has strong impact on steatosis or fibrosis progression, but it does have an all-cause mortality aspect, which suggests that there is something favorable about it. But this study's aim was to really see if the addition of a GLP-1 to metformin would increase that, beneficial aspect. And so they used a large database. They identified individuals with type 2 diabetes and cirrhosis, and then they looked at the group of individuals that was on both metformin and a GLP-1 versus just metformin, and they propensity score matched them so that they were comparable populations. You can see from the graphics that 3-year all-cause mortality was significantly better in the group that had both metformin as well as a GLP-1, and this is in type 2 diabetic cirrhotic patients. And then when they focused this more on those patients that had cirrhosis from NASH, it was a little bit blunted, but they still saw an improvement in 3-year all-cause mortality as well as rates of decompensation. And again, when you're looking at something from ICD code numbers, most of us would think that if I have a patient who's got type 2 diabetes and cirrhosis, that their type 2 diabetes has contributed to their onset of cirrhosis. And so I'm not so sure that the NASH subset is more accurate than just looking at the type 2 diabetic subset with cirrhosis. So this group did conclude that dual treatment offered an improvement in mortality and hepatic decompensation over 3 years, and would advocate that if the patient has indications for a GLP-1, that this should probably be added to their therapy. So in the ACE guidelines, they actually outline not just the use of GLP-1s, but also SGLT2 inhibitors in individuals with risk for fatty liver disease. And the SGLT2s are identified in patients who have higher cardiovascular as well as renal-related risk. And so the GLP-1s are really meant more for progressive liver disease and obesity, but if there's cardiovascular and renal risk, then the GLT2s start to have a more prominent role. So this abstract's question was really, are either of these agents associated with decreased progression or liver-related benefit, and would one be better than the other? And again, they used a large population database, so lots of patients, but again, identifying those patients by ICD code. And they pooled everyone with type 2 diabetes, NASH, and excluded other etiologies of liver disease as well as you can by using a coding system. So this gave them nearly 29,000 NASH patients with type 2 diabetes, of which 17.5% were on a GLP-1 and 13.2% were on a SGLT2, which is thousands of patients. About 43% did have a diagnosis of cirrhosis, which really emphasizes the aspects of using the ICD-10 code, right? In our practices in diabetics, 40% do not have cirrhosis. They certainly have cirrhosis in an enriched rate over non-diabetic patients, but not 40%. So this is a little bit of a skewed database. And then they did find that those individuals that were likely to receive a GLP-1 or SGLT2 were more likely to be Caucasian, were more likely to be young, and they did not find a gender-based difference. In the univariate risk analysis, they showed that both classes of agents were beneficial, and that actually the SGLT2 inhibitors seemed to have a stronger benefit, so lower rates of cirrhosis in the group of type 2 diabetics that received SGLT2. Now, this does not mean that giving this agent prevented cirrhosis. And it could be that the patients with type 2 diabetes that had higher risk for liver disease were less likely to have been prescribed an SGLT2. But either way, the key takeaway point was that both of these agents do seem to be liver friendly, as advocated by the 2022 ACE guidelines, and that in this, there seemed to be a stronger association with a lower risk of cirrhosis in SGLT2s, but that could, of course, reflect the bias of what someone might prescribe to a patient who has diabetes and cirrhosis. So the next presentation that I'm going to discuss is probably one of the more important presentations at the meeting, even though it didn't make a ginormous splash. So the aim of this presentation was to characterize genetic and metabolic risk factors associated with NAFLD and to look at the effect on disease progression across multiple age groups. To do this, they looked at a group of individuals, about 31,000 NAFLD patients identified between 2010 and 2021, and they called out two different things: prevalent cirrhosis, which meant cirrhosis found either at the time or within 1 year of diagnosis of NASH, or incident cirrhosis, which was a diagnosis of cirrhosis after 1 year from the NAFLD index date. So really how many patients had cirrhosis at the time they were identified as having fatty liver disease, and how many developed fatty cirrhosis after they were found to have fatty liver disease. They broke this down by groups of individuals that were 18 to 40, 40 to 60, and then over the age of 60, and there were some pretty striking differences. The first is if you were older and you had NAFLD, you were more likely to have metabolic comorbidities such as hypertension, hyperlipidemia, and diabetes. And if you were younger and you had fatty liver disease, you were much more likely to have class 2 or 3 diabetes. Cirrhosis rates were progressive, so 1.1% in the younger cohort, almost 4% in the older cohort, but 1.1% of 8,000 individuals between the age of 18 and 40 had cirrhosis. It sounds like a small percentage, but still, this is a large number of young individuals with fatty liver disease and concomitant cirrhosis that you have to, address now for multiple years. Genetics. Well, we already recognize that PNPLA3 is associated with fatty liver disease, and as you would imagine, that this was enriched in the younger cohorts. They were more likely to have that G allele, but all of the rest of the genetic polymorphisms really had no concentration by age. When we look at APRI, FIB4, and the NFS score to identify those that might be at risk for incident cirrhosis, so this is the cirrhosis, the time of prevalent cirrhosis, the time of the diagnosis, they found that these scoring systems were really only accurate or most accurate in that middle-aged group, because anytime you're putting age as a factor into your equation, you're going to bias that equation for accuracy. And so that these were the least accurate in our young cohort, but they were also less accurate in the older cohort. Now, incident cirrhosis, this is really what we really want to understand, right? Who's going to get sick and how quickly are they going to do it? Well, the most important message, I think, for the entire study was that the rate of onset of cirrhosis was no different in the young, middle-aged, or older cohort. Once you were identified as having fatty liver disease, your rate of developing cirrhosis was really the same across the age groups. And that's a little disheartening, because I think we would all love to look at someone who is age 20 with fatty liver disease and think that they don't have the opportunity to end up with bad disease until they're 60. But this would strongly argue against that. But they also did find some of the things that we would expect, right? If you have persistently increased liver enzymes, you are more likely to have progressive disease. If you had more metabolic comorbid conditions, you are more likely to have advanced disease. It's also important in this cohort of individuals that diabetes had the strongest association, because our European guidelines actually pull out those NAFLD patients with hypertension as the group that needs hypervigilance, because they feel that that is the most likely. Now, Mary Ranella gave an amazing talk at ACG over the drug development pipeline. I do not have the ability to repeat that talk because I was only given 35 minutes, but I do want to pull out a couple of different aspects. The first is our drug development can really target pretty much 3 areas in the NAFLD care pathway. First is metabolic comorbidities, or things that could increase the risk of developing progressive disease. Second, it can address fibrosis, so those that have very established disease and stabilizing or regressing fibrosis, or addressing the NASH components such as inflammation and steatosis that we know are going to increase the risk of developing fibrosis. Most of us recognize that fibrosis is the lowest hanging fruit, right? Those patients that have established fibrosis are going to have a higher risk of liver-related morbidity and mortality. And although these lines look kind of encouraging, if you look at the denominator, very rarely do we see an improvement over 10%. Sorry, we're on a timer. In these therapeutics. So some of the therapeutics that looked a little bit promising disappeared, but for the most part, none of our therapeutics actually improve fibrosis over about a 10 to 15% margin. When we're looking at NASH resolution, which we think probably drives fibrosis, here we see a little bit more success, with some of our agents having NASH resolution all the way up to 60%. But here you need to concentrate on the gray bars. The gray bars are the difference between the intervention and the placebo arm, because many of our fatty liver disease clinical trials have been impacted by strong placebo effects. And that you can see that the 2 largest interventions were semaglutide, or a GLP-1, as well as weight loss. And now it doesn't specify how this weight loss occurred, whether it's through endobariatrics or true bariatrics, but if you can lose weight, or if you are on a GLP-1, these probably have the strongest association with NASH resolution above the placebo. The last thing I'm going to discuss before we turn it over to our Q&A is drug-induced liver injury. And so Hari Priya Madur gave a great overview of her guideline from ACG, of which she's one of the authors, looking at the ACG DILI management, or drug-induced liver injury management. She pulled out not how to identify necessarily drug-induced liver injury. We have nice algorithms for that. I would encourage you to use the guidelines. At the very beginning, we break things down into either hepatocellular, cholestatic, or mixed. And it's important to remember Hy's law, which suggested that if you have a mixed pattern, you're more likely to have poor outcome from your drug-induced liver injury. But they wanted to answer a handful of questions. So first, is there a role for corticosteroid therapy? So when you have a drug-induced liver injury, the most important thing is to stop the drug of insult, but you want to make sure that you know that you're going to apply something that might help that patient stabilize and improve. And would one of those tools be steroids? Well, the guideline outlines that steroids really should not be a standard treatment for DILI unless there might be a subset of individuals that have DILI that exhibits autoimmune-like features. And so we can all think of things like minocycline, or I think you have an herbal, therapy that was used around COVID. These things caused a DILI that was autoimmune-esque. Higher enzymes, sometimes ANA, smooth muscle antibody, big globulin gaps, and they tend to respond better to steroids. Now, how do you know if you have autoimmune disease versus autoimmune-like DILI? Usually if you start the steroids and the injury improves, and as you taper the steroids or you stop the steroids, if it recurs, well, you're probably looking at more autoimmune disease. If it remains stable and doesn't recur, then you're probably looking at more an autoimmune-like injury from the drug, and usually you want to avoid reintroducing that drug in the future. Well, what about N-acetylcysteine? Because, as a hepatologist, we like to be able to give something, and NAC is something that we frequently recommend. And so the guidelines say that there are really no great trials that say that NAC is either a good idea or a bad idea, but given the fact that it's pretty benign in individuals that have drug-induced liver injury that's more severe, so they call out acute liver failure here, although I would add that acute liver injury probably is also acceptable, and that's where you have coagulopathy or coagulopathy with confusion, that NAC is probably a very reasonable alternative to try while you're considering transplantation. They do state, though, that you should not be using NAC in children. I don't think that's because of harm. I think it's just because of really lack of data and the fact that we don't like to do anything that might place our children at risk, and does not seem to avoid the risk for transplantation, and so you want to avoid it. So the last concept that they really talked about in this guideline for standard of the care, DILI, was to make sure that you do not blame the drug and when you're actually missing another explanation. And so most of the time we test our patients for hepatitis A, B, and C, but here also emphasize that you should be considering alternative viruses, such as hepatitis E. In the Dylan network, when they went back and they looked at possible hepatitis E, they found that about a third of the patients with what we thought was drug-induced liver injury at least had some evidence for hepatitis E exposure. That was hard to know in that network if that was really driving the drug injury or if it was acute hepatitis E, but you don't want to miss something that's different than a drug injury. Also, don't forget EBV, CMV, HSV, some of these other things. If you have a more cholestatic presentation, you really have to do good cross-sectional imaging or at least a very high-quality ultrasound to make sure you don't have something obstructive, because again, that's going to be very different. Now, the last injury I want to talk about before we move to the Q&A is hepatotoxicity from immune checkpoint inhibitors, and so this was a very nice systematic review and management recommendation. You can see here that these are the checkpoint inhibitors that are really addressed in the guidance in this document, because there are now multiple newer checkpoint inhibitors. It's very important, though, that irrespective of which checkpoint inhibitor, they use the same scoring system, which is outlined here, between mild, moderate, severe, and life-threatening. Life-threatening being where your ALT, AST, alkaline phosphatase, GGT, or bilirubin are 10 times or 20 times the upper limit of normal, and this is going to be a striking abnormality. And then they give a very nice algorithm that is kind of hard to see, especially from the back, but it tells you that, number one, if you think you have a checkpoint inhibitor, don't miss something else. So just like our standard Dylan, exclude alternative explanations. And then if you are left with most likely checkpoint inhibitor hepatotoxicity, you need to hold the checkpoint inhibitor. If everything gets better, you can actually resume the checkpoint inhibitor if it was a mild or grade 1 to 2 injury. If you have a grade 4 injury, which is at 20 times the upper limit of normal, or bilirubin 10 times the upper limit of normal, here you are much more likely to have an inpatient observation, frequent liver test abnormalities, and high-dose steroid therapy, and you are probably not going to want to give that same checkpoint inhibitor back. If you're in between here, they actually call out the role of liver biopsy in identifying a group of individuals that might need more aggressive immune modulation. And even here, you could resume your checkpoint inhibitor either at a different dose or as an alternative therapy, really depending on how well that patient did and how important the checkpoint inhibitor was. So steroid therapy, case by case, outside of checkpoint inhibitors where there's a nice standard algorithm. NAC therapy can be considered, but not in children. And remember, your immunotherapies are a newer field, and we're going to be learning more and more about them. So a couple seconds over, but this does give us time now for the Q&A.
Good evening, everyone. I'm sure you will all agree with me. I think Professor Nancy Rao has done a wonderful job taking us, through what's happening around the liver disease and what was presented at ACG 2022. I also will take this opportunity to thank Professor Goenka and the ACG for giving me an opportunity to be moderator for this session, and also for giving me, the stalwarts of hepatology as, the panelists with us. And I'm sure next 25 minutes are going to be a huge learning, at least for me, and I'm sure this is also going to be for you. I'll also try to make it a little interactive. You've all been sitting idle for last 2 sessions. I've seen that. So maybe you can give some mobility break to your vocal cords, and maybe we can start with some of the important abstracts and the papers and the guidelines which were presented by Professor Rio, Nancy. Okay. I think we can start with the first concept about, the portal hypertension and the new concept of cackled, which is coming up now. Cackled is, compensated advanced chronic liver disease. And by definition, we say cackled when the LSM value on FibroScan is 10 or more. So that is what the cackled is. And then the Bovino 7 has given those, saw that beautiful diagram, and where they are trying to determine the clinically significant portal hypertension based on that. So CSPH, we know that the gold standard is HVPG, which has to be again more than 10. But then there are surrogate markers for, CSPH, and one of them is that if you see varices on endoscopy, you see collaterals on imaging, and the other one is if your LSM is more than 25, this is kind of, you're ruling in CSPH. 10 to 15 LSM is suggestive. 15 to 20 is very suggestive, but more than 25, takes you towards, this is the concept of, cackled and the CSPH. Okay, now you're using this to see whether somebody has varices or not. So my first question to all of you, do you use this kind of approach in your clinical practice, or you straightway subject the patient to endoscopy to see whether he has varices or not? There is a school of thought within the country and, internationally, that why do all this and just do the endoscopy and see whether the varices are there? You are trying to look at the CSPH. So how many would you use this approach? Very few. How many will directly do the endoscopy? Majority. Okay, sir, so I'll take this first question to you. Professor Sareen, I think you have been part of Bovino 7 consensus. We are very lucky to have you here. So you saw the audience response here. They will directly like to go for endoscopy rather than do this, number one. So and then this model which she presented, the paper, chest alarm model, which in addition to the platelets and liver stiffness, they have just added age and the gender, male gender, to make it a little more, sensitive enough. So your thoughts on this model, your thoughts on using, liver stiffness as a modality to predict varices or varices needing treatment, number two. And the third question, again, for the sake of audience, the new concept here coming up is not only measure the liver stiffness, but also to measure the splenic stiffness. This is known as SSM. And now people are believing that splenic stiffness is probably even better than liver stiffness, in not only predicting the varices, but also looking at the dynamic things. You give beta blockers, you want to see whether the HVPG is coming down, splenic stiffness is better. You do TIPS and you want to see whether the portal pressures are coming down, splenic stiffness is better. Sir, your thoughts on splenic stiffness, this model, and the CSPH and cackled in general?
Thank you, Ajay. Thanks, Mahesh, and the ACG for inviting, and enjoyed your presentations, Dr. Nancy. I want to make simple things. First is the rule of 5, which was presented in Bovino and reproduced here. This rule of 5 is to exclude, not to include portal hypertension or CSPH. Fib 4 is to exclude advanced disease or not. So simple rules are that if it is less than 10, no question of having portal hypertension. If it is above 25, there may be portal hypertension, and highly suggestive if it is platelets are less than 100,000, even at LSM of 20. So generally these non-invasive markers are for exclusion rather than inclusion. 2 new markers and scores have come, actually 3. One was FAST, where you're using the FibroScan plus AST. The 2 new scores are Agile 3 and Agile 4, published by Arun very recently. Agile 3 includes all the markers, that is AST, ALT, platelets, but also includes age and diabetes. So remember these, for the first time, Agile 3 and Agile 4 give you positive diagnosis. So when you have these markers, non-invasive markers just of LSM, you are not going to gain much. And my personal feeling is they are very unreliable when the patient is obese and he loses weight. So Bavino says use at least 2 times the LSM. Number 2, if it is more than 10, be careful. If it is obese, so all those other things have to be done. Now coming to the SSM, I think it's the best thing that has happened. The splenic stiffness measurement is very reliable. Bavino clearly says above 50, clinical significant portal hypertension. It does not say, but it is proven, below 32, no varices. So if you have SSM, I would be more happy with SSM because there is no fat, there is no other issue. But on LSM, I have my own concerns. Now, one more slide which you showed very well is when to start beta blockers or not. And I'm not touching that part, but just to tell you, if the patient is on beta blockers, LSM does not decrease much, but SSM decreases significantly.
Absolutely. Yeah. Thank you, sir. I think I would say we have had, very nice papers and very nice information given by Professor Nancy. So I think we need to move on. I think probably you got some concept about SSM, LSM, CACR, CSPH. So the next paper she presented was on, anticoagulation in patients with cirrhosis and portal vein thrombosis. In the acute setting, again, the indications are pretty clear. Anybody who's symptomatic, being planned for liver transplant, I think you probably would do. But she also mentioned something about, chronic PVT and choosing anticoagulation, on case-to-case basis. Nancy, the kind of chronic PVT, what we see here in children is EHPVO, which is majority of the time is, idiopathic. But then we do use, procoagulant workup in them. And if somebody has that, we do use anticoagulation in them. So my question again to the hall would be in EHPVO, which is typically idiopathic, whether you would like to do a procoagulant workup in them, yes or no? Very few, okay. So how many of you will not do any workup in EHPVO or idiopathic chronic PVT? Again, I think mix of this thing. So will you use anticoagulation in chronic PVT, which is EHPVO, I'm saying idiopathic, not the adult variety of chronic PVT. Will you use anticoagulation there? Okay, nobody would use. Okay, so the other issue which is now coming up with, the PVT and cirrhosis is the utility of, these oral anticoagulation, are a little difficult in the sense that you need to monitor, INR in them. Sometimes the dietary intervention can be an issue, elderly, there could be a problem. So now we have a new generation which are known as DOACs, directly oral anticoagulation, which has come up. But their safety and the efficacy in the setting of liver disease is not very, very clear because most of these would be excreted from the liver, except maybe dabigatran, which has maybe around 20-25% excretion by liver, and the rest of it is renal, but others are liver. So I think we don't have much data, but people would say that you can use them in maybe in child A and early B, but you can't use them. But the beauty of DOACs is that you don't need any kind of, monitoring in them. So that's it. So maybe I'll go with the next question to maybe Professor Chawla on this. Sir, again, your thoughts on using, anticoagulation, leaving aside the acute, PVT, where, as I said, if somebody is symptomatic, we would definitely use prior to transplant. In the chronic PVT, any scenarios where you would like to use anticoagulation? Maybe something like acute on chronic PVT, or your thoughts on usage of DOACs in this kind of setting? Yeah.
See, the chronic PVT as such in EHPVO, the role of anticoagulation is very limited. Unless the prothrombotic workup is positive or the patient gets symptomatic for intestinal ischemia. But you also have situation where chronic PVT happens in cirrhotics. This is one condition where the prothrombotic workup needs to be done. You may not give anticoagulants if the patient is asymptomatic, but if he has evidence of superior mesenteric vein involvement or any other thrombosis, anticoagulants need to be given. One important situation in clinical practice would be when these patients of cirrhosis come with upper GI bleed. What do you do then? I would say that you should do banding in these patients first, hold on with anticoagulation, see the course of action, and if it is required, then do a TIPS, remove the thrombus from the portal vein, and that will, and then put the patient on anticoagulants. So that will prevent any bleed coming up because of the esophageal varices ulcer.
So any thoughts, sir? Yes, please, sir.
Yeah. This is just to brief you. There was a huge debate in Bavino, just to continue what Professor Chawla said. And the debate was, can you give anticoagulants when a patient has bled or is likely to bleed? Surely the answer is, if the patient has bled, manage. Like yesterday he has bled and you find there is a PVT, you do banding. But immediately after banding, the next day you can start the anticoagulant. Either you can do oral, but preferably low molecular weight heparin. And it has been shown, in fact, there are large number of trials. That's number one. Number two, I would like to ask opinion of Dr. Nancy. Patient has large esophageal varices and has a occlusive portal vein thrombus. Whether we can give, whether you need to do a EVL before you do DOAX or Clexane or not. The Bavino says that you can go ahead and start anticoagulants. There is no need to worry on the large high-risk varices, but you showed data or maybe an abstract that large high-risk varices must be handled first and then PVT. So I would like a debate. It is in everybody's mind. What is your?
So I think that when you have a guideline like the Bavino 7, and we have another guideline from another society that really emphasizes when you have an identified PVT, the first thing you do is cross-sectional imaging. If you see evidence of portal hypertension, you should do a scope, and if you see large high-risk varices, you should address those varices first before anticoagulation. That really reflects the debate, right? It means that there isn't pure consensus, and we don't have a double-blind, well-controlled trial to tell you which is a good idea and which is a bad idea. So you're going to be forced to look at the patient in front of you. And I would be very nervous anticoagulating someone with large varices and a completely occlusive clot. And this might be someone where I emphasize trying to do mechanical thrombectomy, TIPS, or some type of intervention, and then anticoagulation, because I'm nervous. Is that the right answer? Not necessarily. And if you have someone that decompensates from their TIPS and has a complication when you may not have had to do that, you're going to worry that your decision path was probably not a good one.
I think, can I come in?
Yeah, please go ahead. Yeah.
Nancy, you presented a very nice slide which showed a very precarious balance between procoagulants and anticoagulants. And if you look at this slide carefully, there are two factors which go up routinely, rest everything plummets down. And these include VBF, that is 1 Willebrand factor and factor 8, and D-dimer. These are two things which go up, everything else comes down. In fact, if you look at the natural history of portal vein thrombosis and cirrhosis, if you just do nothing, 1/3 of them will spontaneously resolve, 1/3 will remain static, and 1/3 will deteriorate. So if you have large varices, as a clinician, I'll make all efforts to eradicate it, because you are getting time for the natural resolution to go away. Because every time you tend to anticoagulate, because you are sitting on a fence, if the patient has bleeding, because of the anticoagulation provided by you, you are going to have problems. So in such a situation, I'll prefer to put the patient on beta blockers and band it, and that gives me another 2 to 3 weeks to observe. In case the patient continues to be symptomatic, if his liver function deteriorates because of the progression of the thrombosis, then you are justified, otherwise you can wait.
Thank you. I think we move on from here. I think if you have any burning questions or issues, I think, or comments, I think you're most welcome. We are trying to be as, practical as possible, and trying to discuss in the Indian context, these papers. So, no, then she showed, paper where she showed 12-month follow-up of the confirmed trial. Confirmed trial was the usage of terlipressin in patients with, HRS-AKI. So in there, now the follow-up shows that the requirement of renal replacement, pre-transplant and post-transplant, and the reversal of AKI is happening better with terlipressin. This is what I'm pretty sure they used albumin with that. I think that was not mentioned. The only thing was in that particular study, they had given terlipressin as boluses of 1 milligram, maybe 4 hourly or 6 hourly. So how many of you would use, now there's a concept of, infusion of terlipressin which is coming in now. So how many of you use terlipressin as bolus or infusion, any preference? So how many use bolus? Largely. And how many infusion? Maybe equal numbers. That's good. So, okay. So again, I think my question to maybe Dr. Arora, you can take it up. Yani infusion versus bolus, I think that would be a practical question. And then the differentiation of, HRS-AKI versus ATN and the use of, various biomarkers, NGAL and various others, clinically, practically for the audience, if you can just tell us that.
I think this is a very important issue. As much as we keep discussing on paper that we have to be able to distinguish between pre-renal, renal and the HRS, on practical terms it becomes very difficult. Unless there are obvious factors like overdose of diuretics, persistent vomiting, dehydration, or excessive use of the NSAIDs, to distinguish between early phases of AKI because of the ATN or AGN versus HR is not easy. If you look at the last 15 years, there have been so many molecules which are coming into being to distinguish between the two. Or they only tend to give you a cutoff of low level, moderate level, and high level. Only inference you have from this urinary NGAL is higher the level, more the structural damage. That means if there is an ATN, you are going to have the highest level. In HRS, you will have the intermediate level. But I don't think any of us uses it for distinguish between the two. Right. We simply go by the protocol that if you have replaced fluid, if you have stopped the offending agent like diuretics, or if you have corrected the dehydration, replaced the volume, if the patient does not respond, in presence of a normal urinary sediment, almost always it is HRS. To diagnose AKI on the basis of ATN or AGN on the basis of urinary NGAL, I think is more of a theoretical position. I like to know from audience how many of them use this marker.
How many of you use NGAL as a biomarker in differentiating, ATN versus HRS AKI? How many? None. So nobody uses. Sir, yes. So, okay. So I think we can move on, and she had, we have just left with around 8 minutes with us, and, she had presented large studies on fatty liver disease, mainly NAFLD. And the first thing which she had shown about the global burden of study, just for you, the prevalence in India of fatty liver disease is also close to around the meta-analysis of 50 studies shows it's 38.6%. And this is in adults. And in children also we have meta-analysis, same study, 35%. And this is, a population of around 50 studies, 25,000 patient meta-analysis. So India probably would also figure somewhere there the figures which you were showing. The only thing we don't have the incidence data from our country, that what is the per year, new cases which are coming in, but we do have information on cirrhosis and liver cancer where the NASH related, HCC and cirrhosis is going up. So beside the point, I think two beautiful studies which she had shown is, one is the usage of metformin and GLP-1, agonist in treating patients with cirrhosis, with diabetes, right? And if you know, again, in NASH cirrhosis, we don't have any pharmacotherapy which is approved. For that matter, even in NASH, we don't have any pharmacotherapy which is approved, but for SARO, which is approved in India. So, but there are two, studies from Dr. Nagachalasani's group where they had shown retrospective studies, the usage of vitamin E, which reduces the risk of decompensation, and your requirement for liver transplantation, and the usage of metformin, which again had shown and even had reduced incidence of HCC in them. So now this study, particular study, had combined GLP-1 agonist, SAMA, LIRA and all that, with metformin, and where they had shown it to be beneficial. Dr. Arora, your thoughts on this combination? First of all, using any kind of pharmacotherapy in cirrhosis, number one, and then this combination of GLP-1 and metformin, in tackling cirrhosis, NASH cirrhosis.
Yeah, Ajay, these are both brilliant studies presented by Nancy. But the caveat is that the baseline diabetes is the cause of the cirrhosis.
Yes.
We are not talking of NASH-related cirrhosis. So by default, you have diabetes as an underlying etiological factor which is resulting in cirrhosis. All of us know the cardinal drug and the most important agent for pharmacotherapy of diabetes is the metformin. We still do not know how it acts, but this is the drug which has been shown to be consistently of use in these patients because it is an insulin sensitizer. Now, over and above, if you add another drug which will not produce hypoglycemia, will try to control the diabetes as well as the resultant effect of the control of the diabetes, so you will have a better prevention of complication of cirrhosis. So I think it is not directly causing effect on the liver, it is through the indirect good control of insulin sensitization which is giving you the benefit. So it makes sense,
Sure.
You are combining agents which are increasing the insulin sensitivity by different mechanisms.
Yeah, Professor Serene, please. Yeah.
Yeah, so a patient who has cirrhosis and diabetes is a difficult, there are no drugs.
Right.
So one of our very good student, Tanmay, did a thesis and was presented oral at ASLD. So patients who have got cirrhosis and diabetes received metformin or a placebo. There was a significant reduction in portal pressure by about 4 millimeters, number one. There was an improvement in fibrosis score. And thirdly, and very importantly, the platelets count increased. So, and we routinely use it in our practice, metformin in patients with cirrhosis and diabetes. Number two, it also, its major activity is a stellate cell silencer. So it will improve your fibrosis. But the paper of GLP-1 is a very good study, and I think it's the future. But we have to first use GLP-1 independently in cirrhotics and diabetics. We don't have enough data. So if you have GLP-1, like semaglutide in cirrhosis, now the new studies, if we can show there is a reduction by semaglutide or any other thing, and combining with metformin, I think it is the way forward. For prevention of development, SGLT2 is good, but not once cirrhosis has developed. And one more slight point which you asked in the beginning, Ajay, was compensated cirrhosis versus advanced chronic liver disease which is compensated. These are two independent entities. Compensated cirrhosis you can use for any, whether Hep B, Hep C or alcohol or whatever. But the other one, advanced chronic liver disease which is compensated, is generally for NAFLD group of patients.
I think the other paper was, which is again very important paper, I must say, where the paper was the lower risk of developing cirrhosis in diabetes, those who were on GLP-1 agonists or SGLT2 inhibitors. SGLT2 inhibitors are, gliflozins, empagliflozin, dapagliflozin. I think that's very, very, good concept. And if you look at the paper on SAMA and NASH, which actually showed the highest resolution of NASH in comparison to placebo, 59% versus 20%. And if you look at the recent ASLD 2023 guidance paper on NAFLD, what they say is that if the patient has NASH and if is a diabetic or is obese, you can even choose semaglutide in treating NASH in them. So again, I think the question to the panelists would be, I think if somebody is a diabetic or obese, again, no recommendations, no approvals, but then I think these drugs, SGLT2 inhibitors and GLP-1 in preventing the occurrence of cirrhosis, I think that's what.
Yeah, there is no doubt that these drugs are effective in reducing fat. But can they reverse fibrosis? GLP-1 or SGLT2 is a question which is open. Metformin definitely reduces fibrosis. But the other two drugs reduce fat. And that is why the emerging concept of MAFLD, metabolic associated dysfunction associated fatty liver disease, which includes obesity, which includes diabetes, is worth consideration, because you give one physician gives drugs for the combined thing. But I think we need to move forward by using SGLT2.
Another advantage of SGLT2, Ajay, is when this is preventing the absorption of the glucose from the renal tubule.
Right.
At the same time, you also preventing the absorption of sodium and water. Indirectly, you are benefiting hypertension. Since all these things have bidirectional link, diabetes, hypertension, NAFLD, so I think it is an excellent drug with a lot of future.
I think we are done with the time, but the last topic was the DILI and the hepatotoxicity with, the immune checkpoint inhibitors. Maybe Professor Chawla can tell us. We see more of ATT, DILI or maybe CAM-induced DILI, but how many of you see the immune checkpoint induced hepatotoxicity? How many of you use immune checkpoint inhibitors for HCC? So very few. So obviously, I think the DILI, because of immune checkpoint inhibitors, is not a major issue with us. But sir, if you want to say anything on DILI, if anything, yeah.
Yeah, that was an excellent paper where they said that steroids could be useful if there are features of autoimmune following drug-induced liver injury. But by and large, we don't see very often autoimmune features when we have these patients with DILI. Giving them steroids doesn't help. So that is a big question mark how to manage these patients. But certainly if there are features of autoimmune, steroids will work.
So I think thank you very much, Professor Nancy Rao. I think wonderful presentation. I'd like to thank all the panelists and all the audience for this. Thank you very much. Thank you. Thank you.
Thank you, Dr. Nancy, Ajay, Dr. Sareen, Dr. Chawla, Dr. Arora, for a nice discussion. We have to move on, and for the next session, we have pancreaticobiliary, and I would invite Dr. Ajay Kumar, the chairman and HOD of BLK Max Institute of Digestive and Liver Disease, New Delhi, to come and moderate the show. Dr. Ajay Kumar, please. And I would also request our esteemed panelists, Dr. Anup Saraya, HOD, Department of Gastroenterology, All India Institute, Dr. Pramod Garg, Professor from All India Institute again, Dr. Ashokanand Konar from Kolkata, and Dr. V.K. Dikshit, Department of Gastroenterology, BHU, to join, and Dr. Nalini Guda will deliver the lead talk. Dr. Nalini.
Good evening again, everyone. In the next 30 minutes or so, I'll be giving an update on the biliary and pancreatic diseases that was discussed or was published within the last year in relevance with what we decided to talk. So pancreatic disease and biliary disease obviously is a vast subject, so I've broken down for the interest of discussion into acute pancreatitis, and we will go over what would be the risk factor for pancreatitis and what is the long-term effect of pancreatitis in terms of pancreatic cancer risk. Is there a way we could predict pancreatitis? Is pancreatic fat a predictor for pancreatitis, and is there something we could do about prevention? We know that pancreatic necrosis causes short and long-term pancreatic duct disruption. We will talk about the effects of pancreatic duct disruption, both long-term and short-term. I know you just heard about GLP-1 receptor agonists and inhibitors and what is the role of GLP-1 receptor inhibitors on pancreatitis. And when you do necrosectomy, which is a safer method, obviously there are various ways to do it. In chronic pancreatitis, the one thing that was new was, is there a way you could predict exocrine pancreatic insufficiency by a non-invasive way? We'll review the data on that study. Pancreatic cysts are very common. Especially with increasing imaging, you're seeing more and more pancreatic cysts. Differentiation of pancreatic cysts between serous or benign cysts into mucinous or potentially malignant lesions is still a challenge. And do we have a better biomarker than what we have today, which is the CEA? And I will look at the data on that. Pancreatic cancer remains a potential problem. It's increasing in incidence. We do screen patients for high-risk pancreatic cancer now. Are we doing this right is a question that I always have in mind, and I will show you what data were presented. Now, for those who have locally advanced pancreatic cancer, is there something we can do other than just saying just take chemotherapy and palliation? Can we do something as endoscopists? And I'll show you the data on radiofrequency ablation. Choledocholithiasis is a common clinical problem, and those who have recurrent choledocholithiasis tend to have a higher recurrence of choledocholithiasis. And we will review the data whether endoscopic large balloon pancreatic biliary dilation would have any effect on recurrences. Biliary strictures, diagnosing indeterminate biliary strictures is a challenge. What we have is a simple tool that is brushing the stricture, and there are some data to see if doing more brushings might be helpful. And when you have orthoptic liver transplants that are being done more and more often now, more centers are doing it. I know in India there is more living donor liver transplants. How do we deal with leaks and cysts, which are often resistant to endoscopic therapy? Going on to the first paper, the acute pancreatitis recurrences, what is its impact on pancreatic cancer? Animal studies show that inflammation is a major risk factor for pancreatic carcinogenesis. And the aim of the study was to look what the etiology of acute pancreatitis was and is there an effect of etiology and development of pancreatic cancer. Is one recurrence versus 2 or 3 attacks, does it make a difference? We will look at that data as well. And is it just that the pancreatic cancer develops because we all know acute pancreatitis to chronic pancreatitis to pancreatic cancer is a continuum. It's a retrospective study that was done in the Veterans Affairs Hospital between 1995 and 2015. So what the investigators have done is, because we know sometimes acute pancreatitis presents as pancreatic cancer presents as acute pancreatitis, they took a 2-year washout period so they do not murky the water or the data. And then they did the risk factors and did the estimation of what the risk is. So here it's a busy slide, but it shows you that those who developed pancreatic cancer in the acute pancreatitis group, which is about 27,000 patients, acute pancreatitis on chronic pancreatitis, which was about 8,000, and you have chronic pancreatitis group and the controls, which is about 7 lakh people. So if you look at those who had developed pancreatic cancer, the acute pancreatitis cancer group had about a 0.49% risk of development. But if you look at the group with acute pancreatitis on chronic pancreatitis, the risk goes up by about 1.13%, which is higher than those who have chronic pancreatitis alone, as opposed to the controls here, which is quite low at 0.23. So clearly the group here that has acute inflammation over underlying chronic pancreatitis or acute recurrent pancreatitis seems to have a higher risk of cancer development. And this is a graphical data that shows the same. This is acute pancreatitis on chronic pancreatitis here in blue. Those with just chronic pancreatitis and the baseline. So clearly this group seems to have a higher risk. So when they looked at the number of episodes, is it 1 episode, 2 episodes, 3 episodes? Clearly as the number of episodes increases here in the left, then the risk also goes up significantly, which is statistically significant at greater than 2 and greater than 3 episodes. So clearly, here is the green mark that shows greater than 3 episodes of acute pancreatitis. The risk of pancreatic cancer goes up substantially. So when they looked at the effects of smoking and alcohol, that did not really cause any significant increase, though we all know smoking causes chronic pancreatitis potential risk. In this study, somehow the data did not show anything. So those of you who read the Red Journal, it's very clear. They tell you what you know and what you do not know and what is probably new here. So we know from animal studies that acute inflammation promotes pancreatic carcinogenesis. Acute pancreatitis is not always just inflammation, especially when you do not know the etiology. You should always suspect underlying pancreatic cancer. What is new in this study is that etiology does not influence the development of cancer. So whatever the cause of pancreatitis, it did not matter. What mattered is that the number of episodes as they increased the risk of cancer, and those, especially with chronic pancreatitis, that we tend to ignore and say it's just the chronic pain and it's probably not acute inflammation, seems to be that is the group that we probably need to pay more attention because they're at higher risk of development of pancreatic cancer. Now, the next study is looking at intrapancreatic fat deposition as opposed to liver and skeletal muscle and what its impact is on the development of acute pancreatitis versus healthy individuals. So again, we know there are some data that shows the increased pancreatic fat deposition is a harbinger or a risk factor that's predictive of pancreatic cancer and chronic pancreatitis. So this study looked at seeing fat depositions in the pancreas, and as comparison, they looked at liver and skeletal muscle, and compared those with first attack of acute pancreatitis in healthy controls, which is your healthy individuals were the controls. It's a matched case control study that was done, and all the intrapancreatic fat deposition was measured by a 3 Tesla MRI scanner, which is readily available. So when they looked at it, 50 individuals with first attack of, again, non-necrotizing or interstitial pancreatitis were the ones that were evaluated. And what this study noted is that if there is a 1% increase in intrapancreatic fat, then there is a significantly high risk, a 30% or higher chance of developing a first attack of acute pancreatitis. So it probably tells us that if somebody has a fat deposition that is high, that it is predictive of those patients developing pancreatitis, and also potentially we could come up with some intervention to reduce the intrapancreatic fat, thereby reducing the risk of pancreatitis. So there is here probably a potential opportunity for us to intervene, though I do not have any drug or intervention yet, but that's the food for thought. So again, just like our liver fibrosis and cirrhosis models, here is reversible fibrosis that happens, and here is irreversible. And this study actually looked at this subset of pancreatic inflammation and pancreatic fat deposition. So what we know again here is acute pancreatitis, chronic pancreatitis, and pancreatic cancer are a continuum, as we talked about. And it looks like increased pancreatic fat deposition has a significantly high chance of development of pancreatic cancer, about 30% higher risk compared to controls. And if you compare pancreatic fat deposition compared to liver or skeletal muscle, it's not the liver and skeletal muscle, but just only the fat deposition in the pancreas seems to contribute to it. So it seems to be that there is some potential pathogenic process that goes on. And potentially this is a biomarker, and we potentially could have some intervention in the future. So we talked about pancreatic necrosis that causes pancreatic duct disruption. This is a study from the Dutch Pancreatitis Study Group, and those of you who are in the pancreatitis business, you all know that Dutch group does very robust studies. Again, they looked at both short-term and long-term effects. It's a post-hoc analysis that was done on about 896 subjects that were followed over a period of 10 years. And the pancreatic duct disruption was seen in a quarter of the patients. About 27% of the index group of 890 patients or so developed disconnected pancreatic duct. The problem with disconnected pancreatic duct diagnosis is that we do not have a universal or uniform method of diagnosis and measurement, and we routinely do not look for it. But when they looked at the risk factors to see who is the patient who comes to you with necrotizing pancreatitis, and there's a way to predict, it shows that there are two factors that have stood out. That's if you have central or subtotal pancreatic necrosis, or you have a CRP level at 48 hours that is high, your risk for development of a disconnected pancreatic duct is very high. So what is the clinical implications? Why do we need to know? For prognosis and prognostication and seeing how your patient does, I think it's important. And if you look at the data, the ICU admissions, need for interventions, new onset organ failure, persistent organ failure, all were significantly higher in this group. Again, this is the flow chart of the study. As I said, a fourth of them did have confirmed pancreatic duct disruption. And I cannot highlight enough the ICU admissions, organ failure, infected necrosis, interventions, readmissions, everything has gone up in this group with disconnected duct, and hence the reason that it might be important for us to recognize this syndrome. So again, central or subtotal pancreatic necrosis is important. So next time you look at a CT scan, there's pancreatic necrosis, you probably should look at the volume of pancreatic necrosis and where exactly in the pancreas is the necrosis. So when long-term follow-up is done again, as I said, the recurrent pancreatitis and chronic pancreatitis adjusted odds ratio also go up. And not surprisingly and intuitively, the endocrine pancreatic exocrine and endocrine pancreatic insufficiency also was higher in this group of individuals. So what is new here, that at least 1 in 4 patients with pancreatic necrosis have disconnected pancreatic duct, and central and subtotal pancreatic necrosis on imaging do help you identify those who are at risk of developing disconnected pancreatic duct. And the other potential biomarker is to look at the serum C-reactive protein levels at 48 hours. And clinically, when a patient has disconnected duct, they have both long-term and short-term outcomes that are worse than those who do not. So predictors of pancreatitis on initiation of GLP-1 receptor agonists, we talked a lot about GLP-1 receptor agonists in the last session. So more and more patients are taking it. Obesity is now a pandemic. And the problem is that when patients are given these drugs, before giving them, is there a way you can predict pancreatitis? Because pancreatitis can occur in these individuals, drug-induced pancreatitis. So when it's a retrospective study that was done, and when you looked at the patient characteristics, medical comorbidities, and everything else, and a regression analysis was done, 2,245 patients were looked at, and of those who received GLP and had pancreatitis, it's a very small group, only about 2% developed pancreatitis. But if you look at those patients and see what the risk factors are, it looks like those who have type 2 diabetes mellitus have a high odds ratio of about 2.95. Concurrent tobacco use also is a significant risk factor, and advanced CKD is a risk factor. So if somebody comes to you and you want to start them on a GLP-1 drug, you need to know that this particular group of patients is at a higher risk of development of pancreatitis. So if you do start them on the medication, you probably should not ignore any symptoms that the patient complains of. So it's a potential way for you to identify who is at particular risk. We all know endoscopic necrosectomy is what most of us are doing these days, especially with the lumen-opposing metal stent. But there are other ways to do necrosectomy, surgical necrosectomy and IR or percutaneous necrosectomy. So again, the only reason I chose this paper is that it received the interventional endoscopy outstanding research by a trainee. So those of you who are trainees, you can do these kinds of studies. And this is a national inpatient database. So when you look at a database and do analysis, you do not get granular data. You cannot tease out and come out with finer details, but you get a 30,000 feet bird's eye view of what's going on. So when this was done, not surprisingly, only a third of those patients with necrotizing pancreatitis did undergo endoscopic pancreatic necrosectomy. The inpatient mortality was much higher in those who underwent surgical necrosectomy as opposed to interventional radiology, which is in the blue graph, and the green line represents those with endoscopic intervention. And again, if you look at the hazards ratio, much higher for the surgical group, lower cost and length of stay for those who undergo endoscopic intervention. Again, I cannot tease out the data and give you finer details, but that's what the trend looks like. So switching gears to chronic pancreatitis, we talked about, is there a way that we can predict chronic pancreatitis, or say that somebody who has got what you suspect as chronic pancreatitis has some pancreatic insufficiency? And right now what we do is the endocrine pancreatic endoscopy, pancreatic function test, where you do endoscopy, you go into the duodenum and look at the peak bicarbonate excretion. And here the rationale for the study is to see if fibrosis reduces pancreatic secretion, and whether when we do endoscopic ultrasound, you can do elastography and look for the fibrosis and predict the exocrine pancreatic insufficiency. This is a study that was done. They looked at the strain ratio on endoscopic ultrasound, and those with chronic pancreatitis were diagnosed with a low peak sodium bicarb excretion of less than 80 milliequivalents per liter. So 61 patients were analyzed, and it looks like if the strain ratio is higher of about 3 or so, you could predict exocrine pancreatic insufficiency. So we probably have a potential way to predict exocrine pancreatic insufficiency in those who we suspect chronic pancreatitis, because we know there is no good way. Even those who do endoscopic ultrasound, it depends on the day they're scanning. They say, yeah, maybe chronic pancreatitis, maybe not. Unless you definitely see calcific pancreatitis, is hard to say, but this is a potential way for you to look at strain ratios and say somebody is at risk for exocrine pancreatic insufficiency, and hence maybe do some intervention or start them on replacement therapies. So the elastography, based on this study, has a very high sensitivity and specificity, about 92% and 100%. Positive predictive value is very high. So based on this small study, the numbers look very impressive. Obviously, we need larger data, more studies to validate it and see if this is true in all groups of patients and populations. Pancreatic cysts are challenging for diagnosis because it is a significant stress on the patients. Patients feel that whenever you say you have a pancreatic lesion, they think they should go and write their will because, pancreatic cancer is quite a deadly illness, and it causes a lot of stress to the patients. We get several phone calls every day the minute they were told that they have a 5-millimeter cyst in the pancreas. So cysts are commonly identified, and all the guidelines right now suggest that you stick a needle into the cyst, aspirate the fluid, and see if they are mucinous or non-mucinous. And so far we have been using CEA, about 192 nanograms per deciliter as a cutoff to see if this is mucinous or non-mucinous. And intracystic fluid glucose seems to be a promising biomarker, and this was based on frozen specimens. They did not have any histological diagnosis in the initial studies. So this study looked at a multi-center cohort consisting of patients who underwent endoscopic ultrasound and fine needle aspiration over a period of 7 years, compared them with the histological specimens and compared them to see what the results are. So 93 patients, of whom 59 had mucinous neoplastic lesions, met the criteria. And when you looked at the receiver operating curve for glucose, it's about 0.96 when the glucose levels are low. These are statistically significant when you compare it with the CEA level. So intracystic glucose seems to be very superior than our current model of looking for CEA levels. And it's easy to perform. It's a low-cost procedure. And I was told yesterday that people in India actually do it bedside with a glucometer, though I cannot do that in the United States. So widespread adoption of this should be easy, and you should be able to do it bedside at a relatively low cost to predict whether it's a mucinous lesion or not. So is this time for us to replace routine CEA measurements with glucose? I think based on the data, it looks quite convincing, and the answer is probably yes. In the United States, more and more of us have been doing glucose levels, and the glucose less than 25 milligrams per deciliter has a pretty good sensitivity, specificity, and positive predictive value. And I think in the discussion, I'm sure we'll have more answers of what's happening on this side of the world. So what is known, differentiation of these lesions is difficult. And based on this study, it has a very high accuracy if you start measuring intracystic glucose, and it's easy to do it. All you need is a drop or two of the fluid, so you should not need aspiration of large cysts. Pancreatic cancer, as I talked about, the global incidence is going up about 8.1 cases per 1 lakh person years, and it is expected that the burden of this disease will be increasing. And hence, we need to identify people at risk and try to prevent this cancer. Unfortunately, we do not have an easy, reliable way to screen these patients, hopefully in the future. But at this time, what we do is either do endoscopic ultrasound or MRI in high-risk group patients. And this is a study that was accepted for Outstanding Research Award by a trainee again. And what it did look is, are there any harms in the way we are screening the patients? The harms being, are we causing any injury by doing endoscopic ultrasound or MRI? What is the yield and the outcomes? This is 5 centers in the United States. It's a multi-center study. And if you look at it, they don't have any particular guidelines or standards in which they've operated. US was done in 208, MRCP in 44. And the indications were very strong. If you look at this group, these are the group of patients who are at very high risk. Familial pancreatic cancer syndrome, BRCA gene mutations, Lynch syndrome, Peutz-Jeghers, and familial melanoma syndromes. Again, when you look at the data, it's very intriguing. People say it's positive, but low-risk lesions were most common, 23%, which probably do not make any difference in one's life. Intermediate risk lesions, again, side branch IPMNs probably do not make a significant issue. But high-risk lesions were seen only in 0.8%. For somebody who you have subjected to EUS, MRI, and they're high risk, the yield still seems to be very low. So screening, they say, did not lead to any harms. But what harms? Nobody talks about the psychological stress and the sense of false security when you tell them your scan looks good, but next year they have a cancer, so that's not looked at. Nobody looked at the burden of the disease, or the psychological burden of the disease was not done. So here, again, when these two lesions were identified here, one was already beyond resection. So only probably in one of those cohort, we made some difference in going and resecting the lesion. So are we ready to screen high-risk pancreatic malignancy patients? I think I am a little bit mixed about this. I don't endorse that we should do this routinely. When it is done, I would like it to be done in a systematic way, in a programmatic fashion. Have your patients see a genetic counselor, see them, do them in the same standard protocol, and you need to follow them up and have some robust data to look at it. What we also do not know is that what is the psychological stress, false sense of security, cost of doing these interventions. So I think I would leave that with a philosophical note that I don't think we're quite ready yet to do it. Obviously, it's a tough disease and patients want something done, but just doing something for doing is probably not the right thing. How about a high one-year survival rate of unresectable pancreatic cancer? Again, this is a study that looked at tumors that are less than 4 centimeters that are locally advanced and cannot be operated because, especially head of the pancreas lesions with the vascular involvement, surgeries are not done. In those individuals in this study, what they did is they calculated a propensity score based on the patient's morbidities and the comorbidity index. Chemotherapy, again, was administered to the patients based on the oncologist's decisions and patient's functional status. And then the follow-up was done at least for 12 months. That's a pretty impressive follow-up for somebody with a terminal disease. So when you looked at it, there are only 46 patients, 11 in the EOS RFA group and 35 in the control, so very small. So I caution you that the numbers I'm presenting are very small. But when you looked at it, the results are quite impressive. Adjusted progression-free survival, so the tumor did not progress and patients did survive. At 6 months, it was 55% in the RFA group and 28% in the control. And at 12 months, 36% were still doing okay compared to 4% in the control groups. So it does show that there is something that the RFA is doing for these tumors. Again, the overall survival, RFA group versus control group, is significantly higher when you do RFA. So it seems that the RFA treatment seems to be beneficial in these patients who are locally advanced. And I know in India, we have had studies looking at RFA in neuroendocrine tumors and some cancers, but at least it's provocative. It looks like we could do something where there is no hope. So biliary strictures, again, those of you who do ERCPs are not uncommon, and oftentimes you're stumped whether this is a benign biliary stricture, is it cancer, and we all are indoctrinated that until you determine, if you have an indeterminate stricture, it's probably a malignancy until you prove it otherwise. So what we now do currently is either brushing, sometimes brush biopsies. Those are simple tools that most of us can do. And we are taught that maybe 10 times brushing is adequate. And the idea is because the tumors are very fibrotic, you brush, you break down the fibrosis, and you get the cells to diagnose. It's simple, safe, low cost, and it has a very high specificity when it's positive. And you could probably add DNA probes, which is the FISH or fluorescence in situ hybridization, to increase your yield by another 10%. What this study done was very novel. They said, what about just increasing the number of brushings? Instead of 10, what happens if you do 20? What happens if you do 30? What happens if you do 100, right? So all it costs you is your time. So 663 patients, 147 were included in intention to treat for 10 times, 20 times, 30 times. So pretty similar numbers. And 137, so the malignant diagnosis was pretty similar in all these three groups. Benign was again very small. This is a nice graphic that shows you when you do 10 times, your sensitivity is about 38%, which is what we're all used to. That's why we say it's a useless test. When you do it 20 times, it goes up to 47%. And 30 times, it's about 57%. And you have not added any cost. You haven't used any fancy markers, fancy scopes, no direct cholangioscopies. These are all expensive. So all you had to do was spend more time and do more brushings. So more brushings up to 30 times seems to be safe, easy, and has increased sensitivity. What was predictive of getting more cells and positive diagnosis was the increased length of the stricture. And obviously, you do have other modalities when your brushings are negative, including biopsying, FISH, and cholangioscopy. So the limitations, again, are that the sample size was very small. As I showed you, only 11 patients were in the actual intervention group. And beyond 30, I think the brush started bending in at least 3 of those patients, so they couldn't do beyond that. And maybe in the future we have alternate techniques, including artificial intelligence or liquid cytology and other things that might help us. But for now, when you go home tomorrow, take more time and brush more. So how about biliary complications in liver transplant? As I said, this is very common. You have a duct-to-duct anastomosis. Sometimes there is a mismatch. Sometimes there's a leak. Sometimes there's a vascular injury that does not help healing of the anastomosis. So conventionally, we have put plastic stents, but when you place plastic stents, you need repeat ERCPs, repeat interventions. The problem when you put fully covered self-expanding metal stents is that the migration rates are very high. So in this study, the authors looked at placing a metal stent that has anti-migratory fins. It's called a viable stent that's commercially available. So when these stents are placed, the stents do not migrate. So when you did this, the stent dwell time is still high. It's about 4 months or more. Stricture recurrence was about 17%. Stent migration was low, which is the biggest problem we had. And some of the stents were placed outside the papilla and some were placed inside because these stents come in one standard length. So can this really solve our problems and headaches? Again, it's a smaller study, 46 patients. There were 3 instances of proximal stent migration, but did not need any intervention. But the anti-migration part was taken care of. Need for more interventions or recurrent ERCPs was reduced. You still had about 2.4 ERCPs per patient over a period of approximately 4 to 5 months. Endoscopic papillary large balloon dilation, as I said, you do have recurrence of stones, and patients come and ask you, doctor, did you leave my stones behind? Why do I have recurrent stones? It's not that you leave behind, but sometimes it's a flow thing and you have a dilated duct. So once you have recurrence of the stones, your chances for recurrence of stones increases by up to 30 to 60%. So the aim of this study is to look at short-term and long-term efficacies of endoscopic papillary large balloon dilation, which you're all very familiar with in taking out large stones. And the intention of this study was to see if there is reduced recurrence and reduced need for more procedures when you have dilated. Again, this is the flow chart that looks at it. At 24 months follow-up, there were 87 patients who in the EPLBD group, and in the control group, again, 89, decent numbers. You didn't lose much, so your intention to treat analysis was good. So when you have done that, it looks like the number of sessions that is needed is lower. The ductal clearance is much better when you have done large balloon dilation. Again, this graph tells the whole story, the need for multiple interventions. So endoscopic papillary large balloon dilation can be safely and effectively used to treat recurrences of stones, and probably should be done when you are dealing with a dilated duct and recurrent stones. So in the last few minutes, I've talked about acute pancreatitis, especially recurrent acute pancreatitis does seem to increase your risk for development of pancreatic cancer. The etiology does not seem to matter. Increased pancreatic fat deposition might be a potential marker for us to look at who is possibly at risk for pancreatitis, and maybe in the future we would have some form of intervention for these group of patients. When you have pancreatic duct disruption, the outcomes are terrible at best, and you can probably predict that by looking at central or subtotal pancreatic necrosis and measuring a CRP level at 48 hours. When you use GLP-1 receptor agonists, be careful in those who have type 2 diabetes mellitus, concomitant tobacco use, and chronic kidney disease. So those are the patients who are at the worst risk of developing pancreatitis. Again, endoscopic nephrectomy is nothing new. When you have the expertise, try to do it endoscopically. That has lower length of stay and costs and morbidity with the procedure. Pancreatic elastography, especially looking at strain ratios, seem to predict exocrine pancreatic insufficiency and potentially could be used clinically for intervention as well. Intracystic glucose seems to be a readily available, cheaper biomarker for differentiating mucinous and non-mucinous cysts, and probably is ready for adoption widely. Screening, again, if you're doing for pancreatic cancer, should be done only in high-risk individuals in a very systematic fashion, should not be done routinely, is what my thought is. RFA for inoperable pancreatic cancer seems to be promising in a very small group of patients. We need larger data to see if this effect is replicable and can be adoptable. When you do brush cytology, spend more time, probably 30 brushings to 40 brushings seems to increase your sensitivity and specificity. It's a low cost, low risk procedure, just needs a few more minutes of your time. And when you're dealing with biliary strictures and leaks in a setting of transplant, consider using an anti-migratory, fully covered self-expanding metal stent. And when you're dealing with recurrent bile duct stones, probably doing endoscopic papillary large balloon dilation would save the patient of repeated procedures and saves you of the headache of doing more procedures. I'd like to put in a plug for the ACG 2023 that will be held this year in Vancouver, Canada. There is a call for abstracts. I know many of you are intelligent, doing a lot of research here, so please submit your abstracts. Thank you for your kind attention.
Thanks, Nalini, for a wonderful review of the different areas of the pancreatic disorders and what is the latest research and best of the few of the best papers published recently. So friends, the next 20 minutes will take the opinion of the panelists here that how the different areas, how do they apply to our country, what is their implementation, practical guidance for the future, and how they are relevant to our patient population. Well, the first paper that Nalini talked about is the acute pancreatitis, recurrent episodes, increasing the risk of CA pancreas. We knew from the animal studies that does happen due to secondary to inflammation. Dr. Konar, what is your thought process on that? Do you think, I mean, it makes the things a bit, to me as a layman, it becomes confusing that we have a patients of acute recurrent pancreatitis, or we have the recurrent episodes of acute pancreatitis. How do we differentiate, and do we label them as a pre-malignant condition looking at this paper, or is it too premature?
I think we do not have enough data from our part of the country, or that, because we often have patients who have more than 10, 15, 20 attacks of acute pancreatitis recurrently. And we follow them for development of chronic pancreatitis, but we do not normally screen them for development of pancreatic cancer. So I think this study is an eye-opener and might provoke, it is a bit provocative, I think, because
Acute pancreatitis is one of the most common GI admissions, acute admissions into our hospitals. And if we now try to screen them, and it will be almost impossible. So that should be my comment or approach to this problem.
Any of the panelists? Yes, Pramod, what is your thoughts?
So first of all, I'm not sure that data are robust enough to say that acute pancreatitis would actually be called a pre-malignant. The more important question is that even if there is some increased risk, not talking about selection bias here, do we tell a patient that in future he or she might develop pancreatic cancer? Even in patients with chronic pancreatitis, where the risk of developing cancer is fairly high, actually in idiopathic chronic pancreatitis, it is as the odds ratio may be as 90. We do not have, any surveillance strategy in place. So, from a practical point of view, for a patient who has recovered from acute pancreatitis, I don't think there is enough data to say that we will either alert the patient or think of surveillance at later stage.
So the message is that let's not be too alarmed by this data, but yes, it is important to keep it in consideration. This is an important new piece of information that has come up, but we should be on the lookout for the fresh data or the new data on that. Nalini, do you agree to that?
I think so, especially when you have unexplained pancreatitis. You probably should be just more vigilant is what I would do at this time.
Yeah. Pramod, I come back to from actually, I'm jumping the papers, but I come on to the screening for CA pancreas. Before we talk about this paper, what is your current, do you think we have reached a stage in maturity to identify the high-risk patients and to justify screening? Of course, the third thing is that what are the methods to screen is a secondary issue. But do you think we have we can identify a cohort whom we need to screen? And what are your thoughts on that in the Indian context?
So if I understand correctly, your question is there a subgroup patients for surveillance for pancreatic cancer?
Absolutely.
So the paper that Nalini actually presented, where high-risk group was screened, I think as of today, the guidelines say if your risk of developing pancreatic cancer is more than 5%, then you can recommend it. Now, for chronic pancreatitis in general, it is not recommended to offer a screening. In those with familial pancreatic cancer or a familial syndrome where there has been cases of pancreatic cancer, I think one could be justified in surveillance strategy after the age of 40, 45 or 50. But other than that, I don't think we have enough data to say.
See, when we talk about surveillance of any disease, so one is the identifying the right cohort of the patients or group of patients which need to be surveilled. Then the second question comes is, what is the best methodology? In this particular paper, they have used MRCP and US. But there have been a lot of work on this area in the literature that people have used the different markers. What do you think, something consensus is evolving or what is the future in store?
No, I don't think we have enough data on a particular biomarker which is more sensitive or specific compared to EUS MRCP, but surely there is a need to have such a biomarker.
Yes, Professor Anup.
I fully agree with Pramod that there is no established biomarker, at least for this purpose. In this regard, I would like to say that we have identified, in fact, chances of developing malignancy is supposed to be high in patients with idiopathic chronic pancreatitis. So, and we know that certain mutations you can see in the tissue in patients with pancreatitis as well. In CA pancreas, we all know that KRAS mutation is positive in more than 90% of patients. So what I did, we have identified those patients with chronic pancreatitis in a cohort of almost 300 plus patients, which we followed over a period of time and kept on repeating KRAS mutation in the blood from the DNA. And what we have observed that despite having KRAS mutation, in fact, in KRAS mutation was positive in 52 cases out of 354, but none developed CA pancreas. In two patients, even KRAS and P53, both were positive, and both are still under our follow-up, having no features of suggestive of CA pancreas. Then we have also identified a panel of 5 microRNA. We did next generation sequencing and identified differentially expressed microRNA in CP and CA. And we formed a panel, and from the blood we have identified this panel and validated this in blood also. But then in real life situation, in fact, even this panel has not been able to detect any malignancy in this cohort. So whatever we may do in this group, in fact, the high risk group is for this is pancreatitis or late onset diabetes, type 2 diabetes, and especially obese patients and those who are losing weight. So that is one group where we can do surveillance. But I don't think there is any biomarker, because whatever biomarker we have or proteins which are expressed, these are in advanced stages. So in early stages, when the intent is to identify tumor at an early stage, probably there is no established biomarker.
So the carry-home message for the audience when they go back in practice is, though that we have identified certain group of patients who are more prone to have CA, but we still not reached a stage where we can say that we can recommend a regular screening of by any methods, whether it's radiological or endoscopic or biomarkers at this stage, and maybe something more in the future. Do you agree with that message to go home? Okay. Anup, while you are on that, you see, all of you would have heard a lot about fatty liver, and even the previous session, there's a lot of discussion on that. But what is now intriguing, what Nalini presented, which is on fatty pancreas. And from where we learn is, we knew that the fatty patients of CA pancreas, if they have a fatty pancreas, then probably the spread is more, and so is the problems with the chronic pancreatitis. But this is probably the first study to suggesting that patients who have a fatty pancreas may be more prone to develop acute pancreatitis. I will like your opinion on, Anup, how do you react to this particular paper, that do you think a fatty, right now the practice is we do not even look at the ultrasound report of a fatty pancreas, we just tell the patient that it is nothing to worry. Do you think we have come to a stage where we have to start counseling the patients of taking care of this? Of course, we have no remedies for that, but what is your understanding?
In fact, in last couple of years, in fact 2-3 years, there are papers in which people have shown that there may be fatty infiltration in pancreas. Now, what you are saying, that we see deposition of fat in liver and deposition of fat in pancreas as well. In both the situation, the one thing which is different is that in liver, this fat is deposited inside the liver cell. But in pancreas, mostly these are adipocytes, and fat is not inside the pancreatic cell. This is one major difference as far as deposition in liver and pancreas is concerned. And there is replacement by fatty tissue, or there may be infiltration by fatty tissue in the pancreas. Generally, in a patient with acute pancreatitis, you may find that there may be certain acinar cells which are destroyed, and there may be fat cells present over there. Or there may be transition or transformation of acinar cell into adipocyte. That also happens even after acute pancreatitis, that adipocyte may be transformed into a dactylar cell. So these changes are seen in pancreas. Now, if fat is present in the interstitium, that means that stroma is altered. And now these fat-laden cells, they may secrete certain adipokines or cytokines, and that will change the milieu. So they may, in fact, if fat is present, that may be responsible for few episodes of acute pancreatitis. We can't say at this stage, but yes, that is possible. Second thing, if this is present in the matrix,
concise the answer.
in the matrix, then if these changes are occurring in the matrix, that may predispose these pancreatic cells or the DNA in the pancreas to alter. So even a malignant transformation may be possible if there is a lot of fat in the pancreas. That is my hypothesis, and based on certain animal studies.
Any quick reaction from any of the panelists?
I agree with them, but one thing is very clear by his paper, what he has presented, the intrapancreatic fat deposition is very important. Even the person who has got a skeletal fat deposition or the deposition in the liver, they may not directly cause any pancreatitis. They have nothing to do with the pancreatitis. It is the intrapancreatic fat deposition which is much more important. And sometimes even it has been found that obesity may be preventing actually for the pancreatitis.
Obesity may be preventive.
This is a new concept, which is more important, because it has been found that patient has got almost 20 to 25% chance of developing the acute pancreatitis if the person has got intrapancreatic fat deposition.
Okay. Well, friends, the message that I like to convey is that let's start seriously looking at so-called fatty pancreas. I mean, it may not be all that innocent that we have been made to believe till now. It's of course, another message from this particular study, which has been quoted by Dr. Nalini, is that this does not go hand in hand with the fatty liver or with the intraskeletal muscle fat, which also sounded quite odd to me. But I think let's move on. We have a short time with us. I have to finish during that time. Pramod, your favorite topic, endoscopic necrosectomy. Endoscopic versus percutaneous versus surgery. This study has shown that endoscopic necrosectomy has a better outcome. My question to you, that if you look at the step-up approach or you look at the different patients, you always use a modality according to the disease. So you cannot compare the three modalities in totality. So maybe these are the patients who were difficult, who had worst outcomes or more difficult outcomes or more recurrences and so on? Or is it actually an endoscopic modality scoring over the others? What are your thoughts on that?
I think you are absolutely right. There seems to be a selection bias here. So when you say endoscopically treated patients, these are the patients who have a fairly walled off collections or at least partially encapsulated collections, if not fully. And whatever studies are available, that most patients who have had endoscopic drainage were mostly fully encapsulated. And these are the patients, they are going to do much better than others. On the other hand, percutaneous drainage and percutaneous interventions are done rather early in the course of the disease because of infected necrosis or suspected infected necrosis, where the collections are not walled off, they are multiple, they are diffuse. And surgical patients are even worse actually. So unless you have a randomized trial where both these are matched, the disease severity is matched, you can't draw that conclusion.
Nalini, do you agree with that observation?
Yes, that's why when I presented it, I said the data are not very granular, it's just a very broad-based thing. And only a third of those patients actually underwent endoscopic intervention. So Pramod is right, not everybody is amenable for endoscopic drainage. But when amenable, when feasible, I think you should say, maybe I should do it endoscopically and not send, maybe I should swallow my pride, send the patient to Pramod to do endoscopic necrosectomy, then send it to percutaneous. So the take-home message is when feasible, when possible, when the patient is appropriate, doing endoscopic necrosectomy trumps over the other modalities.
Right. I think that's a message very clear that we should not go with a message that one modality is better than the other. We should also just follow the algorithm what we have been told that when to do which, what are the right indications of doing a procedure, and that's the way to go about it. See, another paper that we have left with only maybe 3 minutes, 4 minutes, the disrupted duct syndrome, Dr. Konar. Now, it has shown that a disruption of the duct will cause more recurrences, more complications, more interventions, more chronicity. My question to you is, how easy or difficult it is to diagnose ductal disruption in the setting of acute pancreatitis? Because if you look at the data, the range is very wide, that how frequently it occurs. I mean, it's a...
I think the basis of diagnosis of this is imaging, basically, and we normally rely on CT scan because it has to show there is a necrosis, there is disruption, and the upstream tail portion of the body portion is thriving, still is alive, and also there is collections, maybe within the pancreas, outside the pancreas, or in distant places like pleural effusion or ascites. So I think this constellation of findings will make it a duct disruption. And the problem is we always know that it has to be extensive necrosis to produce this amount of clinical picture, which these patients will have not only have the systemic problems like organ failure, but also will have local complications and will need as we know, the multidisciplinary
Can we be brief? We have less
approach.
time. I want to discuss one more paper.
So multidisciplinary team approach, and you need to have radiologist, endoscopist, and the intensivist to tackle the problem.
Pramod, you want to comment on that?
So I think what we should differentiate is, can we predict DPDS or how do we diagnose? So in the beginning of the illness, so first 2 weeks or so, if you have a patient with significant necrosis in the central part, neck body area, there are the patients who are likely to develop acute necrotic collections and later might develop DPDS, where you have a classical stricture and a disconnection between the duct and an upstream dilatation there. So that is much later. The initial problems are because of severity of the disease, not because of DPDS.
That's right.
DPDS will result in complications later, but fortunately in not more than 5 to 10% of patients in terms of recurrence of pancreatitis or recurrence of fluid collections.
Okay. Last paper, Dr. Anoop, very interesting now. I think the significant data has appeared on the mucinous cyst, differentiating between the benign, malignant, the glucose, value of glucose. What I am not clear, what value of glucose, what method to test, whether you test on the glucometer or you send it to the lab. I mean, that's something which I am not clear, which a lot of delegates here will be interested in knowing. Can you update us on what is the current understanding on that?
In fact, in this paper, they have shown that if it is less than 25, then chances are more. But there are papers in the literature where they have shown in a series of 153 cases, they have shown that even if it is less than 50, then also chances of malignancy are more. Because, but what method, I have no idea. In fact, I am not aware of it. If Pramod wants to add something,
I think before we go to the glucose test, we should understand that there are primarily 3 kinds of cysts that we are worried about. 2 of them are mucinous, MCN and IPMN. So we are not, problem. There's no problem. The third is serous cystatoma, which is, classical appearance in macrocystic. So it is only in a few patients that there is a confusion about non-mucinous and mucinous. And there this test might be helpful. So don't go with the idea that, you have a cyst, just put a needle, take the fluid out and do a glucose test. There are so many other features which are suggestive of mucinous and non-mucinous, and also the decision to intervene, which is not based on glucose, by the way. So it's a good test, but not just the panacea for everything.
Nalini, do you test all your cysts for the glucose, and what is your algorithm on that?
So if I decide to puncture the cyst, then I'm doing glucose. But as Pramod said, if the cyst is stable, so does not change, is a small branch, IPMN, then I don't routinely puncture the cyst. But if I puncture, then I'm checking glucose.
Well, friends, you will agree with me that the experts have given us a slightly good take-home messages on at a very good paper selected by Dr. Nalini, and I hope it has been useful to you. Well, thank you very much, and thanks to all the panelists and Dr. Nalini.
Thanks Ajay, Nalini, Pramod, Dr. Dikshit, Dr. Saraya, and Dr. Ashokanand Konar for an interesting session. So we are on to the last session of the day. In fact, last session of the season 3 of Best of ACG in India. And I'm very happy to invite the moderators and the panelists, Dr. Uday Ghoshal, the head of the Department of SGPGI Lucknow, and till recently the editor-in-chief of Indian Journal of Gastroenterology. We have 4 eminent panelists, Dr. Amrinder Puri from Gurgaon, Medanta, Dr. Piyush Ranjan from Gangaram Hospital, Delhi, Dr. Rajesh Upadhyay from Delhi, and Dr. Ramesh Ruprai from Jaipur. So I would request the panelists to come and join on the dais. And I'm very happy to invite Professor David Johnson, the Professor of Medicine and Chief of Gastroenterology at Eastern VA School of Medicine, USA. He has been a president of American College of Gastroenterology as well. Very happy to have him in this meeting. Dr. Johnson.
Well, good evening. It's a true privilege to be here, and by way of introduction, I have to issue some thanks, and in particular, the special thanks go to our co-directors for this marvelous course and the exceedingly marvelous durability over 3 different venues. But Dr. Nalini Gouda, the ACG governor for Wisconsin, and you just heard from one of the godfathers of gastroenterology here in India and around the world, Dr. Mahesh Goenka. And I have to say not only thanks, but I want to raise for the attention of the audience the special congratulations that goes with these thanks to recognize, if you've not heard yet, that both are going to be awarded by the American Society of Gastrointestinal Endoscopy special awards. These are awards given to 1 or 2 persons each year from around the world. The 2023 awards for the Master Endoscopist, Dr. Gouda, and then the ASGE International Service Award goes to Dr. Goenka, and I really think we should give him a round of applause in anticipation of Digestive Disease Week. I'd add in that the end is not a co-director, but a co-faculty member and an esteemed colleague, Dr. Vanessa Shami, who's the ASGE Distinguished Educator Award. How could we possibly get 3 internationally recognized people on the same stage in the same program? Congratulations, and again, an honor to be here. I would be remiss if I didn't start with also the very special thanks to the Lupin team. Dr. Pradeep Sashvata is the VP of Sales and Marketing. You've heard from him earlier this evening. And I will tell you, it's an absolute consensus, and I say this on behalf of the faculty. We all are invited around the world. We've been involved in countless meetings and symposia, and it's uniform 100% agreement that we've never been involved with an organizational structure such as these 3 meetings. Team Lupin, from the leadership to the marvelous feet on the ground, has just been remarkable. You're truly really incredibly gifted, and in admiration that you have such a marvelous resource in your country, not only to enhance your practice, but the best outcomes and communicative skills for your patients. And again, you are truly in a very fortunate position in collaboration with a company like Lupin. With that, I would begin by saying Namaste. Manasar Sat Hon Ke Li American called up gastroenterology ke pratinidhi ke roop mein samanit mahasus. You're thinking perhaps that I hope the rest is in English because he didn't do a very good job, and I try. But let's talk about what we're going to discuss briefly and set some goals for the strategies here. And my goals were really to review the esophagus and beyond. So with that, I'm going to highlight national guidelines from the American College, and particularly what's new. What did I find in my practice, and I've done this for 44 years, what are remarkable comments that I would make? 30,000 foot, as Dr. Galini talked about in his views from the pancreas, but again, talking about what really changes practice. And looking into the ACG presentation, some of you may have seen them or seen the highlights, but really talk about what's meaningful there, in particular applying to your practice. Hot topics, I've taken out some recent articles from the Red Journal in particular, but other journals that are still in press. And again, put this in perspective. I've done this now for 44 years. I don't have the esteemed faculty experience that some of your godfathers that you saw at the start of this meeting particularly have, but I've been doing this for a long time, and I would give that guidance and perspectives. And in particular, I'll leave it with take-home messages, guiding clinical judgment and clinical experience, and hopefully leaving with things that may be beneficial. Let's start with the guideline as it relates to reflux disease. Extremely common. The graded recommendations are now uniformly applied to the most guidelines, National Society guidelines, in particular the American colleges use this now for the last 15 years, but strength of the recommendation and level of evidence are applied. The diagnosis of reflux, the recommendation here is if it's not clear, really endoscopy does not show evidence of, objective evidence of GERD, and we'll come back to that in a minute because a lot of people think it's a test for GERD. It really is not. It's a test for consequences or complications. Obvious evidence of GERD, we see most non-erosive disease. That's not a test that's very diagnostic when you do endoscopy. Reflux monitoring, if you don't really have a clear diagnosis, is recommended, but off therapy, and we typically will stop the therapy for typically at least a week, and ideally a little bit more than that. And the strength of the recommendation here is strong, but low evidence to support that. As far as pH monitoring, impedance is where we do more, in particular to do this monitoring off therapy, and if you're going to use it, with the exception is if you have such obvious evidence of reflux disease, LA grade C or LA grade D, that's almost 100% gastroesophageal reflux disease, or if you have long segment Barrett's, you do not need to use pH monitoring if you see those endoscopically. Again, strong recommendation, low evidence. What about maintenance therapy? Do we start and stay on something forever that patients will look at me frequently and now over-the-counter access? Maybe you don't even see the patients for a while. How long do I need to take this? Some say I don't want to stop it because I feel so good. But in particular, the idea that you want to take this patient to a recommendation for that stay on PPI if they have refractory symptoms and abnormal, I'm sorry, I back up here. The idea here is that you keep them on maintenance therapy if there are consequences. So LA grade C and D esophagitis for sure. And again, the idea that if they have evidence of objective disease, Barrett's esophagus, that would not go forward as a reason to stop the medication. Extraesophageal GERD is clearly a problem we see very, very commonly. Typical GERD symptoms, it makes the diagnosis a lot more implicit. A trial recommendation here is BID. We typically will not see those patients back for at least an 8 to 12-week trial before you talk about additional testing, and that would be, in particular, impedance pH. Endoscopy is not helpful in this particular parameter of outside of the symptoms that would already give you the diagnosis in most cases. But again, if you have a diagnosis of reflux disease and suspect asthma or chronic cough or laryngopharyngeal reflux, these are not diagnostic tests that endoscopy is helpful. And again, recommendation is low, but the conditional recommendation, low evidence. The evidence that impedance pH should be done on therapy is really if patients that are on PPI therapy, and I will push this to BID before I measure that, and if you're not adequate control, do it on therapy. You want to see what am I going to do at this point? Is it non-acidic reflux? Is it not evidence of reflux at all? Is it functional heartburn? Again, these are patients that you don't want to go to surgery when they think they're going to get better and they didn't 100% improve with a BID PPI. The exception is in patients that have primary regurgitation. We do not do well with medical therapy in uncomplicated non-gastroparetic reflux-related type consequences of regurgitation. But if the patients have primary regurgitation, could at least consider anti-reflux surgery or a transoral incisional fundoplication known as TIF. But again, if you send it to anti-reflux surgery, make sure that it's an experienced surgeon, high volume type surgery. These are not procedures that are to be done casually or occasionally. They need to be done by high quality, high service, and high utilization with high performance standards. If we talk about reflux disease and said endoscopy is not a diagnostic test, it can be in severe LA grade C and D esophagitis. And this is an article that's just in press right now that you've not seen. But looking at objective evidence of reflux disease, we can see that that's helpful. But response to a PPI doesn't necessarily tell you that they truly have erosive esophagitis. And in particular, if they have LA grade A esophagitis, you may be misled that they don't necessarily respond to a PPI. In particular, looking at ways that you can objectify this, we look at objective evidence, clinical evidence. They have heartburn, they have primary symptoms of heartburn, maybe occasional regurgitation, they have body habits and other factors that precipitate it. But looking at that now in composite with new recommendations from the Chicago 4 classification, that there are other objective measurements that we can do. And this goes to acid exposure times, where we typically would say over 6 is clearly abnormal. There's a gray zone between 4 and 6, and there are new parameters that we are now incorporating as objective evidence of reflux disease by pH impedance testing. And these include a mean nocturnal baseline impedance and a term also called post-swallow induced peristaltic wave. These are impaired, and these are now objective signs of reflux. When we start to look at this, we can see that the patients with LA grade B and C have virtually 100% objective evidence of reflux disease just based on their history. And compared to that with LA grade A, it's around 17%. And again, we're not seeing this in particular going from C, B, where it's almost uniformly. We can get that by history. We don't see that exceptionally with A in a rarity, 16+%, but not very common. And the other things that we potentially would look at then is this gray zone of the acid exposure time between 4 and 6%. Again, it is virtually 100% in LA grade C, and you can see the diminution where you get just to a marginal percentage around 16% as it goes to the measurement with the acid exposure time. And then what about the idea that you have true acid reflux? Well, you see this in all the LA grade C, most of the LA grade B, but virtually none of the LA grade A. And again, objective evidence is really not what we're looking at when we see A, and you're not to send that patient to surgery based on what you saw was LA grade A esophagitis. So the take-home message here, it's not objective evidence for GERD. These are people that need to have further diagnostic testing. Now let's get to some of the highlight abstracts that were presented at the American College meeting, the first of which I've taken is from an internationally renowned consensus of multi-centers, but looking at vonazepam, and this is a PCAB, and we'll talk about in a second, but applying it to non-erosive reflux disease. We know in people that have dealt with GERD for a while, PPIs are not effective for on-demand therapy for non-esophageal reflux disease. We can perhaps talk about why in the panel discussion. The background of vonazepam, though, is it's a potassium-competitive acid blocker. So not a PPI, but a new type of therapy that does interact at the potassium channel adjacent to the proton pump. It binds ionically, unlike PPIs, which are really covalent bonding, and the binding to PCABs is potentially reversible, but it has immediacy as far as the effect, and it reaches its, because of the faster onset, its half-life is also more durable. PPI half-life would be around 1.5 to 2 hours. A PCAB is in the range of 7 to 8. PCAB takes 1 dose to reach maximal effect, and PPIs, as you know, may take 5 half-lives to get there as well. So contrary to in an area in the Euro-Pacific, in the Asian-Pacific area, in particular, the prevalence of C219 pathway metabolism is higher. The Asia province certainly drives this as a concern when you're giving PCAB, when you're giving PPIs, and this whole PCAB class is irrespective to the 2C19 pathway, so it does not seem to have much of an issue. Look at the methods that they did, and the studies that they evaluated first was the percent of valuable heartburn episodes focusing on 2 endpoints, complete and sustained relief. They had an episode, and that started the clock of evaluation. So 1 episode, study intervention, and then they looked at complete relief, and this is defined very short windows. So they had 30-minute windows beginning at a half an hour, extending up to 3 hours, and then that was registered. Once they had relief, it had to be sustained. So it had to be sustained for 24 hours. You got that 1 dose, no rescue medication. So the run-in period here was with vonazepam for 20 milligrams, so they all had response, and then they were randomized in a 1-to-1-to-1 ratio, but looking at composite of 3 different type of dosing regimens for vonazepam, placebo-controlled, and then they looked at this at a 1-week period and looked back and looked at the episodes of heartburn. Again, these defined elements of relief were very short windows. So they really had snapshots beginning at 30 minutes and over 3 hours. Well, what did they show? Was this going to be effective? The answer is overwhelming yes. Virtually all these dosing regimens showed more complete and sustained relief. So their heartburn episodes were all compared with placebo. As you know, with any intervention in drug trials with the reflux patients, there is a placebo response, but demonstrably much better across the board, highly statistically significant p-values of 0.0001 in all these comparisons with vonazepam. So the take-home message here is that it suggests that PRN benefit, unlike PPIs, may be extremely effective. This is promising, but it clearly needs a larger study. It's only a phase 2 study, so I'd like to see more information. Another very interesting study, and one that I think may change your practice if you're not doing this, is the idea of using a cap assist when you're treating a particular esophageal food bolus or foreign body ingestion. This was a meta-analysis and a systematic review. And basically what we all have dealt with when we get a call in the middle of the night and you go in and you see this piece of chicken or whatever and it's in the middle or distal esophagus and you sit there and they may have salivation and hypersalivation along with this. And you're troubled as to what do I do to get rid of this thing. And there are traditional measures that actually have implied we can push this gently down. I've not ever found that helpful. And my consternation there is that I don't know what's causing the obstruction. So an obstruction that's generated by a stricture or a tumor or something, what you can do is tangentially punch laterally and perforate that esophagus. So this concept is now potentially challenged by the idea of a cap, which would apply a more formative avenue for suction. And so that was the focus of this particular intervention. So the background here, again, using a suction, using a transparent cap, and the idea that you would then apply that cap to the bolus, apply now a high-level suction, different than what you would normally have otherwise with your aspiration channel, and allow that meat or that bolus or whatever to be drawn back up into the cap. In particular, changing this perhaps intentionally to an en-bloc resection. So let's look at the endpoints of what they reviewed. First, technical success, overwhelmingly compared to the conventional, it was clearly statistically highly significant. Here on the bottom, you can see the odds ratios compared again to the traditional extraction, and we've all done this. We've used snares, used Roth nets, whatever you can try. It just is very problematic because what happens is these fragment, and they tend to be an ongoing issue trying to get all these things out. But compared here, the technical success was favoring the intervention with a cap overwhelmingly. And again, the same as it relates to en-bloc resection. Remember how nice it would be if we can just pluck that foreign body out. And in fact, again, the odds ratios compared to conventional therapy were uniformly consistent, strongly in favor of this cap assist. And what about the time of the procedure? If you've been doing this for a long time, you'll say, how long is this going to take? And your endo team is saying, you know, we've been here for an hour. When are we going to be done? And you're worried about aspiration and all these kind of things. And again, the procedural time was inordinately in favor. So now, again, the odds ratios here are shifted at the way they're displayed. So compared to conventional, we want to see that shift to less time, and in fact, that's what we see. So this block assist, and in particular the food bolus obstruction with a cap, uniformly is consistent. So the take-home message here for you is it's significantly better technical success, shorter procedural times, fewer adverse events, esophageal mucosal tears as you slide a snare back and forth or a Roth net. Again, that may be something you've seen frequently. And it's safe, and 48% of the patients in these meta-analyses and reviews were performed without general anesthesia. I would always opt for general anesthesia for airway protection if I can, but again, this is done frequently. This is available now. It's not really a cost involved, but it may change your practice, and it has done to mine. When we establish reflux disease, we typically tell the patients what they can't do, right? And they talk about diet, and you can't do this, you can't have that, and can't do this. Well, this is a randomized controlled trial, and it's in press as well, and you'll see in the Red Journal here shortly. But it looked at 4 dietary aims, in particular with varying 2 things. One is the type of carbohydrates and the components of simple sugars. So looking at this and basically using high-low in both of those categories and looking at changes through the course of the week, What I've highlighted in the middle is that somewhat aberrant, but the high total carbohydrate and low simple sugar was the best one as it relates to acid exposure time, but they all uniformly, as far as these interventions outside of the high total and high simple, performed marvelously well in decreasing heartburn and other epigastric symptoms, even sleep as it relates to reflux disease. And it's a good, basically good health diet. The more we can do for reductions of carbohydrates perhaps, but in particular simple sugars. So I think that this reduction is a reasonable strategy. And I try to put this into a global health issue, not just this is about reflux, but again, it may affect their daily life and their overall health. I want to change the episode of what you've been taught for your traditional training as far as reflux, which we view as an acid-related disease. And the traditional notion is that acid contact with the esophageal mucosa creates a direct chemical injury, correct? We've all been taught that for years, and my mentors were all the thought leaders of the world. Don Castello is one of my closest mentors. And we expect histologic injury because of that direct caustic effect, right? And that's where we see the inflammation, that's where we see the response. Well, really, some very seminal work by Drs. Sue Speckler and Rhonda Souza, you know well from Baylor and Dallas, and they put this article together in JAMA looking at just opposite, that they showed that reflux disease in their patients they studied was a T lymphocyte predominant inflammation. But the inflammation as it resulted to where this was occurring was not in areas of erosions. It had nothing to do with, the erosions had nothing to do with what we saw as traditional reflux histologic criteria, going way back to Ismail-Beghi type criteria that the godfathers that are here will probably the only other ones than me that are old enough to remember that. But here they were seeing damage without damage to the surface epithelial cells. They were seeing damage in the submucosa, and in particular, Pete Gorillas, who did the editorial for this, really titled this, I think, appropriately. He said, turning the pathogenesis of acute peptic esophagitis inside out. What did he mean by that? It wasn't top-mediated damage by caustic effect. It was top-mediated cytokine upregulation to the submucosa and a retrograde inflammatory response moving up. I've become very interested and very focused on this, in particular as it relates to microbial effect, and we'll talk about this, but if we look at the traditional therapies with PPIs, they're acid-directed. And that whole paradigm of acid contact injury is really the challenge now. And what we're seeing potentially is a movement towards that there may be a influence, at least, on the microbiome in the esophagus. In particular, we're looking at gram-positive, gram-negative ratios, and what we're seeing is that the gram-negative ratios are predominant. Why is that a concern? Because lipopolysaccharides are a component of the bacterial wall in gram-negatives. When they get endotoxemia and septic shock, it's because they have this cytokine storm, so they're profoundly inflammatory, driven through interleukin, but in particular also toll-like receptor pathways. And what this does then is drives a central effect down in the submucosa with inflammatory cytokines. This leads to the lymphocyte infiltration, which leads to a retrograde response up to the mucosa, and that's where the inflammation begins, and that's where the surface erosions develop. So again, it's the basement going up, not the roof coming down, and that's the whole paradigm shift. When we start to look at this and challenge that it may be microbial, there's an emerging growth of literature that really is exponentially over the last 2 years, focusing on things like reflux disease, Barrett's esophagus, esophageal adeno, even squamous cell, and eosinophilic esophagitis, just to name a few. We've profiled this in our most recent book, but in particular looking at these composites, what you're seeing is that in some categories in certain disease states, the association is that there are increased bacterial changes in ratios, and in some circumstances in association, there's just the opposite of reduction in certain genera and phyla that now lead to at least the association and implicit perhaps to causality. If you'd like to know more about this, we've just published a new book on this just 2 months ago and with the world's experts on this, in particular the esophageal disease and the microbiome. Again, something that I think stay tuned. So my take-home message to you is I'm not sure it's providing the answers. Stay tuned. Who would have thought that esophageal diseases were potentially infectious diseases? We're not talking about Chagas disease here now, but we're talking about common reflux, inflammatory neoplastic diseases, and a paradigm shift perhaps from just acid injury. We're going to shift for a couple discussions that really I thought were very profiled at the American College meeting, talking about abdominal pain. For those of you that have never heard this, this is a pearl that I want you to remember and never forget. That's how strongly I feel about it. It's called Carnet's sign. The implicit test is very simple. You examine the abdominal wall, you examine that patient, find where the point of maximum tenderness is, 1 or 2 fingers perhaps in the supine relaxed position. You then do the test B, where you have them flex up with their shoulders, lift up their neck and head, or their flex or pull up their legs. And so what you're doing is creating a rectus extension away from the abdominal cavity because they flexed up like that. This pain, if it's from the abdominal cavity now, because you've essentially put a roof on that, you've lifted the roof, changes the pain away if it's a true visceral source to now the abdominal wall, which is flexed and higher tension. And that's a very, very strong indicator that this is abdominal wall pain. I can't tell you how many surgical patients I've seen, how many times patients have been to the ER, but it's a remarkably easy thing to do. Has basically implied every time I see abdominal pain, I look at this and the chronicity may lead me more to abdominal wall pain. It's very simple, it's easy, it's discriminate, there's no cost. And in my country, in our country particularly, when patients come into abdominal pain, they all go to CT, and I say to the ER doc, what was the abdominal pain, what was the abdominal exam? They said, I don't know, but the CT is negative. That's just the way it is. I call it drive-by shootings in the United States. They all get CT radiation, but nonetheless, this has no radiation. It's 100% actionable now. Let's talk about guidelines as it relates to gastroparesis. Dr. Michael Camilleri, probably the world's leader on this area, put together these guidelines for the second time, most recently updated back in January. And talking about this in your institution, the recommendation should be sonographic imaging should not be any shorter than 3 hours. In our institution, it's 4 hours. Our recommendation is to standardize it, validate in your own institution, but the minimum standard should be 3 hours. Metoclopramide doesn't really work all that well. That's probably the only prokinetic drug that we can actually prescribe in the United States, or domperidone, which you have here. And again, these are things that really have low conditional type level of supports. But again, you have more advantage for domperidone than we have to import it across borders to get it. One tip here that I think is really potentially actionable is the 5-HT4 agonist over no treatment. The one that I use routinely, if I can, is prucalopride. This is one that's indication for chronic constipation or idiopathic constipation. But it does have a profound effect on gastric emptying and associated with, in particular, type 2 diabetes. So we've seen this overlap, and people that have a more general visceral myopathy, prucalopride would be the drug of choice, at least from my perspective. One that I would challenge, because you have so much in the way of over-the-counter advantages that we don't have, antiemetic agents do not improve gastric emptying. They may improve the nausea and vomiting, perhaps, but they don't improve the gastric emptying. The caveat for you here, especially since you have domperidone over the counter, you have to be careful because domperidone and antiemetic like ondansetron have QT potential prolongation interaction, which don't have any symptoms, and the patients may have significant cardiovascular events as a consequence. There were no recommendations to support herbal therapies. Again, you have more advantage than we do in some of these therapies. One emerging technology that I think is very advantageous and certainly advantage recognized by the guideline committee was the idea of an endoflip we've used routinely in the esophagus, in particular now with achalasia or some more of the motility disorders. And now it's been categorically supported, not high recommendation, but the value as it relates to pyloric categorization, particularly if you're going to do a POEM procedure, certainly in the pyloromyotomy POEM procedure for gastroparesis becoming increasing at least advantage. No data to support, at least in randomized control data, for use of intralesional Botox into the pyloric area. I will tell you that there's one trial from France that does support that. It's a trial, though, that did endoflip to look at pyloric distensibility as it relates to particular evaluation with endoflip. They suggest it may have some advantage, but the recommendation's fairly strong that intrapyloric Botox doesn't work, at least from the randomized trials. If symptoms are refractory over medical therapy, pyloromyotomy, or this GPOEM type approach certainly is getting a lot of attention. And the reason it's a problem, and this is a study this is a meta-analysis coming out over the next couple months, a paper in Gastro, but it basically profiles that there really are very few, if any, drugs that have effectiveness. The two drugs highlighted here for you, cleopride and domperidone. Cleopride's not really been shown that effectively. It's in dyspeptic patients that have a marginal gastric emptying, not well done, not really clear gastric domperidone, the odds ratios approach 1 and barely don't touch, but again, not significant very strongly. We just don't have good medical advantage for potentially these gastroparetic patients. This is a paper, this is a symposium, this is a profile reference that I want you to put on your laptop because it's on mine. And it's a remarkable monograph that the American College put together with the really thought leaders, and particularly focusing on pregnancy. We all get a little bit nervous when we treat the pregnant patient. I know the IBD side, in particular, hepatic liver disease and pancreas diseases are all certainly profiled in this, but I wanted just to highlight it as it replaces the discussion here on heartburn, nausea, and vomiting. And again, it's something that was a remarkable resource, looking at how do you manage these, beginning with lifestyle and diet changes to medication assessments, when to test. But again, it's something that I just make as a reference, put it on your desktop. It's a go-to reference. And certainly the challenge to the authors, and I was one, they told us we needed to have it final manuscript to them within 6 months because it was going to get published that quickly. So again, it's the remarkable time efficiency here that really puts it together, and it's timely and referenceable and actionable. The global prevalence and burden of disease, I want to move into some of the functional diseases in particular here, looking at India and looking at the functional diseases in India. No surprise to you that it's not an uncommon issue. The 2 profile areas that were surveyed in your country were looking at bowel problems or a 1 or more month any health problem, and then looking at these over the composite of functional disease or non-functional diseases. The odds ratios here shown are 95% confidence intervals, but again, strongly in favor of the fact if you had functional disease, there was a tremendous burden and a tremendous prevalence, not only in the patients with bowel symptoms, but any other health symptom, really recognizing these patients have a lot of functional disturbance. I'll move into that discussion with the idea that abdominal bloating is something that we see quite commonly. It's a bothersome GI problem. I see patients a couple times a week that bring this up. Sometimes they don't even bring it up. The differential, as you would expand on your differential diagnosis, would be quite broad, but we're talking here about functional bloating, not obstructive bloating due to mechanical causes that we might see from other neoplastic or inflammatory diseases. We're talking about functional disease and visceral hypersensitivity. And this seems to be a somatic behavioral response, again, maybe adaptive to some degree, but the new term here that I raised in this article just came out in the Red Journal as well is abdominal phrenic dyssynergia. It's a concept that you probably have not considered, but it is really a diaphragmatic contraction in a dissociated response to abdominal wall relaxation that's backwards to what we would normally see. So the normal abdominal condition, the abdominal wall would push in because you're getting distension, and the contraction would lead to a diaphragmatic movement up into the chest. And that would allow displacement in this basal condition to accommodate that gaseous distension. But just the opposite, if you have this distension in a dyssynergic way, there's a paradoxic movement of the diaphragm down. This increases the intra-abdominal pressure, and what you see here is this leads to distension that's now aggravated. The gas started it, but the dyssynergia now aggravates it, and you have very much a more provocative effect of that bloating effect. Now, the reason that this is important, I think it's a take-home message that I would think you could use today. It's a new concept and understanding. It's promising data, and I apply particularly this with biofeedback or diaphragmatic breathing. If you have not used that before, find that very, very helpful. There are no standard treatments really how to access these or do these things, but they may be adjunctive treatments. But here we're targeting central sensitization and visceral hypersensitivity. Again, we're talking about functional dyspepsia, not obstructive disease. Since we're talking about functional dyspepsia and bloating, there's a very profound article that was, abstract that was presented from the group at Jacksonville Mayo Clinic and in concert with Brennan Spiegel at Cedars-Sinai in California. Now this is talking about other ways that we can deal with these visceral hypersensitivities, this time using virtual reality in a double-blind controlled pilot study. So the focus here is virtual reality is basically affecting pain perception by attention concentration and emotional alteration. If you think about the kind of the gate theory of pain, if you tap your finger enough times and then hit it, it doesn't hurt as much. But what you're trying to do is desensitize and change your visceral perception or your perception of wherever the pain is being initiated. And this virtual reality tends to do that by overwhelming the senses and potentially creating immersive environments that diminish the pain by downregulating this noxious stimuli. So you have a downregulation from the brain with this virtual reality. And you can also then have an upregulation of this change in non-painful neurostimulation. And this allows for basically a recalibration of how that pain is perceived. So again, very, very important to understand this has been done in irritable bowel syndrome, so now they're expanding it potentially to patients with functional dyspepsia. To show you how this would potentially work using brain scans, and this is something that really has been studied in the pain literature particularly, not necessarily the functional disease, but the idea of brain activity changes. So here we're talking about virtual negative and opioid negative and other analog that's used to treat pain. But as you move to virtual positive and opioids negative, again, you start to see changes here. In particular, note the changes of color. When you go to virtual positive, virtual reality positive, and opioids positive, there's a remarkable dismissal of this reddish orange color and very diminution of the greenish discolorations. But again, these are correlates that suggest there's less of an inflammatory condition at sensory perception, at least in the brain. And this is the way that the novel program for IBS was validated, and then now it's being applied to functional dyspepsia. With this, the functional dyspepsia was defined by the Rome criteria, and my esteemed moderator knows more than I do about the Rome criteria, but certainly this is defined by strict criteria. These patients all had this for exceedingly durable treatment time for 3 months at least, and for 6 months prior for the onset. Again, no evidence of structural disease. We're talking about visceral hypersensitivity and functional dyspepsia. They were randomized, favoring obviously experimental, but the experimental group had a virtual reality software. The active component of this was 3D audiovisual, and they had a passive component as well. And the identical virtual reality headset was applied to the control group, but they had two-dimensional nature videos, so they didn't really see anything other than these images of creeks and mountains and peaceful things. All patients were asked to use the headset for 2 weeks. There were no restrictions on diet, other activities, and the number of times that they had it per day, but they were asked to do it at least once a day. And they were allowed to different programs to select within a menu of things, both based on the experimental and control group. The primary objective here is about the patients. So patient outcomes were really compiled and looking at a very short intervention here for only 2 weeks. But the two validated indices that were used here, the PAGI score, which is a patient assessment of GI symptom severity index, and again here the active intervention with virtual reality, highly statistically effective. And just the opposite of the DPN dyspepsia index, going up means they're getting better, and just the same we see with the virtual reality, active control versus control, highly statistically significant. So the take-home message here is that virtual reality is intriguing, and it's a novel treatment in functional dyspepsia, but clearly larger trials and longer duration, remember this study was only 2 weeks, are warranted to see what the durability of this effect may be. Along that same lines of cognitive desensitization, there was an app-directed therapy that focused on hypnotherapy in a program called NERVA, and this was looking at ways that they could deliver a desensitization by hypnotherapy. And it enables the spread of the widespread use of treatments despite professionals that are not available locally, potentially. It's a cost-effective availability and improves overall symptoms, in particular in irritable bowel. The limitations are pretty striking, though. The limitations are access to trained therapists, the therapist's availability, so even if you got the referral, they can see them, it may be 2 months, it's very frustrating for the patients, and then the cost. So NERVA therapy, again, the instructions were to use it 10 to 15 minutes a day. 6 weeks, they had diaphragmatic breathing exercises focusing on a number of things that can compile anxiety and certainly upregulation, visceral hypersensitivity, and central recognition of pain thresholds being lowered. They completed the program. 17% were referred by healthcare providers. The majority were self-referred. And this is important because when you looked at the patients that were more likely to complete, they were basically driven by the healthcare providers. So again, patients listen when we as providers provide that information and reassure them rather than they seek this care out on their own. How did it perform? Well, it performed marvelously against all the endpoints here. The p-values were across the board uniform, 0.0001, highly significantly effective. Again, a novel therapy for hypnotherapy. Putting this in perspective, an article that just came out, not yet in the journal in press only, and you can find online, but it targets digital health therapeutics. And what do we do with this? And we know that it's rapidly growing. The new solutions created because of all the expertise around the world in putting these things together, and people are thinking out of the box. But the preliminary data shows they're really evidence-based treatments, and they do respond, and it's helping address the shortage, in particular of GI psychologists and people that are trained in getting patients to desensitize. It certainly putting it in perspective, I'd say it provides a great glimpse into the future. The technical solutions allow people to reimagine now how we currently view the clinical care model. You come into the clinic, we tell you, you see a referral, and you get online and you get into the testing, and it may take forever to get there. But we're now starting to expand our availabilities perhaps and think out of the box where we can break out of this brick and mortar system and maybe really start to develop timely care, very personalized approach. And the cognitive therapies, I think that the take-home message here is change is inevitable. Right change is the one to make, and certainly the ones that bring benefits to you as a providers and patients as well. But don't be afraid of it. Do diligence and try it before you recommend it. That being said, there's another therapy that is very, very powerful, and again, something that has widespread potential application. This deals with a yoga program. It was certified and developed by the Isha Foundation, which you all know well as a product of India. And the UPA program consists of a very focus on joints and muscles, but it has a variety of things that deal with physical exercise and breathing control. The mantra meditation, in particular the is something that the prophets of this meditation, this is a sound that you can, only 3 sounds you can make without using your tongue, and it's very powerful, as the prophets would tell about this chanting, reconciling a lot of stress and anxiety and things that help and make differences in quality of life. There certainly is something that's very easy to do and something that the take-home message here, building on these alternative therapies, cognitive therapy is there and will be much more emergent in functional diseases and increase our armamentarium for therapy. The availability is the one that limits our application. Availability, in one final comment about availability, is the problem with dietitians. When we talk about treatment, we talk about diet very infrequently, and most of us weren't trained in talking about diet, and this is a college guideline, a college survey. 56% showed really no comfort in, or they had been counseled and trained a little bit inadequate in nutritional counseling. Most people said that they didn't ever provide this information, talk about menu planning. The time spent on this is very de minimis, even for those that did do this, but they all recognize that utilization of a dietitian is very, very profoundly impactful. And certainly the access to this would be great if we could expand this, and the effectiveness would really manage the patient better and improve our delivery and maybe save our practice time when we start to deal with these patients. The problem here is lack of access. Take-home message here, dietary advice, I do it in all my patients. It's a key element, spend a little bit of time, but talk about ways we can refer these patients. Availability, again, is a technical limitation for access. So if you have a problem, how do you fix it? Well, look at what's out there. And the one that Dr. Shah mentioned earlier is one that's called GI On Demand. This is a service and something that's provided through the American College of Gastroenterology. It involves multidisciplinary GI expertise. It's an online potential resource for your practice and your patients. Virtual platform, and what does it do? Well, it basically provides web-based referrals for dietitians, genetic counseling, educational programs, GI psychologists, GI subspecialists, information and resources. Go to gi.org, look at this, again, something that we can really expand on deliverables of some of these opportunities. The one that I profiled, the NERVA program, is one of the mainstays of that program, so easy to access. I want to conclude with something that we deal with all the time as far as anticoagulants and antiplatelets. We heard that a lot about that with the portal vein thrombosis discussions. But how does it relate to GI bleeding in the periendoscopic period? This goes to the American College Guidelines. A couple take-home messages: GI bleeding on warfarin. The recommendation, we're talking about patients on Coumadin, is not to use warfarin, not to use the fresh frozen plasma. We certainly don't have any application in the hepatic liver patients. Those patients don't respond to FFP. You may actually aggravate the bleeding if it's from varices. There's no recommendation about prothrombin concentrate, but again, something that if you're dealing with patients on antiplatelet and dual antiplatelet therapy, it's one thing, but single aspirin-related antiplatelet therapy, the recommendation is don't stop it. If they're only on a single agent, like a P2Y12 type, those are things that you have to discuss. I would make the recommendation you never stop these medications without concert in the patients, the doctors that are prescribing these things before you as a gastro go in and start messing with them. The harm potentially is a lot worse, and we can talk about that in the panel session. As far as dual antiplatelet therapy, again, if you can do it on therapy, I think that's even better. I've moved a long way away from stopping these things. Never stop after them. You've got a number of antiplatelet agents. But again, the recommendation here is be very cautious when you stop these. Do it in concert with the prescribing physician. more harm than good, and we can talk about that. Consider maintaining certainly the aspirin for virtually all procedures. And I use more and more cold snare technique and do more and more on even dual antiplatelet therapy, especially in patients at high risk. So concluding here, what I've tried to bring to you in a short period of time is talking about guidelines, what's new. We've profiled some of the ACG recommendations as it comes from the American College presentations and things that are yet to be seen in publication, but we look toward to those peer-reviewed publications. I've profiled also hot topics, looking at new articles, and I've given you perspectives dealing with this for 44 plus years now. And again, I've compiled this with what I think are appropriately take-home messages, things that change my practice approach, and hopefully identifying these as potentially things you can use tomorrow, but also providing you opportunities for improvement. And again, that's really the goal. And the bottom line is get involved. Go to GI.org. The American College is here to work with you, and again, we can do more together. So with that, I'll conclude as ACG Jandana, GI Jandana, Sat Milkar Hum Bahatar, Ko Saktehan. Hey. Together we can be better. Dhanyavad.
You will agree with me that in a short time, Professor David Johnson made a sort of covered most of the topic. We know we are waiting or we are between your dinner and ourselves. We'll try to make it brief but practical. I'll not try to touch on the areas which are theoretical, but we'll go to the practical areas. I thank Professor Mohesh Goenka for giving me this opportunity and SCG for giving me this platform. So, David has discussed several topics. The first one was GERD guidelines. And in that guidelines, I picked up certain things. One is endoscopy negative GERD, and I thought SCG said it is a strong recommendation. That means GERD may be often endoscopy negative. So can I see hands? How often do you see endoscopy negative GERD? Patient comes with heartburn and he has normal endoscopy. So it is very, very common. I tell you, in India it will be commoner than in the West. The reason is in India, PPI is available in the counter. Patient doesn't need a prescription to buy PPI. So, do I request Dr. Rajesh Upadhyay to comment on this?
Yeah, I entirely agree that non-erosive or normal endoscopy in a patient with typical GERD symptoms is very common. But thankfully, the treatment remains the main drug which is used is the PPI. And as Dr. Ghoshal was pointing out, patients often go to the chemist here and buy these drugs on the counter and utilize it on a regular basis. Now there is an immense amount of misuse of these drugs as a consequence of this practice. So we have to ensure that the patients are receiving the right drug at the right time, in the right dose, and for the right period of time.
Okay, so then may I ask Dr. Piyush that let us say we have a patient who has negative, endoscopy is negative, he has heartburn. And another patient in whom endoscopy shows maybe grade B, LAB or LAC erosion. Now in the two group, what is your experience on the PPI response? One, endoscopy negative GERD, other is endoscopy positive GERD.
The endoscopy, obviously the first thing is that NERD is more common than erosive esophagitis, and endoscopy negative reflux disease, they respond poorly to PPIs, and endoscopic patients who show endoscopic lesions, they respond better to PPIs.
So now, if it is so, how will you manage this patient? Will you do a reflux monitoring if somebody is endoscopy negative? he doesn't respond to PPI, will you do a reflux monitoring or will you increase the dose of PPI?
Patients who are endoscopic negative reflux diseases, I think doing a pH monitoring sooner than later may be more useful rather than continuing PPIs in these patients.
Okay, so this is very important. This is what David told us, that PPI response was comparable in LAB and LAC. But PPI response was poor to the tune of about 40% in LAA. The reason is these patients often don't have reflux. They have esophageal hypersensitivity and therefore they need different kind of treatment. So what will be treatment among them? Let us say the patient is on PPI, he is endoscopy negative, you gave PPI, he did not respond. And now what will be treatment in him?
Sir, once we do these pH studies, if the patient shows true reflux, then the best strategy for these patients in long term is using on-demand PPIs, and in one of the studies, what Dr. David showed, that the use of vonoprazan is one potential thing which can be used, and patients who have reflux hypersensitivity or functional heartburn, they might be treated with tricyclic antidepressants, and adding them early might save the long-term use of PPI.
So this is a very important message. If somebody has endoscopy negative GRD, you have given PPI, he doesn't respond, there may not be much point in increasing the dose of PPI. Add a visceral neuromodulator. In fact, we don't call this drug anymore as antidepressant because they work in absence of depression. These are visceral neuromodulator, and as Dr. Piyush said, obviously amitriptyline is a good drug. Now there, I want to ask you, let us say you have to do pH monitoring, impedance monitoring, or both. Which one will you prefer?
So in patients with extraesophageal symptoms, obviously doing an impedance manometry would be better. And where we are going just for reflux testing, patients, especially in preoperative assessment for hiatal hernia surgeries, just simple pH monitoring would be good enough.
Okay, so may I have comment from David that between pH monitoring and pH impedance monitoring, which one do you normally prefer?
Well, let me begin by saying I agree with you 100%. GERD is a clinical diagnosis. I don't need endoscopy to diagnose GERD. I can do that clinically. The reason we do endoscopy is to look for complications, in particular Barrett's, and not so much in your country, but in ours, or evidence that we may be evaluating for alarm features, right, dysphagia or other reasons. That's the reason we do endoscopy. In fact, American College has moved the screening for Barrett's esophagus back to 50 years and require now, or suggest, at least 3 other risk factors to even screen Caucasian males. So we've really moved back the idea of screening or doing endoscopy, even to screening for harm outside of, again, the alarm feature. So GERD is a clinical diagnosis. Second is I 100% agree with the PPIs. I have no concern to speak of about all the allegations of harm. I chaired the International Safety Consensus Conference on this a couple years ago, and all the harm issues are all risk stratified in retrospectively more disease allocation that was biased because the odds ratios are all extremely low, close to 1, maybe to all less than 2. Getting to what do I do with my monitoring, if they're not responding and I think they have reflux, my first response is to double the dose. First, I'm going to ask them when they take it, meal timing for PPI is best taken in the morning, so most of the patients that have nighttime symptoms take at bedtime, because that's when they really recognize their heartburn, although their acid reflux is 4 times greater through the course of the day by standard pH monitoring. Second is if I'm going to monitor or I'm going to measure that, I'm going to basically do them on therapy if I think they have reflux, and now I'm trying to prove that they don't have reflux in their composite symptoms, and I do impedance pH for that particularly.
So that is very important. Remember, pH alone is very, very inferior. In fact, now you do not have this technology in the market. But when you are looking at the data of pH impedance monitoring, give a lot of importance to the impedance data because we have less parietal cell mass. We are often infected with Helicobacter pylori, therefore we do not secrete so much acid as a fellow in US or Europe would do. And therefore, if you rely on pH, you will be often not diagnosing reflux. And if you want data, our paper is going to come in maybe within a month. And that showed pH monitoring could detect only 10% of the reflux. When we added impedance to it, there was an increment by another 50%. So if people have heartburn, 60% had reflux by pH impedance, but only 10% by pH alone. So, yeah, that's right.
One adjunct to that, because if you do just a pH monitoring and just do it for a snapshot with a standard probe, you get 24 hours. If I do pH monitoring, I'm going to do a Bravo, which is a 96-hour potential, and you can increase the likelihood that the episodic reflux will be captured, and hence the diagnosis is better established, rather than taking a snapshot. I do impedance pH when I'm trying to prove it's not reflux disease.
Okay, so there I will make a point again. The Bravo is not supposed to be superior in our country, because we know Bravo can do a prolonged monitoring of 3 days compared to pH with its 24-hour, but our patient can tolerate beyond 24-hour having a catheter in the nose. And second is our problem is low acid, and therefore the Bravo will detect only the acid and not the liquid reflux. So we go to the next. So I'll, before going to the next, you told Dr. Pius that you will give on-demand PPI, but Ronnie first data which David presented is on-demand PPI may not be a great option because PPI takes time to act, and the PPI, we know CYP polymorphism. In the West, 95% will be wild, only 5% will have polymorphism, whereas in our country, look at data from cardiologists, 30% are only wild and 70% have polymorphism. So therefore, the PPI will have different metabolic profile in our country than in the West. Now we go to cap-assisted endoscopic therapy for foreign body and food impaction. So we all know esophageal motility disorder patient may come to you suddenly with severe dysphagia. Now these patients, you suspect that there's an impaction of food or foreign body, and David presented to us data from meta-analysis showing that if you use cap-assisted, 99% was success. If you use conventional, 97% was success. Obviously, the difference was only 2%, but statistically significant because of the huge number. And he showed there was a 4-minute reduction in the time to remove the impaction. Dr. Puri, your comment on this.
What is the exact question?
Question is that we were presented with the meta-analysis which showed that if a patient has impaction of the food or foreign body, now if you use a cap-assisted removal, the cap-assisted removal was more successful, 99%, based on the meta-analysis data. If we use conventional method, it was 97%. So second is time to remove was lesser with cap-assisted. So would you do cap-assisted or would you go with conventional?
See, it depends on the kind of foreign body that you have. So if you have a food bolus that is stuck, I mean, there is unanimously, it is going to be using the cap-assisted. But when you have something like a fish bone or something, even there you need protection. So there'll be very few conditions that you can justify where you're not using a cap.
Okay, no problem. So we go further. We go to the next study that David presented, diet and GERD, and it was a randomized controlled trial where 4 groups were there: high total sugar, high simple sugar, high total sugar, low simple sugar, low total, and high simple, and low both simple and total. Now, what he found is sugar matters. And we know in GERD patient, we really ask them to avoid certain food, particularly the cold drinks, which have sugar added to it. So, Dr. Rajesh Upadhyay, do you want to comment on this, followed by maybe Dr. Ramesh Ruprai, is a very senior person with a lot of experience.
Well, I think this is a very, very useful study, and the findings really are there for clinical usage. because as clinicians, we are spending very little time with the patients explaining about the dietary aspects. We talk about the fried food, we talk about alcohol and smoking, but we are barely talking about the sugar. And what is a little odd to me in this findings of this study is the group, I thought the one which had low simple sugar and a low total carbohydrate should have done the best. But here it was the high carbohydrate total and the low simple sugar. So certainly simple sugar reduction is the most important. But I don't know how to explain that this group of high carbohydrate versus low carbohydrate, there was a difference.
Okay, so Dr. Ruprai, do you have any comment on this study?
I think I agree with Dr. Upadhyay, but the issue is that many patients come to you when they are taking the conventional sugar. They complain of retroesternal burning and the soreness in the mouth also. And I think
5 minutes.
High sugars and low total calories are going to be better tolerated by the patients.
Okay, so we go further. Nalini told me to close. We'll take 5 minutes more just to summarize some of the important clinical points and maybe some comment from the panelists. Now, GRD concept was really there was a paradigm shift. Earlier we thought in patient with GRD have symptom because of the erosion. But David showed to you from 2 studies that it was related not only to erosion, but maybe something more. Like he talked about inflammation by lymphocytes. He spoke about change in the microbiome. We know about a lot about microbiota. Firmicutes are the good bugs, whereas the bacteroids or proteobacteria are bad bugs. And we know that in the gut, it is very, very important. But now he showed that in the esophageal disease also it is very important. And obviously we will like to read his book on esophageal microbiome. Then he spoke on guideline on gastroparesis. And this is very, very important. You know that the gastroparesis is not uncommon, let me tell you. What happens is many of these patients are labeled as functional dyspepsia by gastroenterologist and physician. So gastroparesis is diagnosed by radionuclide gastric emptying for solid. This is very important, solid, not liquid. And he showed that ACG also agrees to that the gastric emptying for solid is important. He also showed endoflip can assess pyloric distensibility as it assesses the ileus distensibility. Only thing is that he showed that Botox doesn't work. So Botox doesn't work based on the randomized controlled trial. So I'll request panelists to give comment if anybody has an experience with Botox therapy for gastroparesis.
Botox we have not used.
Okay.
I was just wanting to tell that the word which we have used, that solid technetium 99 studies, they are not truly representing all the patients of gastroparesis, because almost 25% of patients will be negative for this. And this is in one of our studies we published, we showed that 25% of patients, the technetium 99 studies are normal, but the patients have very severe gastroparesis symptoms. So it is probably the reason that the fundal relaxation is not taking place, and that is not being accounted in the studies of the technetium 99.
Yeah, you're absolutely right, sir. In fact, gastroparesis is a very complex entity. It is related to gastric emptying, it is related to fundic relaxation, and it is related to pyloroduodenal coordination. In fact, fundic relaxation is not assessed by solid gastric emptying. So actually EGG is coming up in a big way. So we don't have time to talk about it. Yes, Dr. Puri, Dr. Rajesh had some point.
I was just wondering, how commonly really in clinical practice are we doing this scintigraphic study for diagnosis of gastric emptying? team. Can we have a show of hands?
Yeah, how many of you, I know there are limited number, how many of you really use solid emptying scintigraphy for diagnosis of gastroparesis? Can I see hands? So not many. So it requires more and more awareness. Patients are there. Then David presented data on doctor visit and FGID. This is from our Rome Global Epidemiology study. And he showed that functional gastrointestinal disorder is a common reason for doctor consultation, even in the community. Therefore, gastroenterologists have to be more aware about this disorder. And as we can see from the hands, that there are hardly anybody who is even maybe being aware of gastroparesis. And then lastly, I'll take 2 or 3 more minutes because obviously Nalini said that we have to shorten the discussion. The virtual reality is very, very important. So virtual reality's method of caring remotely, and obviously David presented several papers on using virtual reality and also cognitive behavior therapy and other kind of mindfulness meditation and other kind of psychological therapies in patients with functional gastrointestinal disorder, which we now called as disorder of gut-brain interaction. Dr. Ramesh Ruprai, do you have any comment on this?
I totally agree that this is a gut-brain interaction disorder. So we have to take good history of the patient and also spend time with the patient to explain him what this virtual thing, this is not going to come up to clinical practice very fast. So we have to spend time, explain the gut motility, explain him why his symptoms are coming, why he is perceiving more of the symptoms. Even if it is a normal stimuli, he is perceiving it higher. So we have to teach him with time taken and explain him all these points, all those points which has been taken care by the virtual reality. I think that is a very important point which is going to come up. But till then, all of us have to understand that we have to be patient with the patient, listening his complaints and explaining him all the symptoms.
So, yeah, it is very important comment that you have made. In fact, a study published from Australia that is known as Mantra study showed that a group of IBS patients where they were randomized to therapy given by psychologists, gastroenterologists, counselor and dietitian. Another group received only gastroenterologist delivered therapy, and obviously the people who were treated with gastroenterologist, psychologist, counselor and dietitian actually did much better. So the way to care for this patient is multimodal approach taking psychologist, dietitian together, and the multiple studies presented by David actually proved that. So we have to all accept currently these patients are not being cared for adequately. Maybe we are evolving with time, and maybe this floor will help us to have more and more GI trained psychologists and GI trained dietitian in the country working with the gastroenterologist to make the life of these patients better. So finally, I know
Can I take 1 minute?
Yeah, yeah.
Just wanted to tell you that this abdominal wall pain, which sir has rightly pointed out at this point, in India, most of the people lift the weight with one hand and they have the abdominal wall teared. And whenever they have pain, abdomen, they come to the gastroenterologist. As the Carnet sign has been mentioned, in 94 we published this article that abdominal wall pain is a very common problem and how to elicit is very important. If you do not raise the leg of the patient and make him understand that the pain disappears, what we used to do, why we do it, that we put the thumb on the abdomen and at one particular point the patient cries. And this we labeled as cry sign, and if that is there, we say that this patient is having abdominal wall pain. And he has rightly pointed out.
Yeah, so that highlights the importance of clinical examination. Unfortunately, the history taking and clinical examination is becoming a dying art in the medicine today. which is obviously bad. Much of the information you get by the history and physical examination, up to 80%, and the remaining 20% you get by investigation. We know now anybody having abdominal pain actually is labeled as functional GI disorder, and given a PPI, it is so unfortunate and so much disservice to the patient. This is what Dr. Ramesh Ruprai has highlighted. I would be going on this further and further because this is an area in which I work. I like to discuss this area more to make people aware, but unfortunately because of shortage of time, we can't go on. So I'll again thank Dr. David for presenting such extensively important abstract from SCG, and also I thank all the panelists for discussing and all the audience. If there is any audience question, we'll take up at the end because I have 34 seconds left. Any audience question? I'm sorry I did not give you opportunity because of shortage of time. No question. They are all tired and they want to take food. Thank you. Thank you so much.
So I think they want to take a picture with. Thanks, everyone. I know it has been a long day. It's the end of the day, and I think I don't think you care about the food but I think there are some drinks at the end of the room, so I think that's what is stopping you from going there is me. So I'd like to thank my co-faculty members, Dr. Nancy Rowe, Manesa Shami, Samir Shah, and David Johnson for all the hospitality, for us being here. This concludes our 3-day journey of 3 different cities, and we had the fortune of meeting several of our friends and colleagues from all these 3 cities. I'd like to thank Lupin. My special shout out goes to Payal, who despite getting married about 2 days back, she was actually texting us, making sure we are doing okay when she was getting married. So that's beyond the call of duty. She's not here. She came and went away. And then we have Amitava and Aditi. There she are. Please raise your hands. Please give them a round of applause. They have been phenomenal in helping us and coordinating it. And Dr. Goenka and I thank all the moderators and the panel members and all of you for being here and making this program work the way it is supposed to. Thanks again. And I guess Mr. Sachdeva, Amitava, can the faculty please come up on the stage, please? Dr. Ghoshal, you ended the note very profoundly, but by saying we're not doing enough clinical exam and history taking. So. Jai? Yes, please come on the stage. So as a token of thanks, the Lupin executives would like to felicitate you. Wait, Amitabh. Who better than you come? It's okay. They're the important people.